are a vital component of pediatric and public health care, allowing for the prevention of disease through immunizations and anticipatory guidance, and early detection of existing individual health issues that require further follow-up. The schedule starts shortly after birth with the first well child examination conducted at 3 to 5 days of age. The first 36 months of life is a time of rapid growth and development, and children should be closely monitored with a series of regularly scheduled visits at gradually increasing intervals, from every 2 months to every 6 months. From the age of 3 years, children are assessed annually. Important components of the well child checkup include age-specific screening recommendations, history taking and physical examination, growth and development assessment, including developmental milestones, administering immunizations, and proactive anticipatory guidance for children. WA.FO 5. Overview. Schedule 2-3. Neonatal visits 3 to 5 days after birth or another visit by 1 month of age, typically at 2 weeks or 1 month. Sent during the first 3 years, at 2, 4, 6, 9, 12, 15, 18, 24, and 30 months of age 3 years and older, annual visits. Approach. Perform the following at every well child visit. Review the child's past medical history, including any active medical issues. Copyright results of pediatric screening questionnaires, example developmental surveillance, risk assessments, copyright vital signs and growth charts. Sent. Perform a thorough review of systems and physical examination. Recommend and discuss age-appropriate, copyright immunizations according to the ACIP schedule. Copyright pediatric screening studies. Copyright pediatric anticipatory guidance. Arrange the following. Further evaluation for abnormal findings, example studies, treatment, follow-up. Copyright the next well child visit appointment. Sent for children equals 11 years of age, see also adolescent health care. Copyright a sports physical, or pre-participation examination, involves additional history and physical examination components. 4. Overview of visits by age 31. The following tables are an outline of the recommended content of well child checks for healthy children with no additional risk factors identified. If additional risk factors are identified at any point, example risk factors for pediatric hypertension, risk factors for lead toxicity in children, more frequent screenings, example at every visit, may be required. Copyright screen children once between birth and 21 years of age for risk factors for hepatitis B, and if risk factors are present, send HPV serology, even if the child has been vaccinated. Infancy. Overview of recommendations for infants by age I3 RDEDing, at visit assess for abnormal pediatric growth. Asterisk check immunization status and offer recommended immunizations / catch-up immunizations as appropriate, see ACIP schedule. Asterisk perform a physical examination. Asterisk screen for all ages degree behavioral, social, and emotional disorders degree risk factors for pediatric hearing loss. Copyright risk factors for pediatric vision loss. Copyright risk factors for pediatric hypertension. Asterisk perform developmental surveillance, with developmental screening using a validated tool if there are any concerns. 3 to 5 days. Asterisk ensure assessment of the newborn and newborn screening has been completed, follow up abnormal results. Repeat newborn screen if required by state law. By 1 month. Asterisk screen for risk factors for tuberculosis. Screen the mother for postpartum depression. Equals QL. Collapse fine text outline. EEEEEEESSSEE sent screen the mother for postpartum depression. 2 months. Asterisk give recommended immunizations, see well child visit immunizations. Sent screen for risk factors for pediatric iron deficiency anemia. 4 months. Asterisk screen the mother for postpartum depression. Asterisk give recommended immunizations, see well child visit immunizations. Asterisk screen for degree risk factors for pediatric lead toxicity, degree risk factors for tuberculosis, 6 months copyright risk factors for dental caries. Asterisk screen the mother for postpartum depression. Asterisk give recommended immunizations, see well child visit immunizations. Cent consider application of fluoride varnish. Asterisk perform developmental screening using a validated screening tool. 9 months Cent screen for risk factors for pediatric lead toxicity and risk factors for dental caries. Asterisk consider application of fluoride varnish. Asterisk obtain a hemoglobin level to screen for anemia, see pediatric screening studies. Asterisk screen for 7DMN copyright risk factors for pediatric lead toxicity and consider checking serum/capillary lead level, see pediatric screening studies. Month 7 degrees risk factors for tuberculosis, give recommended immunizations, see well child visit immunizations. Consider application of fluoride varnish. Copyright screen children for risk factors for dental caries once at 6 months and at 9 months. If the child does not have an established dentist by the recommended age of 12 months, continue to assess for risk factors and the need for fluoride varnish through 6 years of age. 3. Toddlers and preschool children. Overview of data for children by age 3 are at visit. Assess for abnormal pediatric growth. Perform a physical examination. Screen for degree behavioral, social, and emotional disorders. Copyright risk factors for pediatric hearing loss. Copyright risk factors for pediatric vision loss. All ages. Copyright risk factors for pediatric hypertension. Degree risk factors for pediatric iron deficiency anemia. Perform developmental surveillance, with developmental screening using a validated tool if there are any concerns. Check immunization status and offer recommended immunizations/catch-up immunizations as appropriate, see ACIP schedule. For children with no dentist, degree screen for risk factors for dental caries. Copyright consider application of fluoride varnish. 15 months Cent no additional age-specific screenings recommended. Cent perform developmental screening using a validated screening tool. Asterisk screen for 18 months degree autism spectrum disorder. Copyright risk factors for pediatric lead toxicity. Screen for autism spectrum disorder. 24 months degree risk factors for pediatric dyslipidemia. Copyright risk factors for tuberculosis. Consider a capillary/serum lead level, see pediatric screening studies. 30 months perform developmental screening using a validated screening tool. Perform pediatric vision screen. Screen for 3 years. Copyright risk factors for pediatric lead toxicity. Degree risk factors for tuberculosis. Start annual screening for pediatric hypertension. Perform pediatric vision screen and pediatric hearing screen. Screen for copyright risk factors for pediatric lead toxicity. Degree risk factors for tuberculosis. Copyright risk factors for pediatric dyslipidemia. 4 years. Perform annual screening for pediatric hypertension. School-aged children and adolescents. Overview of recommendations for school-aged children by age 3G, at visit. Plus assess for abnormal pediatric growth. Equals AQO. Collapse fine text outline. X well child visits. School-aged children and adolescents. Overview of recommendations for school-aged children by age 3 SCR9G. At visit assess for abnormal pediatric growth. Perform a physical examination. Perform developmental surveillance, with developmental screening using a validated tool if there are any concerns. Screen for all ages. Copyright behavioral, social, and emotional disorders. Copyright hypertension, see pediatric hypertension screening. Copyright risk factors for pediatric iron deficiency anemia. Degree risk factors for tuberculosis. Check immunization status and offer recommended immunizations/catch-up immunizations as appropriate, see ACIP schedule. Perform Copyright Pediatric Vision Screen. Copyright Pediatric Hearing Screen. 5 years Scent Screen for risk factors for pediatric lead toxicity. For children with no dental home, copyright screen for risk factors for dental caries. Copyright consider application of fluoride varnish. Perform, copyright Pediatric Vision Screen. Copyright Pediatric Hearing Screen. Screen for 6 years. Copyright risk factors for pediatric lead toxicity. Copyright risk factors for pediatric dyslipidemia for children with no dental home, degree screen for risk factors for dental caries. Copyright consider application of fluoride varnish. 7 years *, no additional age-specific screenings recommended. Scent perform, a copyright Pediatric Vision Screen. Ears U copyright Pediatric Hearing Screen * screen for risk factors for pediatric dyslipidemia. 9 years * obtain a lipid panel once between 9 to 11 years of age, see pediatric screening studies. * perform, copyright Pediatric Vision Screen. Pediatric Hearing Screen. 10 years copyright screening for pediatric hypertension. Copyright girls only, screening for scoliosis. 5 * obtain a lipid panel once between 9 to 11 years of age, see pediatric screening studies. 211 years * see adolescent healthcare. FO. Growth. Approach L7. Scent obtain all indicated growth parameters at each visit. Plot measurements on a gender-specific growth chart. Scent calculate the midparental height in order to 9. Determine the expected adult height based on genetic potential. 10 compare current growth percentiles to the expected growth percentiles. Scent track growth over time to identify pediatric growth patterns. QL. Collapse. Find text outline. AE pediatric growth patterns, 71. Scent normal pediatric growth. E proportionate growth parameters. O growth parameters that follow closely to a percentile curve, mil 9L. OE expected height within 2 standard deviations, i.e., 10 centimeters or 4 inches, of the midparental height. A, 9E abnormal pediatric growth. O values that deviate 2 standard deviations from the mean, i.e. 97% percentiles. 1 copyright crossing equals 2 major percentile lines on the growth curve. 7 copyright deviating 10 centimeters, 4 inches, from the midparental height. 1 degree copyright disproportionate parameters, 1. To help identify abnormal growth patterns, compare the child's growth parameter percentiles to their expected adult height, i.e., midparental height. Holtz. Children. Growth parameters, 7. Pediatric growth parameters, ILO, indications and method. Expected trends. Abnormal growth. A. Infants and children. Infants grow 24 cm/year, 10 in/year, in the first year of life. Length increases 30% by 5 months and 50% by 2 SDS above the mean. Tall stature and abnormally rapid growth. Linear growth. 7. Newborns lose weight and regain it by 2 weeks of age. Copyright breastfed infants may lose up to 10% of birth weight. 17 below the mean, failure to thrive. Weigh infants in only a diaper. 1 copyright formula-fed infants may lose up to 7% of birth. ERD SIB, 2 SDS above the mean, only significant when weight for age measurement. Older children I may be weight-eyed in clothes. 1 weight-eyed. 18 Ornpers WNTSTR growth parameters. C1 infants gain 25 to 30 g/day for the first 3 months of life. 41 birth weight doubles by 4 months, triples by 1 year, and quadruples by 2 years of age. 91,119. A percentile change may occur at 2 years of age. FF21 2 SDS above the mean, obesity. Weight for length or 2 years, BMI for age, 20. Screening. Routine screening allows early detection and early treatment of common healthcare problems. This section includes recommendations from the American Academy of Pediatrics, AAP, and the U.S. Preventative Services Task Force, USPSF. Sent for additional recommendations, example sexual health screening, substance use, in older children, see adolescent health care. RORDN. S. Physical exam screening. Sent see also pediatric growth for recommendations on monitoring height and weight. D. 2322 Pediatric physical exam screening. Conditions to screen recommended ages method of screening equals QL. Collapse fine text outline. S. Physical exam screening. Sent see also pediatric growth for recommendations on monitoring height and weight. Pediatric physical examining, 2LSI 22. Conditions to screen recommended ages method of screening. As neonate, see newborn hearing screen. Annually degree between 4 to 6 years. Copyright any patient with risk factors for pediatric hearing loss, example history of torch infection, meningitis, head trauma, recurrent or persistent otitis media, family history of childhood pediatric hearing. Screening 2124125 hearing loss, or NICU stay for 5 days, * pure tone audiometry, if abnormal, consider tympanometry. 1 * at 8 and 10 years of age * once between copyright 11 to 14 years, copyright 15 to 17 years, copyright 18 to 21 years. Instrument-based, photoscreeners and autorefractors, which * 1 to 3 years of age, if instrument-based screening is available, estimate refractive error and detect risk factors for amblyopia. Pediatric vision FIBO screening 22127, I28 I29. Starting at 3 years of age at regularly scheduled intervals I29-28 annually for children with risk factors for pediatric vision loss. Visual acuity testing. Visual inspection and the atom forward bend test. Use of scoliometer, if available, to determine degree of scoliosis. Scoliosis 534-35 5 * girls, at 10 years and 12 years of age. Boys, once between 13 to 14 years of age. At every visit, if risk factors for hypertension in children are present. Sent annually from age 3 years old for children without risk factors. In-office blood pressure measurement 38 I5 hypertension. See also screening for hypertension in children. Vision screening identifies conditions, example cataracts, strabismus, in infants equals 4 months of age, amblyopia, that require interventions to prevent permanent vision loss. During a fundoscopic evaluation, the absence of a red reflex and / or the presence of leukocoria requires urgent ophthalmology referral and further evaluation. 39. Copyright hearing loss can be mistaken for other conditions. Always perform a pediatric hearing screening in children with communication disorders, neurodevelopmental disorders, and behavioral problems. 401L41. Red Noteman Accent and History and Examination. History 22. Review the patient's medical and family history. Sent perform a pediatric review of systems, including a copyright constitutional symptoms, example changes in weight, fevers, copyright sleep-related concerns, example deficient sleep, night terrors, napping, snoring, copyright dietary concerns, example picky eating, unhealthy eating habits, eating disorders, copyright elimination disorders, example daytime continence, encapricis, nocturnal enuresis, constipation in children, copyright menstrual cycles, example menarche, menstrual cycle abnormalities, copyright school-related concerns, example ADHD symptoms, learning disorders, academic problems. Behavioral concerns, example temper tantrums, anxiety, depression. Sent see Pediatrics, History and Physical Examination for more information. Physical Examination 22. Perform a thorough physical examination, including age-specific examinations. See Pediatrics, History and Physical Examination for further information. Age-specific fascination in age-recommended evaluation possible findings. Verify that, copyright a full assessment of the newborn was performed. Copyright newborn screening has been completed. Neonatal, **C clinically relevant neonatal conditions. Take appropriate actions for abnormal results. Repeat newborn screen at 1 to 2 weeks if required by state law. Perform a full physical examination. Cranial sutures and fontanelles musculoskeletal conditions plus eyes, red reflex with Bruckner test, all ages, Hirschberg test, if 6 copyright abnormal head shape, example craniosynostosis, positional plagiocephaly, months of age, 33 copyright developmental dysplasia of the hip, DDH, brachial and femoral pulses, 53, St. Eve conditions equals QAL. Collapse fine text outline. Age-specific FISI in age-recommended evaluation possible findings. Verify that, copyright a full assessment of the newborn was performed. Copyright newborn screening has been completed. UNS 77 neonatal. *C clinically relevant neonatal conditions. Take appropriate actions for abnormal results. Repeat newborn screen at 1 to 2 weeks if required by state law. Perform a full physical examination. Cranial sutures and fontanelles musculoskeletal conditions plus eyes, red reflex with Bruckner test, all ages, Hirschberg test, if 2-6 copyright abnormal head shape, example craniosynostosis, positional plagiocephaly, months of age, 33-degree developmental dysplasia of the hip, DDH, brachial and femoral pulses 1-3 St. Eye conditions infants 7-5, eye musculoskeletal, Barlow maneuver and Ortolani maneuver until 6 copyright strabismus, abnormal after 4 months of age, C250 4 months of age Fook OE. Neuro, tone and normal resolution of primitive reflexes Sukcone *GU examination, check for testicular descent. SENT-GU, cryptorchidism ES55 any change to skin lesions SENT skin, cradle cap dermatitis. Strabismus eyes, same as for infants and, if 3 years of age, cover tests 33 umbilical hernia C54 St. brachial and femoral pulses A, 53 St. labial adhesions toddlers and P-Hool aged musculoskeletal St. pediatric lower extremity disorders children copyright standing and gait evaluation copyright evaluation for DDH, Galeazzi test, leg length abdomen, examine for masses and persistent umbilical hernia. Genivalgum, Genivarum copyright femoral retroversion copyright intowing of the foot secondary to metatarsus adductus tibial torsion or femoral anteversion. Delayed or advanced pubertal development, see puberty. Pubertal gynecomastia varicocele or phimosis scoliosis. Very similar to the physical examination in adults pubertal development, Tanner stages school-aged children and adolescents. Normal pediatric vital signs vary greatly by age. OS. OE. Anticipatory guidance. Anticipatory guidance involves proactive counseling for expected age-appropriate topics, example safety, healthy lifestyles, nutrition, and dental care. See also anticipatory guidance for pediatric development. Illness management. Give examples of when to, copyright go to the emergency room, example signs of respiratory distress, clinical features of dehydration, red flags for pediatric fever copyright schedule an appointment in the clinic, copyright call the clinic or send a message through a patient portal for advice discuss fever management. Copyright in children. Child Safety 571 I-581 I-22. Safe sleeping, provide counseling on sudden infant death syndrome, see also prevention of SIDS. 59 Second-hand smoke, advise caregivers on the risks of second-hand smoke and offer assistance with smoking cessation. Plus child passenger safety, children. Copyright laws regarding minimum safety requirements for car safety seats vary between states. Copyright: the AAP recommends using car safety seats in the following order: advance to the next seat once the child reaches seat limits, a rear-facing with harness, starting at birth until at least 2 years of age, one forward-facing with harness, convertible or dedicated forward seat, 1 equals booster seat. Copyright: lap and shoulder seat belts can be used once they fit correctly. CA supervision. Copyright supervision must be provided by a responsible adult who is awake and not under the influence of alcohol or other substances. A. 63, copyright 3 to 5 years, continuous supervision is necessary, copyright 41. Copyright 6 to 8 years, supervision is necessary near bodies of water or during risky activities, example climbing. 65, scent abuse prevention, teach verbal children, example 3 years of age, how to recognize, respond to, and report inappropriate interactions. Street and recreational safety, copyright instruct children to wear protective gear when engaging in activities with an increased risk of injury, example cycling, skateboarding. Copyright teach children road safety. E-water safety, encourage LTP preventive strategies. Q collapse fine text. O. Outline. Scent water safety, encourage multiple preventive strategies. Copyright do not leave children unattended near bodies of water. O. Consider survival swim lessons at an early age. Copyright a self-locking fence should be installed around pools. Scent child-proofing the house. Copyright potentially harmful household products, medications, and tools should be kept out of reach. O. Set water heaters to 120 degrees Fahrenheit 49 degrees Celsius maximum temperature. Copyright firearms should be locked out of reach of children, unloaded with ammunition stored separately. Copyright anchoring furniture to walls can prevent accidental crush injuries. Scent fire safety, install smoke alarms and formulate a family escape plan. Lifestyle 22 IL 66. Plus pacifier use 671 I 59. Copyright consider delaying pacifier use until breastfeeding has been well established. Copyright to assist in prevention of SIDS, encourage pacifier use during sleep in infants 1 to 6 months of age. Copyright limit pacifiers after 6 months of age to reduce the risk of otitis media. Copyright discontinue pacifiers at 2 to 4 years of age to prevent adverse dental effects, example dental malocclusion. Scent behavior and discipline. Copyright discuss age-appropriate behaviors to manage parent expectations. Encourage consistency, positive reinforcement, and age-appropriate discipline. Copyright for persistent behavioral problems, example temper tantrums, aggression, recommend evidence-based parenting programs. Plus toilet training, copyright 8. Copyright initiation, at 2.5 to 3 years of age, when children are developmentally mature enough to begin toilet training. 69. Use positive reinforcement. Copyright completion, typically by 4 years of age plus screen time, 1. 64 LL 22 IL 66. Copyright children aged. Scent physical exercise, ensure at least 60 minutes of daily physical activity. Personal hygiene, establish good hygiene habits, including hand hygiene, respiratory hygiene, regular bathing. In adolescence, this should also include the use of deodorant. Counseling on sexual activity, smoking, alcohol, and drug use, see adolescent health care. Copyright do not attach pacifiers to sleeping infants or to items that present a suffocation risk, example stuffed animals. 59. Nutrition 711, 721, 1221. A healthy diet is essential for normal growth and development and helps prevent a variety of metabolic and other conditions, such as obesity and type 2 diabetes mellitus. Scent infant feeding, see also infant nutrition. Copyright encourage exclusive breastfeeding for the first 6 months. 221 older children degree once eating solid foods. A healthy diet consists of 13 equals 3 meals and 2 snacks per day * caloric intake appropriate for the child's age and level of activity. 1 equals fruits, vegetables, legumes, beans, grains, preferably whole grain, protein foods, and dairy. Limited saturated fats, salt, and sugar. Copyright for children on specialized diets. Example for medical indications: vegetarians, vegans. Consider referral to a dietitian to ensure proper dietary intake of macronutrients and micronutrients. 75. Picky eating, 7 cent 1 cent definition. Copyright the refusal to eat certain foods, try new foods, or eat sufficient amounts of food. AQL. Collapse. Fine text outline. Well child visits. Nutrition 7111721I22. A healthy diet is essential for normal growth and development and helps prevent a variety of metabolic and other conditions, such as obesity and type 2 diabetes mellitus. Sent infant feeding, see also infant nutrition. Copyright encourage exclusive breastfeeding for the first 6 months. 22 cent older children. Copyright once eating solid foods. A healthy diet consists of 5 equals 3 meals and 2 snacks per day equals caloric intake appropriate for the child's age and level of activity. 1 fruits, vegetables, legumes, beans, grains, preferably whole grain, protein foods, and dairy. Limited saturated fats, salt, and sugar. Copyright for children on specialized diets. Example for medical indications: vegetarians, vegans. Consider referral to a dietitian to ensure proper dietary intake of macronutrients and micronutrients. 75. Picky eating, 76. Sent definition. Copyright the refusal to eat certain foods, try new foods, or eat sufficient amounts of food. Copyright often associated with an excessive preference for certain foods. Sent red flags in picky eating that merit further evaluation include degree vomiting, diarrhea, or atopy. Example eczema. Copyright dysphagia may manifest with coughing, choking, or recurrent lower respiratory tract infections. Copyright odynophagia may manifest with crying while eating. Failure to thrive, developmental delay management. Depends on the severity of the condition. Normal growth with no red flags. Diagnostic studies are not indicated. Reassure parents and encourage them to continue offering a wide variety of foods. Copyright poor growth and / or red flags in picky eating. Perform a detailed history, including screening for eating disorders. Obtain diagnostic studies as indicated. Consider caloric supplementation. If indicated, make appropriate referral. Encourage caregivers to offer a variety of foods without pressuring children to eat. Dental care and caries prevention, 771I78. Sent general care. Before tooth eruption, wipe gums with a clean cloth after meals. Copyright after tooth eruption. Brush teeth twice a day with fluoridated toothpaste. Floss daily between teeth that touch. Copyright encourage dental visits every 6 months beginning with tooth eruption or at 12 months, whichever is first. Plus additional fluoride. 771. After tooth eruption, consider applying fluoride varnish every 3 to 6 months. 7 / copyright consider fluoride supplementation in those who drink fluoride deficient water. Oral health concerns. Sent teething, the physiological process by which an infant's deciduous teeth emerge through the gums. Copyright usually begins with the lower central incisors between 6 and 10 months of age and ends with the molars at 2 to 3 years of age. 82. Manifestations fluctuate with the eruption of teeth and include drooling, irritability, disrupted sleep, and / or swelling / inflammation of the gums. Copyright providing infants with a chilled teething ring to chew on safely or applying pressure to the baby's gum using clean fingers or wet gauze can reduce discomfort. Copyright systemic analgesics, example acetaminophen, ibuprofen, are reserved for teething pain not effectively managed with conservative interventions. Copyright advise parents against using topical numbing treatments due to the risk of adverse effects, example methemoglobinemia. 83. Scent dental malocclusion, discourage non-nutritive sucking habits, including thumb sucking and pacifier use, beyond 3 years of age. 4. OS. CE. Tin and Linba equals QAL. Collapse fine text outline. Well child visits, 1/12. Birth to 24 months, girl's name length for age and weight for age percentiles record hashtag GGG9G birth 369 12 15 18 21 24 41 in cmm in 39 100 age, months, 1007 plus 38 387 EL 374 9 equals 81 to 374. J plus 498 AE 4A5 as SFEAKOE EAH. 337 E2 SES. 257 XSEE 32 equals 80 BZZI equals 184.407 PETS PZCS or C7, 30-7. ZSOE 47 to 38 plus 294 EE Saint Ho. Minus 28, underscore 39 Assis Tat 36 to 4. And 277 EWCBAA ASA MMA 15. Team SYZ Assad, 30 to 4 A5 UALZZD 23 UI, GI 6130 L524 IT R3Q04W. 2154 7 equals A equals AL. 20 to 4 PEALSOI 54 124 561 H-19/BS equals 2S equals T. EEAG at A11 plus 24 M74 AE equals dash 16 dash plus 40 equals 10 plus 22 dash 4, 15 FES at 107 LAAI equals on a ST9 205. R plus 8. TWAAIOEE 8. 18 AAEAEAF if as EL. 14 UZI equals EKGIBL slash Y law 22's age, months, 2E12 to 46 WA 9 12 15 18 21 24. 1 EKAVE mother's stature underscore gestational G minus 10 to 4 YY, father's stature age, weeks comment HL4 VA date age weight length head CIRCTE 87 VP birth. 6 AY. 2 IBKG. Birth 36. Length and weight for age percentiles for age, girls 0 to 24 months, VV. This image is an adaptation. Source of original image, Centers for Disease Control and Prevention. Original title, birth to 24 months, girls length for age and weight for age percentiles. Created by, Centers for Disease Control and Prevention. Licensed under public domain. Modifications to original image, CDC logo removed by request. Well child visits, 2/12. Birth to 24 months, boy's name length for age and weight for age percentiles record hashtag. Birth 369 12 15 18 21 24 41 Lin CM in L underscore 39 to 1100 age, months, 139. IL 38 to 4 387 euros SRA equals 98 I 37 plus 36 to 4 L 957 4 3674 1 to 90 T equals 0 90 plus T plus 35 Sats are 354 44 A 50 34 to 4 EO 10 327 to 55 IEs XESA equals 184,407 CE. 30 to 155 VES. ZLES Jesse 17 plus. 387 minus 29 to 4a 22 e 2 z equals 28 to 176 ZAR and ZA7 CON plus 274 ZZ equals M7 FO6 LE sorries AE. H plus 244 MEZ, 95 P32 2354 7 EEE sealed by P22 plus 214 SSYFAEG equals ETZIIEL, 1. 2050 FO, RAL PR1 121 26H-19 equals S T18 to 4 AIOE 45 at equals 28 MTR 24 to 417's number 25 plus 164 40 bzs 2 SSCS sends 510 plus 22 plus equals LF way SA as equals O equals E plus 20 equals Y of SE E G184 R16 3 Yo A EOS Ket R16 to 4 W6YH months SSWIC 9 12 15 18 21 24 SS plus mothers stature gestational G-10 YY fathers stature OH weeks comment H date age weight length head circ R4 yen 4 if birth LG equals V 2 IBKG birth 36 length and weight for age percentiles for age, boys 0 to 24 months, VV. This image is an adaptation. Source of original image, Centers for Disease Control and Prevention. Original title, birth to 24 months, boys length for age and weight for age percentiles. Created by, Centers for Disease Control and Prevention. Licensed under public domain. Modifications to original image, CDC logo removed by request. Well child visits, 3/12. Birth to 24 months, girl's head circumference for age and name weight for length percentiles record hashtag. Birth 3 6 9 12 15 18 21 24 _ in _ cmm lin _ 4 age, months, E equals A 52 52. Plus 20 20 to 50, 98 equals F50. H plus dash 19 dash _ 48 SS equals 48,194 cents F equals 755, SRES equals SOUD 46 EE equals ESOE 25 to 46 4 EESSSES POAETS IOC 44 SLES, equals AA add R. IA Leary equals 174. And 42 WGAB2 SOSUEEF 24 to 1524 copyright. MP 167140 VAG ISJ 234 to 594 FMLALS OE/-22- +4G. E 15 to 38 Hlilold CLZ 21-46-44, LLL 98// N 36 WIM equals GES/O/20 plus 447 EE 11, EP 19 plus A 2. E34 JAC by 18 to 1407 13 La Ya 572 MLOE plus 32 GAT SLL 5A 164 degree 42 to 1 AZZ 151 30A 442 Pace SZ Erie 3552783 ST IA ZT 12-1 Zeke IE 12-plus-264 AG plus 22-plus-10 NSGA 10-plus-224 T plus 20-4 plus 9 Yale 9 plus 20 plus AIE equals Lee SAG 18 W 18 to 7 YLMAAZ 716 E 41 Voila 5147 LEZAI sent, dot comma underscore pound underscore Z, a CRHB4 length KGLBTAIA equals Z 64 66 68 70 72 74 76 7880 82 84 86 88 90 92 94 90. This image is an adaptation. Well, child visit. Birth 3. A 40. 1 plus 32 pay. Microcephaly VV. The head circumference of this newborn infant is more than 2 standard deviations below the mean size for age and sex. Consistent with congenital microcephaly. Source, Fig 1, in, Microcephaly by Hans Licky, Giganti J, Children, licensed under CC by 4.0. Facial features of Fragile X syndrome. Macrocephaly and large earlobes. Source, file frax2.jpg by Peter Saxon, Wikimedia Commons, licensed under CC by SA 4.0. Modifications, eyes pixelated. Using the correct car seat or booster seat can be a lifesaver. Make sure your child is always buckled in an age and size appropriate car seat or booster seat. €1 2 3 4 5 6 7 8 9 10 1 12 plus ET 111. Rear facing. CLUS. Car seat forward facing car seat booster seat. Age by years asterisk. Birth until age 2 to 4 after outgrowing rear-facing car after outgrowing when seat belt fits properly buckle children in a rear-facing car seat with a seat and until at least age 5 forward-facing car seat and without a booster seat harness until they reach the maximum weight or when children outgrow their rear-facing car until seat belt fits properly children no longer need to use a booster seat height limit of their car seat. Keep children's seat. They should be buckled in a when children outgrow their forward-facing when the seat belt fits them properly. A seat belt rear-facing as long as possible. Never place a forward-facing car seat with a harness until car seat. They should be buckled in a booster fits properly when the lap belt is across the upper rear-facing car seat in the front seat. Front they reach the maximum weight or height limit seat until the seat belt fits properly without a thighs, not the stomach, and the shoulder belt is. Passenger airbags can injure or kill young children of their car seat. Booster seat. Proper seat belt fit usually across the center of the shoulder and chest, not in a crash, occurs when children are age 9 to 12. On the neck/face or off the shoulder. Keep children age 12 and younger properly buckled in the back seat. Recommended age ranges for each seat type vary to account for differences in child growth and weight/height limits of car seats and booster seats. Use the car seat or booster seat manual to check for important information about installation, the seat weight and height limits, and proper seat use. Child Safety American Academy of Pediatrics, AAP, 2018. Child Passenger Safety VV. This image is an adaptation. Source of original image, CDC. Original title, Child Car Seat Booster. Created by, American Academy of Pediatrics, CDC. Licensed under public domain. Modifications to original image, cropped away CDC link plus label. X vaccination. Vaccination is a very effective measure for providing immunity to many infectious diseases. The discovery of vaccines played a central part in the eradication of smallpox and helped significantly reduce the incidence of potentially severe diseases such as poliomyelitis and measles. Live vaccines, attenuated, i.e. non-infective pathogens, inactivated vaccines, subunits or complete pathogens, viral vector vaccines, and nucleic acid vaccines, DNA, RNA, mRNA, or viral replace icons, are used to achieve active immunization, which enables the host's immune system to build up a sustained immune response to specific pathogens. The immune response may be measured and quantified by assessing the antibody titer. In the event of potential disease, example after exposure to high-risk pathogens, if the immune system is unable to produce sufficient antibodies fast enough, passive immunization can offer immediate short-term protection via direct injection of pooled antibodies for many conditions. Modern vaccines are usually well tolerated, and adverse events are rare. However, the intervals between vaccine administration and possible contraindications must be considered. For ACIP vaccination recommendations, see immunization schedule. OS. Definition. Scent vaccine OEA product, example dead or weakened organism, that provides immunity from a disease O may be administered through injection, orally, or nasally. Scent vaccination, administration of a vaccine that induces an active immune reaction in form of cellular and/or humoral response, providing immunity against a pathogen. Scent immunization. Copyright the process by which a person becomes protected from a disease. Copyright vaccines and recovering from some infections cause immunization. References L. OS. OXO. Aims of routine immunization. Scent herd immunity. Copyright. Once a certain percentage of the population has received immunization, non-vaccinated individuals, example children too young to receive vaccination, will also be protected. O mass vaccination, vaccination of a large number of people in the shortest possible time after the outbreak of an epidemic, with the goal of herd immunity. Scent eradication of disease. Copyright. High immunization rates over prolonged periods of time can achieve eradication of certain diseases. 2. Copyright. To date, only 2 diseases have been eradicated by human efforts: smallpox, 1980, and rinderpest, 2011. Scent lower incidence and associated risks. The Haemophilus influenza type B, HIB, vaccine has decreased the number of cases of invasive HIB disease, example pneumonia, bacteremia, meningitis, epiglottitis, infectious arthritis, in children younger than 5 by more than 99%. 3. WA. OCE. Passive immunization. Scent mechanism of action. Copyright. Injection of preformed antibodies induces a rapid humoral response against a specific pathogen. O provides only temporary protection, as antibodies have a half-life of 3 weeks and their titers decrease over time. E. Examples: O antitoxins, O humanized monoclonal antibodies, O maternal immunoglobulins that are transmitted via breast milk, IgA, or cross the placenta, IgG, to provide passive immunity. Copyright. Intravenous immunoglobulins to provide temporary passive immunity to a specific pathogen, example CMV, *. Indications: O acute, post-exposure elimination of a pathogen. Viruses, rubella, rabies, hepatitis B equals toxins, tetanus, botulinum, diphtheria. O rhesus incompatibility prevention. Scent application. Vaccines are available for intramuscular as well as for intravenous injection. 1. Scent combination. O simultaneous vaccination equals 2 different passive vaccines may be administered simultaneously. Back collapse. Fine text outline. Scent combination. Copyright. Simultaneous vaccination. 2 different passive vaccines may be administered simultaneously. An inactivated active and a passive vaccine may be administered simultaneously, example in acute hepatitis A, hepatitis B, rabies, or tetanus infection. 4. O after transfusion of certain blood products and/or immunoglobulin therapy, live vaccines should be delayed depending on the estimated amount of IgG in the transfusion. 1. SLEL. And passive immunization helps beat the disease rapidly. HPV, botulinum, tetanus, diphtheria, and rabies are indications for passive immunization. 4.7. OBETS. Active immunization. Scent general information. Copyright. In active immunity, the body's immune system reacts to the presence of antigens by producing antibodies. Copyright in general, a combination of different active vaccinations is possible. 1. Copyright slow onset, but immunity usually lasts for years or even a lifetime. Copyright besides vaccines and toxoids, natural infections lead to active immunization as well. Asterisk classification copyright live attenuated vaccines O inactivated vaccines equals whole vaccines equals subunit vaccines equals protein-based, subunit and toxoid vaccines, equals polysaccharide-based copyright viral vector vaccines copyright nucleic acid vaccines, DNA, RNA, mRNA, or viral replace icons. Current vaccination recommendations for the U.S. can be found in the immunization schedule. 7 CE ES live attenuated vaccines. Scent definition, modified functioning virus or bacterium that can replicate in the patient's body but does not cause disease. Scent mechanism of action copyright similar to an infection with a wild pathogen and induces a cellular and humoral immune response. Copyright specific B cells against an antigen are formed, which induces a potent, lifelong immune response. Scent administration copyright oral vaccine or subcutaneous/intramuscular injection in children 12 months copyright not indicated in children. Copyright varicella, against varicella zoster virus, VZV. Copyright zoster, prevents reactivation of latent VZV, i.e., shingles. Copyright yellow fever copyright rotavirus copyright influenza, intranasal, O smallpox adenovirus oral polio, Sabin, no longer available in the U.S., A degree BCG1 copyright typhoid, oral, Ty 21A, scent special considerations. Degree. O very rarely, live attenuated vaccines may become virulent again and are thus often contraindicated in immunodeficient individuals and pregnant women. Copyright HIV-positive individuals can be vaccinated with live attenuated vaccines, example MMR and varicella, if their CD4 cell count is 200 cells/mm degree. Copyright adenovirus vaccine is given in its non-attenuated form to military recruits. Back collapse fine text outline. Tyler and Paul burnt their infamous roasted yellow ruby chicken meat very much. Typhoid, adenovirus, polio, BCG, influenza, rotavirus, yellow fever, rubella, CHICKEN pox, measles, varicella, and mumps are live attenuated vaccines. References. 7 IL. WA. OE. Lee inactivated vaccines. Characteristics. Available vaccines. Mechanism of action. Special considerations. Administration. Whole vaccines. Whole inactivated or dead pathogens, using chemicals or heat, that are unable to replicate surface epitopes remain unchanged, since they are important for triggering an adequate immune response. Cause a weaker immune response, but are considered to be safer than live vaccines. Polio, Salk, inactivated vaccine, hepatitis A, rabies, typhoid, 6 polysaccharide, IM, influenza pertussis, cellular vaccine, cholera, Japanese encephalitis, tick-borne encephalitis. Mostly humoral immune response. Overview of inactivated vaccines. Inactive antigenic subunits of pathogens that provoke the most effective immune. IBSPONI weaker immune response and more expensive but lower risk of adverse reactions. Subunit degree hepatitis B, using the HBsAg. Degree influenza. Degree pertussis, acellular vaccine, HPV, specifically types 6, 11, 16, and 18, anthrax. Degree. Number of circulating antibodies decreases over time. Less affected by circulating antibodies than live vaccines. Subunit vaccines. Protein-based. Scent toxoids are bacterial toxins in which the toxicity has been inactivated while immunogenicity is maintained through intact receptor binding sites. Scent immune system reacts to exposure with production of antibodies against bacterial toxins. Protective immunization. Asterisk toxoid vaccine. Degree diphtheria, C. diphtheria, copyright tetanus, Clostridium tetani. Usually injected into the deltoid muscle, alternatively, example in infants, injected into the vastus lateralis muscle. First dose does not provide protective immunity. Multiple doses required. Periodic boosts necessary to ensure sufficiently high antibody titers. Inactivated vaccines may generally be combined with other vaccines without any time interval in between. Polysaccharide-based. Bacterial cell wall polysaccharide equals ROA is linked to a protein. HIB, conjugate vaccine, 1 pneumococcal vaccine copyright PCV13, conjugate vaccine, copyright PPSV23, unconjugated vaccine. Meningococcal vaccine, conjugate vaccine, various strains of Neisseria meningitidis, Salmonella typhi. Polysaccharides induce a relative T-cell independent B-cell response and therefore achieve sufficient immunization only in adults and older children. In conjugate vaccines, the carrier protein activates T-cells, which stimulate a more rapid and long-lasting immune response, especially in infants and toddlers. Not consistently immunogenic in infants. And beware of hepatitis A on your trip. Hepatitis A, typhoid fever, rabies, influenza, and poliomyelitis. References 91L101. G. RO, XO. Lee viral vector vaccines. Scent definition, an unrelated virus, example adenovirus, vesicular stomatitis virus, influenza virus, is modified to be used as a non-pathogenic vector that delivers genetic code to cells containing instructions for the production of the desired antigen. 11. Asterisk mechanism of action. There are two types of viral vector vaccines, replicating and non-replicating. Non-replicating vector vaccines enter the cells and induce the production of vaccine antigens, but cannot produce new viral particles. Replicating vector vaccines enter the cells, inducing the production of new viral particles. New viral particles go on to infect other host cells, leading to the production of further viral and vaccine antigens. Back collapse. Find text. A. Outline. New viral particles go on to infect other host cells, leading to the production of further viral and vaccine antigens. Copyright induce both humoral and cellular immune responses. Scent administration, usually injected intramuscularly, but can also be administered intranasally, intradermally, and orally. Scent available vaccines. Ebola virus vaccine, RVSV-Zbov, Ervbo, 1 copyright COVID-19 vaccine, Janssen COVID-19 vaccine, Vaxzevria, Sputnik V vaccine. Scent special considerations. Copyright pre-existing. Immunity to the virus that serves as the vector may affect the effectiveness of a vaccine. 12. Copyright less strict storage and handling conditions than nucleic acid vaccines. Viral vectors are genetically stable and lack a viral genome and non-structural proteins. Therefore, they do not interact or integrate into the host's DNA and are non-pathogenic. WA. A5. Lee nucleic acid vaccines. RNA vaccines, 131I14. Scent definition, a vaccine based on mRNA that delivers genetic code containing instructions for the production of the desired antigen to cells. Mechanism of action. Copyright 2 types of mRNA vaccines, non-replicating and self-amplifying. Non-replicating mRNA vaccines contain the sequence of the desired antigen and the 5 and 3 untranslated regions. Self-amplifying mRNA vaccines contain the sequence of the desired antigen and the viral replication machinery, example RNA polymerase, that Enables intracellular RNA amplification. Both types induce humoral as well as cellular immune responses. Scent administration. Copyright injected intramuscularly or intradermally. Require multiple doses. Available vaccines, COVID-19 vaccines, example Comirnaty, Spikevax, contain modified mRNA embedded in lipid nanoparticles that encodes for the spike protein mRNA sequence of SARS-CoV-2, Scent special considerations. mRNA is a non-integrating platform that is degraded by normal cellular processes. Due to its transitory nature, mRNA does not interact or integrate into the DNA, and bears no risk of insertional mutagenesis. Example COVID-19 vaccines are safe to use during pregnancy. Copyright There is no potential risk of infection as mRNA is non-pathogenic. Require strict cold chain. Copyright Different techniques can be used to deliver the vaccine, example injection of naked mRNA or encapsulated within nanoparticles or polyplex. DNA vaccines, 15. Scent definition. A specific antigen-coding DNA sequence is introduced using a genetically engineered plasmid to induce endogenous antigen production in the host. Scent mechanism of action. After entering the cells, the vaccine antigen is expressed from the DNA construct. Copyright induce both humoral and cellular immune responses. Scent administration. Copyright intramuscularly or intradermally. Require multiple doses. Scent available vaccines. No DNA vaccines have been approved for human use in the United States. Scent special considerations. Copyright potential advantages observed in animal models are improved vaccine stability and the use of non-pathogenic agents. Copyright in order to properly deliver the vaccine and ensure cellular uptake, injection needs to be followed by electroporation. D. Vaccine administration. Back collapse. Fine text outline. Vaccine administration. Vaccinations. A equals WA Re XO. Adverse effects of vaccination. Common adverse effects, 16-171 I-18. Effects 130 usually begin within the first 48 to 72 hours after administration and last 1 to 2 days. Symptoms. Copyright local swelling, redness, and pain at the injection site. Low-grade fever, post-vaccination fever, co-headaches. Fatigue. Copyright flu-like symptoms. Live attenuated vaccine, can cause mild form of the disease, usually appearing within 1 to 3 weeks of administration. Usually caused by replication of the attenuated vaccine strain. Rare adverse effects, 16-171 I-18. Scent. Cardiovascular complications, observed in young men who received mRNA vaccines, COVID-19 vaccines, Hg. Copyright pericarditis. Myocarditis. Myocardial ischemia. Serious allergic reaction, generally. There is no link between autism and vaccines or their ingredients. 2021. VA. Contraindications for vaccination. Precautions. Scent. General precautions. A precaution is a condition in the recipient that might increase the risk for serious adverse reactions or interfere with the vaccine's ability to produce immunity. Copyright. Generally, vaccination should be deferred when a precaution is present, except when the benefits of protection outweigh the risks. Acute, moderate or severe illness, with or without fever, scent. Special precautions. Copyright rotavirus vaccine, uncorrected GL tract malformation, example Meckel's diverticulum. Copyright egg protein containing vaccines, allergic reactions other than urticaria, example angioedema, bronchospasm, to egg products. Pertussis vaccine, progressive or unstable neurologic disorders, example uncontrolled epilepsy, infantile spasms, progressive encephalopathy. 22. Copyright tetanus toxoid containing vaccines equals development of Guillain-Barré syndrome within 6 weeks of a previous dose. Arthus reaction after a previous dose. 22. Contraindications. 23. Sent general contraindications. Vaccines are generally contraindicated in recipients with conditions that increase the risk for severe vaccine reactions or in whom the vaccine may exacerbate the condition. Previous severe adverse reactions, example anaphylaxis. Severe adverse reactions to a vaccine component, example egg protein in yellow fever vaccine, yeast in hepatitis B vaccine. Sent contraindications to live degree rotavirus vaccine equals severe combined immunodeficiency, SCID, history of intussusception, 24. Back collapse. Find text outline. SSESEEE copyright pertussis vaccines, risk of encephalopathy, example prolonged seizures, decreased level of consciousness, coma, within 7 days following a previous dose. Copyright live, attenuated virus vaccinations 221. Equals pregnant individuals equals immunodeficient individuals, example individuals receiving chemotherapy or long-term immunosuppressive therapy, individuals with congenital immunodeficiencies, patients with HIV and severe immunocompromise, individuals receiving IVIG therapy, example for Kawasaki disease, 1. Sent false contraindications, 25-26, fever within 48 hours. Copyright current or recent mild illness, example rhinorrhea, otitis media, mild diarrhea. Copyright current or recent antibiotic therapy, exception is oral live typhoid vaccine. Copyright current or recent low-dose and/or short-term steroid use, i.e. All children should be immunized with the standard doses of vaccines according to their chronological age. Doses should not be adjusted to weight or height. OS and special patient groups. Immunizations during pregnancy, vaccinations in preterm infants, and vaccinations in individuals with HIV are detailed in the immunization schedule article. Pathogens affecting unvaccinated children. Affecting eye and undereye disease. Clinical features. Treatment. Prodromal catarrhal phase degree, high, fever. Copyright colic spots degree coryza, cough, conjunctivitis. Exanthem phase. Copyright, high, fever, malaise degree. Symptomatic treatment. Measles virus. Measles LBS plus vitamin A supplementation degree. Erythematous, maculopapular, blanching, partially confluent plus post-exposure prophylaxis. See prevention in measles. Exanthem equals begins behind the ears along the hairline, disseminates to the rest of the body toward the feet, palm and sole. Involvement is rare. Transformation into brown discoloration and desquamation can occur in severely affected areas. Prodromal phase degree. Low-grade fever, malaise, sore throat, conjunctivitis, cough degree. Postauricular and suboccipital lymphatic. Exanthem phase, symptomatic treatment. Rubella virus. Rubella II degree. A degree. Fine, non-confluent, pink, maculopapular. Exanthem plus C. Treatment in rubella. Begins on the head, typically behind the ears. Extends to the trunk and extremities, sparing the palms and soles. Copyright polyarthritis. Prodromal phase, low-grade fever, malaise. Exanthem phase. Symptomatic treatment. Varicella zoster virus plus chickenpox. Hundreds of severely pruritic lesions in varying stages of development, example papules, vesicles, and S-degree lesions. First manifest centrally, i.e., on the face, scalp, and trunk, and spread to the extremities. Antiviral therapy for high-risk patients. Acyclovir, valacyclovir. C. Treatment for chickenpox. Prodromal phase, fever, malaise. Classic course. Copyright inflammation of the salivary glands. Symptomatic treatment. Mumps virus. Mumps equals most commonly parotitis. C. Treatment in mumps. Usually unilateral degree. Possible orchitis. See complications in mumps. Back collapse. Find text outline. Varicella zoster virus equals chickenpox. Mumps virus. Mumps. Corynebacterium, diphtheria. B. phoenix. Epiglottitis. Haemophilus influenza type B. Streptococcus pneumoniae * bacterial meningitis. Neisseria meningitidis. Viral meningitis eolovirus plus poliomyelitis. Clostridium tetani tetanus. Bordetella pertussis. Hepatitis A virus * hepatitis A. Hepatitis B virus * hepatitis B. WA. OE. Related 1-minute telegram. Prodromal phase, low-grade fever, malaise exanthem phase E. Hundreds of severely pruritic lesions in varying stages of development, example icicles, and DP, copyright lesions first manifest centrally, i.e., on the face, scalp, and trunk, and spread to the extremities. Prodromal phase, fever, malaise classic course copyright inflammation of the salivary glands. Equals most commonly parotitis equals usually unilateral. Degree possible orchitis, see complications in mumps. Respiratory diphtheria degree rehit D over the posterior pharyngeal wall and / or tonsils cervical lymphadenopathy and nuchal soft tissue swelling, bull neck, foul smelling breath difficulty breathing, inspiratory stridor. Degree cutaneous diphtheria. High fever sore throat dysphagia and odynophagia drooling muffled voice, hot potato voice, respiratory distress, tripod position. Sore throat, pharyngitis. Sinusitis, pharyngitis. Myalgia possibly petechial or purpuric rash possibly Waterhouse classic triad, fever, headache, and neck stiffness photophobia Friedrichsen syndrome nausea, vomiting malaise scent gastroenteritis altered mental status, seizures plus sore throat * myalgia * ASY flaccid paralysis. Copyright most commonly affects the leg muscles usually more severe in proximal muscles. Painful muscle spasms and rigidity degree trismus, rhesus sardonicus, opisthotonus degree possibly laryngospasm / respiratory muscle spasms, autonomic dysfunction, example circulatory arrest. Prodromal catarrhal phase, URTI symptoms paroxysmal stage degree PPY, often occurring at night, copyright followed by a deep, loud inhalation or high-pitched whooping sound vomiting, smiley face. Convalescent stage, cough may persist for several weeks. Right upper quadrant pain, tender hepatomegaly fever, malaise anorexia, nausea, vomiting jaundice, pruritus. Symptomatic treatment antiviral therapy for high-risk patients see treatment for chickenpox. Acyclovir, valacyclovir. Symptomatic treatment see treatment in mumps. Isolation precautions airway support antibiotic therapy, penicillin G or erythromycin diphtheria antitoxin see treatment in diphtheria. Airway management in epiglottitis empiric LV antibiotics copyright third generation cephalosporin, such as cefotaxime or ceftriaxone O or beta-lactam with a beta-lactamase inhibitor, such as ampicillin/sulbactam or amoxicillin/clavulanate consider adjunctive therapy with steroids, dexamethasone or methylprednisolone. See treatment for epiglottitis. Isolation precautions obtain CSF studies and begin empiric antibiotic therapy for bacterial meningitis. Tailor antimicrobial therapy once the pathogen has been identified. For H. influenza type B and S pneumoniae, adjuvant dexamethasone for H. influenza type B and N meningitis, give contacts PHs for 2C management and treatment in meningitis. PHY. Mechanical ventilation in patients with respiratory failure supportive treatment see treatment in polio. Airway support wound cleaning and debridement antibiotic treatment, metronidazole or penicillin G active and passive immunization, see tetanus prophylaxis, supportive treatment see treatment in tetanus. Supportive treatment oxygen administration with humidification antibiotic treatment, macrolides such as azithromycin, clarithromycin, or erythromycin see treatment in pertussis. Supportive treatment consider antiviral therapy for chronic hepatitis B. Copyright nucleoside analogs or nucleotide analogs, example tenofovir, entecavir, opeg-IFNA. See treatment in hepatitis A and management of hepatitis B infection. Sent 1-minute telegram 9-2020-1/3, SARS-CoV-2 vaccine candidate shows promising results in phase 1-2 trial. Interested in the newest medical research, distilled down to just 1 minute? Sign up for the 1-minute telegram in tips and links below. Back. PE collapse. A. Find text. O. Outline. Euro vaccination, 1/3. Traditional vaccines virus genetic vaccines particle. Inactivated vaccines nucleic acid vaccines. Live attenuated whole cell subunit vaccines vaccines DNA vaccines RNA vaccines viral vector vaccines. ARVNQOFO, B. Whole virus recombinant mRNA in lipid recombinant attenuated virus inactivated virus subunits plasmid membrane viral vector. Vaccine types VV. This diagram illustrates vaccine types based on the example of antiviral vaccines. Traditional vaccines are either live attenuated or inactivated. Live attenuated vaccines contain modified whole virus particles capable of replication, but not of causing disease. Inactivated vaccines contain either the whole inactivated virus particles or their subunits. Gene-based vaccines contain only the genetic information of the pathogen. This information, which is transmitted either directly in the form of nucleic acid, DNA in a recombinant plasmid or mRNA in a lipid envelope, or by means of a recombinant viral vector, induces endogenous antigen production in the host cells. Copyright Boss. Euro vaccination, 2/3. Exploratory preclinical research studies. 4 to 6 years. Standard vaccine development. Phase clinical trials phase 2. 5 to 8 years 10 to 15 years. Regulatory approval phase 3. 41 to 2 years. Manufacturing of 1 to 2 years. In standard vaccine development, individual study phases, exploratory, preclinical, and clinical phases, are performed sequentially. The application for regulatory approval, in the US to the FDA, is submitted on the basis of the complete study data after the clinical trials are finished. Manufacturing begins only once approval has been granted. Copyright Boss. Painpinaknanyi exploratory/preclinical SY clinical trials phase. Clinical trials phase 2. Clinical trials phase 3. A 2-re, smiley face, regulatory rolling review/approval. Manufacturing. 12 to 24 months. Accelerated vaccine development during the SARS-CoV-2 pandemic VV. Vaccine development during the SARS-CoV-2 pandemic was substantially accelerated through the following measures: 1. Overlapping study phases. 2. Accelerated regulatory approval through rolling review, i.e., the submission of preliminary data to the authorities while clinical trials were still ongoing. 3. Manufacturing start prior to completion of clinical trials and regulatory approval. Copyright Boss. Vaccination, 1/1. AE4 IET equals to TTPS4. AEEEA___ epidermis. Dermis. Dash subcutaneous tissue. AES_A. AIES NES AE muscle equals T equals E hour equals _A/J intramuscular injection subcutaneous injection. Comparison of intramuscular, IM, and subcutaneous, SC, injection VV. For IM injection, the needle is inserted at 90 degrees to the skin to ensure the medication is delivered directly into muscle tissue. Muscles commonly used include the deltoid and vastus lateralis. For SC injection, the needle is inserted at a 45 degrees angle to deliver the medication into the subcutaneous tissue. Sites for injection should have sufficient subcutaneous tissue and no bony prominences, major nerves, or large blood vessels, example the dorsal upper arm. Choice of technique depends on the medication to be administered and the desired speed of effect. Muscle tissue has greater vascularization than subcutaneous tissue, therefore, medications usually act more quickly if given IM rather than SC. Copyright Boss. AA4. Spike protein exocytosis, spike protein endocytosis. Spike protein SA dendritic cell anines, spike protein fragments processing vector DNA enters nucleus. MHC. Mechanism of action of viral vector-based COVID-19 vaccines VV. The vector-based COVID-19 vaccines are based on various recombinant adenoviruses, example the chimpanzee adenovirus in AZD1222 by AstraZeneca, or the human adenovirus type 26 in AD26.cov2.s by Janssen. The recombinant DNA of the vector virus codes for the spike protein of SARS-CoV-2, which is synthesized by the host cell. The spike protein is then either processed and presented via MHCI molecules or exocytosed. Exocytosed spike proteins are taken up by phagocytes, especially dendritic cells in muscle, and presented via MHC2 molecules. Presentation of the spike protein fragments via MHC- and MHC2 leads to the development of a specific immune response against the spike protein. Copyright Boss. A. E0 degree. E. GS asterisk and A. 8JE8 spike protein end. EE 500 degree. AIAY. mRNA vaccine enters the cell. Equals MHC2. Dendritic cell mRNA translation JS and spike protein synthesis, spike protein processing, spike protein fragments. MHC. Mechanism of action of mRNA-based COVID-19 vaccines VV. The mRNA-based COVID-19 vaccines contain mRNA coding for the spike protein of the SARS-CoV-2 virus. To increase stability and enhance uptake into cells, the mRNA strands are encapsulated in lipid nanoparticles. Within the cell, the mRNA causes transient, local expression of the spike protein, which is then either processed and presented via MHCI molecules or exocytosed. Exocytosed spike proteins are taken up by phagocytes, especially dendritic cells in the muscle, and presented via MHC2 molecules. Presentation of the spike protein fragments via MHCI and MHC2 leads to the development of a specific immune response against the spike protein. Copyright Boss. X immunization schedule. Vaccinations are one of the most effective methods of disease prevention, drastically reducing illness, hospitalizations, and deaths from infectious diseases. In order to prevent a resurgence of vaccine-preventable illnesses in the U.S., the Centers for Disease Control and Prevention, CDC, and Advisory Committee on Immunization Practices, ACIP, publish yearly immunization schedule recommendations. These schedules are formulated based on extensive research and aim to protect individuals at the age at which they have the highest risk for infection. Specific recommendations are available for the general population, children and adults, individuals with certain health conditions, and those traveling to areas with high rates of infection. Education on the importance of vaccination and the implementation of catch-up schedules for under-immunized individuals are vital to ensuring herd immunity and preventing infectious diseases. WAOES. General Principles. Routine Immunization 213. Scent immunizations are a vital component of primary prevention. See pathogens affecting unvaccinated individuals. Scent follow the recommended ACIP immunization schedules. Age-appropriate vaccines should be administered at the same visit when feasible. See simultaneous vaccination and combination vaccines. Plus be aware of contraindications for each vaccine. 41% identify individuals with risk factors and/or medical indications that necessitate altered immunization schedules. EOC immunization schedule by medical indication. Copyright. See the Special Patient Groups section. Educate individuals on the disease that each vaccine aims to prevent and the possible adverse effects. Vaccine dose is not adjusted for weight but may vary based on age. Vaccinations against multiple diseases at the same visit. 13. Simultaneous vaccination. Administration of one vaccine on the same day, but in different syringes and at different anatomical locations. Sent may include a combination of inactivated vaccines, live attenuated vaccines, or immunoglobulins A. Sent. Most vaccines can be administered simultaneously. Exceptions include OPCV13 and PPSV23, do not administer simultaneously. EOPCV13 and Menacquad, do not administer simultaneously in individuals with HIV or asplenia. Combination vaccines. Combination of different vaccine components in a single product. One, timing and spacing of vaccines. Delayed or missed vaccines, under vaccination, 1271I2. Sent. Follow recommended catch-up immunization schedules for under-vaccinated individuals. Sent. Do not restart the immunization series from the beginning. Sent. Continue with the next dose in the immunization series. EA equals vaccines administered before the recommended minimum age or interval. 3. In general, any vaccine administered equals 5 days earlier than the minimum age or interval is considered invalid and needs to be repeated. V. Back collapse. Find text outline. In general, any vaccine administered equals 5 days earlier than the minimum age or interval is considered invalid and needs to be repeated. Copyright. Doses administered. VA on. OE ed NE. ACIP immunization schedule. This table provides an overview of the ACIP immunization schedule. See the latest CDC recommendations for detailed guidance. OMC. Also special patient groups, travel vaccines, and contraindications for vaccination as needed. Copyright. For catch-up vaccines, continue with the next dose in the immunization series. Do not restart the immunization series from the beginning. Hepatitis B vaccine, Hep B vaccine. DIP-IA, pertussis vaccine, DTaP. Tetanus, diphtheria, and acellular pertussis vaccines. Tetanus, diphtheria, acellular pertussis vaccine, Tdap, and tetanus, diphtheria vaccine, TD. P. IPV. Rotavirus vaccine, RV. Back. Overview of ACIP immunization schedule. T71L2. All infants, 3 doses. Copyright. Dose 1, monovalent Hep B, equals birth weight equals 2 kilograms, within 24 hours after birth. Birth weight. Copyright. Dose 2, 1 to 2 months of age. Copyright. Dose 3, 6 to 18 months of age. All infants, 4 doses, DTaP primary series. Copyright. Dose 1, 2 months of age. Copyright. Dose 2, 4 months of age. Copyright. Dose 3, 6 months of age. Copyright. Dose 4, 15 to 18 months of age. Boosters. Copyright. 1 dose at 4 to 6 years of age. Copyright. Proceed to Tdap boosters after 11 to 12 years of age. 1 dose Tdap at 11 to 12 years of age, 1, followed by 1 dose Tdap or TD every 10 years. All infants, 3 doses, primary IPV series. Copyright. Dose 1, 2 months of age. Copyright. Dose 2, 4 months of age. Copyright. Dose 3, 6 to 18 months of age. Booster dose, 1 dose at 4 to 6 years of age. All infants, 2 or 3 doses, varies by vaccine, J dose 1, 2 months of age, F dose 2, 4 months of age, dose 3, for the 3-dose vaccine only 6 months of degree. Age. All infants, 2 or 3 doses, HIB primary series varies by vaccine, A. Copyright dose 1: 2 months of age. Copyright dose 2, 4 months of age. Copyright dose 3, 6 months of age, for all series except PedVax HIB, booster, 1 dose at 12 to 15 months of age. A collapse. Catch-up immunization schedule and by children. If individuals equal 7 years of age with copyright incomplete DTaP series, 1 dose of Tdap, followed by either Tdap or Td for subsequent doses as needed. IMA, a 7, copyright complete DTaP series, with incomplete Tdap, 1 dose of Tdap, then Tdap or Td boosters every 10 years. Children. Complete primary series, 1 lifetime booster of IPV. Incomplete primary series, complete the degree 3-dose primary IPV series. Unvaccinated adults, 3-dose primary IPV series. Degree. Age. Children. Q. Find text. Special considerations. Infants born to individuals with HBsAg positive or unknown status require additional management. Individuals with indications for HPV post-vaccination serology require additional dose, S, if anti-HBs. Minimum age for the first dose. Copyright DTaP, 6 weeks. Copyright DTaP IPV, 1, 4 years. Copyright Tdap, 7 years. 5 Copyright Td, 7 years. Ensure close contacts of newborns have received all the recommended age-appropriate pertussis vaccines, DTaP, Tdap. JC. Also copyright prevention of tetanus. Copyright prevention of pertussis. Copyright prevention of diphtheria. Minimum age for the first dose. Copyright IPV, 6 weeks. Copyright DTaP IPV, 1, 4 years. Oral polio vaccines are not used in the US. 8171. Minimum age for the first dose, 6 weeks. Maximum age for the first dose, 14 weeks. 6 days. Maximum age for final dose, 8 months. Minimum age for the first dose, 6 weeks. Individuals with risk factors for severe Haemophilus influenza type B disease may need 1 or 3 additional booster doses, depending on the risk factor. A. Outline. Children. Pneumococcal 13 valent conjugate vaccine, PCV13, * or pneumococcal 15 valent conjugate vaccine, PCV15. Children, FO. Pneumococcal vaccines. Adults. Degree pneumococcal 15 valent conjugate vaccine, PCV15 adults, and pneumococcal 23 valent polysaccharide vaccine, PPSV23, or pneumococcal 20 valent conjugate vaccine, PCV20. HEPA. Rubella or measles, mumps, rubella, varicella vaccine, MMRV. MMR. Varicella vaccine, VAR. * Children. All infants, 3 doses, primary series with PCV13 or PCV15. Copyright dose 1: 2 months of age. Copyright dose 2, 4 months of age. Copyright dose 3, 6 months of age. Booster, PCV13 or PCV15, 1 dose at 12 to 15 months of age. Pneumococcal disease may require additional doses, including a dose of PPSV23. A conjugate vaccine, PCV, and a polysaccharide vaccine, PPSV23, cannot be given at the same visit. M7 copyright. If both are indicated, administer the conjugate vaccine first. Adults equals 65 years of age with complete childhood primary series 2112 I13. Adults equals 65 years of age with incomplete childhood primary series, 2, F12 copyright 1 dose of PCV 20 copyright or 1 dose of PCV 15 and, equals 1 year later, 1 dose of PPSV 23 1. Individuals equals 19 years of age with risk factors for invasive pneumococcal disease with copyright prior PCV 13 only, at any age 1 dose of PCV 20 or PPSV 23 equals 1 year after last dose prior PPSV 23 only, at any age 1 dose of PCV 20 or PCV 15 equals 1 year after last degree. Dose F. PRA copyright prior PPSV 23 at age, 1 dose of PCV 20 or PPSV 23 equals 5 years after last dose J. Children. All children, 2 doses copyright dose 1, between 12 and 23 months of age copyright dose 2, equals 6 months apart. Under-vaccinated children and adolescents, 2 doses A, adults with no evidence of immunity to measles, mumps, or rubella. All children, 2 doses dose 1, 12 to 15 months of age, MMR preferred over MMPV, 161. Dose 2, 4 to 6 years of age. Degree. Copyright not at increased risk of infection, 1 dose. Degree copyright 8 increased risk of infection, 1, 2 doses, 2 4 weeks apart. All children, 2 doses dose 1, 12 to 15 months of age, VAR preferred over MMR / 1 dose 2, 4 to 6 years of age. Degree. Adults and children with no evidence of immunity to varicella, 2 doses, J, 971 I2. Degree. Individuals 15 years of age at initial dose, 3 dose years of age degree series at 0, 1 to 2 months, and 6 months copyright dose 2, 6 months after adults 27 to 45 years of age, use shared decision making. Immunocompromised individuals, use a 3-dose series regardless of age at first dose. 13 to 15 years of age, 2 doses copyright dose 1, 13 to 15 years of age copyright dose 2, at equals 16 years of age and 8 weeks after dose 1. 16 to 18 years of age, 1 dose individuals with risk factors for invasive, 15-16. All children, 2 doses. Copyright dose 1, 11 to 12 years of age A, degree dose 2, 16 years of age meningococcal disease copyright children, minimum age for the first dose varies by vaccine used and indication E adults with complete childhood series, further to 3-dose series, varies by vaccine, Individuals 16 to 23 years of age without risk factors for invasive meningococcal doses. Human papil 9-valent INE, HPV INE. Dose 1. Men ACWY vaccines. Meningococcal vaccines. MANI 1B INE, Men B disease. Vaccine. Pentavalent meningococcal INE, Men ABCWY INE, 17. Back. EU's shared decision making. Degree 2 doses, 1 to 6 months apart, varies by vaccine, A. Consider for individuals 10 to 25 years of age in whom both meningitis ACWY and meningitis B vaccination are indicated at the same visit. V equals Q. Collapse fine text. Sent minimum age for the first dose. Copyright PCV 13 and PCV 15, 6 weeks degree PPSV 23, 2 years. Plus a conjugate vaccine, PCV, and a polysaccharide vaccine, PPSV 23, cannot. Be given at the same visit. 17. If both are indicated, administer the conjugate vaccine first. Minimum age for single antigen HEPA vaccine, 2-dose series 12 months 17. Minimum age for combined HEPA and Hep B vaccine, 3-dose series equals 18 years. Minimum age for the first dose, 12 months, for routine vaccination, maximum age for MMRV, 12 years. Consider contraindications for live vaccines. During community mumps outbreaks, an additional dose may be required. 14. Minimum age for the first dose, 12 months, maximum age MMRV, 12 years. Consider contraindications for live vaccines. Minimum age for the first dose, 9 years. History of sexual abuse, administer dose 1 at 9 years of age. Men ACWY vaccines are interchangeable. 16. Men B vaccines are not interchangeable. Kane. Received FDA approval in October 2023, indications may change. Outline. Zoster recombinant vaccine, RZV, adults only. Influenza vaccine 9. Pfizer-BioNTech COVID-19 vaccine. COVID-19 vaccines 24. Moderna COVID-19 vaccine. Novavax COVID-19 vaccine. Dengue vaccine, 1261. Respiratory syncytial virus vaccine, 28. Adults 50 years of age, 2 doses, 2 to 6 months apart. IMA individuals 19 years of age with current or anticipated immunocompromise EA 2 doses, 2 to 6 months apart. 18. All individuals 6 months of age, 1 dose annually during flu season, unless there are contraindications, 1 individuals traveling to areas with influenza activity. 20 children aged 6 months 8 years who received primary series, monovalent 2 or 3 doses. Degree 6 months 4 years of age, 3 doses equals dose 2, 3 to 8 weeks after dose 1 equals dose 3, 8 weeks after dose 2. Copyright 25 years of age, 2 doses, 3 to 8 weeks apart. Primary series, monovalent, copyright 26 months of age, 2 doses, 4 8 weeks apart. Primary series, monovalent, copyright 212 years of age, 2 doses, 3 to 8 weeks apart. Indicated in children 9 to 16 years of age who, reside in a dengue endemic region a degree and have laboratory evidence of previous dengue infection, i.e., 27, equals a prior infection with a positive dengue test, equals or a positive pre-vaccination screening test. 3-dose series, 0, 6, and 12 months. Consider in individuals equals 60 years of age with adult risk factors for severe RSV infection, use shared decision making. Minimum age for the first dose, 19 years. Minimum age for the first dose. Copyright inactivated vaccine, 6 months. Copyright live attenuated vaccine, 2 years. Copyright recombinant influenza vaccine, 18 years. Individuals 6 months 64 years, administer any age approved vaccine. Adults to 65 years, high dose or adjuvanted vaccines are preferred. 1. 21. See contraindications and precautions for influenza vaccines. For those with severe egg allergy, example angioedema, respiratory distress, vaccinate in a monitored setting. 22-23. See also prevention in influenza. Do not mix vaccines for the primary series. The booster dose can be from a different manufacturer than the primary series. Minimum age for the booster. Copyright Moderna 2 5 years. Copyright Pfizer, equals 6 years. Booster series, 1 dose, 2 months after any primary series or last booster. Recommendations differ for IMRA and PRD Individ ALS, refer to the latest CDC recommendations. 25. Minimum age for the first dose, 9 years. The dengue vaccine is not required for children visiting dengue endemic regions. Young children and older adults are at increased risk of severe RSV infection. RSV prophylaxis is indicated for, copyright Alan Fonts. Copyright unapproved delayed or alternate immunization schedules put individuals at risk for vaccine-preventable conditions and complications. Copyright monitored setting. 22I23 egg allergy is not a contraindication for influenza vaccination. For those with a severe reaction, example angioedema, respiratory distress, administer the vaccine in a special patient groups. Plus adjustments to the routine immunization schedule are needed for certain indications. 29I80 An overview of recommendations for vaccinating preterm infants, pregnant individuals, and those with HIV infection is detailed in this section. See immunization schedule by medical indication and the latest CDC recommendations for adjustments in copyright patients with any of the following. Altered immunocompetence, example those with HIV, AIDS, asplenia, complement deficiencies. 31 End-stage renal disease and those receiving hemodialysis heart disease lung disease chronic liver disease, alcohol use disorder diabetes. Copyright healthcare personnel. Back. V = Q. Collapse fine text. O. Outline. EAEEEESEIEESO healthcare personnel O men who have sex with men. TE1 = I1Z-LENES. 29-30-32 Immunizations in individuals with HIV inactivated vaccines are generally safe. Exceptions to the routine immunization schedule. The routine ACIP immunization schedule is applicable to individuals with HIV with the following exceptions: Sent varicella vaccine, MMR vaccine, and dengue vaccines. Copyright contraindicated in individuals with CD4%. The efficacy of immunizations is reduced in individuals with HIV as a result of impaired immune function. 34. Immunizations in preterm infants. 35. Sent premature infants weighing prior to pregnancy, 5S9I36. Recommend all routine age-appropriate immunizations. Plus assess for evidence of immunity to varicella, rubella, and hepatitis B. Cell for all 6, non-immune women should receive appropriate vaccinations. 36 Copyright if live vaccines are administered, advise individuals to avoid conceiving for 1 to 3 months. 3L411L42 Recommend influenza vaccination, especially if pregnancy is expected during flu season. 36 During pregnancy /61I371I38. For all pregnant individuals, recommend 36-37 Sent Tdap vaccine once every pregnancy, preferably at 27 to 36 weeks gestation. 43 RSV vaccine between 32 to 36 weeks gestation plus inactivated influenza vaccine during flu season, safe in all trimesters. 341I37 COVID-19 vaccines. 36 LL44. Consider additional immunizations based on risk factors, e.g., 61-371I45. Sent high risk for HIV infection, HEPA vaccine. Sent high risk for HPV infection, Hep B vaccine. 1. Sent high risk for invasive meningococcal disease, meningococcal vaccines plus certain travel vaccines. Avoid contraindicated immunizations. Plus live attenuated vaccines are contraindicated as they carry a theoretical risk of fetal infection, example congenital rubella syndrome, congenital varicella syndrome. 39-36-37-15. Copyright MMR vaccine, varicella vaccine, HPV vaccine, and live attenuated influenza vaccine are not recommended during pregnancy. 46. Copyright women who lack immunity to rubella and/or varicella on prenatal screening, see prenatal care, should be vaccinated postpartum. V. WA. OO on immunizations before travel. Immunization. Meningococcal conjugate vaccine 55-16-56. Typhoid and paratyphoid fever vaccine I. Japanese encephalitis vaccine I. Yellow fever vaccine 9. Rabies vaccine, 60-61. Inactivated poliovirus vaccine, PV, 621. O. Tips and links. Sources. Back. Schedule. 2 months 2 years of age, 2 or 4 doses, depending on age and vaccine, and 2 years of age, 1 dose 1 give equals 10 days before traveling. Booster doses every 3 to 5 years for future travel or if ongoing exposure or re-exposure is expected. 1. Inactivated typhoid vaccine, injection 1 dose. Degree give 2 weeks before traveling. Copyright booster dose every 2 years live typhoid vaccine, oral 4 doses, 48 hours between each dose, copyright give equals 10 days before traveling. Copyright booster dose every 5 years. 2 doses, 28 days apart should be completed equals 1 week before travel. 1 booster dose equals 1 year after dose 2 if ongoing exposure or re-exposure is expected. 1 dose, given 10 days before departure. A booster dose is recommended in the following situations: copyright pregnancy, post-stem cell transplant, HIV infection, travel to areas with degree outbreaks if last dose was equals 10 years ago. 2 doses, 7 days apart. The series should be completed before travel. Titer levels and booster doses may be needed. 61. Adults and children with an incomplete primary series, complete primary IPV series before travel. Adults with a complete primary series, give a one-time booster dose. Overview of travel immunizations. Minimum age risk areas. Men ACWYCRM 2 months * meningitis belt of sub-degree * Menaquadi, 9 Saharan Africa 1 months * countries with outbreaks of Menaquai-TT, meningococcal disease 2 years. Sent inactivated, typhoid vaccine, 2 recommended for travelers. Yields. To most countries sent live typhoid vaccine, 6 years. Sent Southeast Asia and the Western Pacific * countries with outbreaks of Japanese encephalitis. Endemic areas include rural * agricultural areas. * 2 months in temperate areas, there are seasonal peaks in summer and fall. In the subtropics and tropics, transmission occurs year-round, peaks in the rainy season. Sent Africa, South America, and *A months H parts of Panama. Rabies has been found on none all continents except Antarctica. *6 weeks Middle East, Africa 63. Last updated October 31, 2023. V. NA collapse. 53. Recommendation. Recommended for individuals traveling to or residing in hyperendemic or epidemic countries who are in close contact with local residents. Recommended for travelers who may consume potentially contaminated food and beverages. Or recommended for those staying in rural areas and / or small cities. Recommended for long-term, 1 month, and frequent travelers to endemic regions. 1. Should be considered for short-term travelers to endemic regions. Recommended for all travelers visiting or residing in areas with increased risk. Considered for copyright individuals traveling to rural areas. Copyright individuals with risk factors. 1. Recommended for all travelers to endemic regions. A. Find text. Other considerations. Sent travelers to Saudi Arabia equals 2 years of age need proof of meningococcal vaccination, 85. Prevents illness in 50 to 80% of C571 individuals. There is currently no efficacy data available for the XERO vaccine. Asterisk recommend mosquito bite prevention. Many African and South American countries require proof of vaccination from incoming travelers. One dose provides lifelong protection, a booster dose may be required certain high-risk groups. Recommend mosquito bite prevention. Vaccinated individuals require rabies post-exposure prophylaxis if there is concern for rabies infection. Accelerated dosing schedules are recommended for those who cannot complete the standard primary IPV series before travel. See the latest CDC recommendations for further guidance. Outline. Recommended range of recommended vaccination recommended no recommended vaccination based on ages 4. A recommendation / ages for all 00 can begin in shared clinical, for catch up certain high. Not applicable children, this age group _ decision vaccination risk groups, making. Birth to 15 months. These recommendations must be read with the notes that follow. For those who fall behind or start late, provide catch-up vaccination at the earliest opportunity as indicated by the green bars. To determine minimum intervals between doses, see the catch-up schedule, Table 2. Vaccine and other 192 immunizing agents birth MO2 MOS 4 MOS 6 MOS 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 15 MOS. Respiratory syncytial virus at 1 dose depending on maternal RSV 1 dose, 8 through 19, RSV MAB vaccination status, see notes months, see notes near Sevimab. Hepatitis B at LEU equals. Rotavirus, RV, at 4 etiology RV1, 2 dose series, dose dochagi RV5, 3 dose series, SOS. Diphtheria, tetanus, and acellular pertussis 4 st second 3 id 4 ih at dose, DTAP. Haemophilus, REIQST second c. Pneumococcal 4 st second third conjugate at dose Salosi, PCV15, PCV20. Inactivated poliovirus 4 STQND at dose GADs. IPV. COVID-19 at 1 or more doses of updated, 2023, 1 VCOV mRNA, 2024 formula, vaccine 1 VCOV APS, see notes. Influenza, LAIV4, at. Measles, mumps, rubella at, MMR. Varicella at, VAR, Jose. Hepatitis A at. Tetanus, diphtheria, and acellular pertussis at, Tdap, 27 YRS. Human papillomavirus at, HPV. Meningococcal at, Menacui CRM 22 MOS, Menacui TT 22 years. Meningococcal B at, Men B4C, Men B FHBP. Respiratory syncytial virus vaccine at, RSV Abrysvo. Dengue at, Denacid, 9 to 16 YRS. Mpox at 18 months to 18 years. 18 months to 18 years. VV1 Euro Ali. Iodizits equals I equals. Respiratory syncytial virus at, RSV MAB. Nirsevimab. Hepatitis B at, Hep B. Rotavirus at, RV1, 2 dose series, RV5, 3 dose series. Diphtheria, tetanus, and acellular pertussis at, DTAP. Haemophilus influenza type Hep at, HIB. Pneumococcal conjugate at, PCV15, PCV20. Inactivated poliovirus at, IPV. COVID-19 at, 1 VCOV mRNA, 1 VCOV APS. 1 or more doses of updated, 2023 to 2024 formula, vaccine, see notes. Influenza, IIV4, degree annual vaccination 1 or 2 doses annual vaccination 1 dose on. Varicella at, var. Hepatitis A at, hepa. Tetanus, diphtheria, and acellular pertussis at, Tdap, 27 YRS. Annual vaccination 1 or 2 doses. Human papillomavirus copyright, HPV. Meningococcal at, men-ACWYCRM equals 2 mos, menac-YTT 22 years. Meningococcal bo, men B4C, men BFHBP. Respiratory. Syncytial virus vaccine at, RSV Abrisvo. Dengue at, Den4-SID, 916 YRS. Annual vaccination 1 dose on. Seropositive in endemic dengue areas, see notes. Mpox at. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age 4. Review vaccine types, frequencies, intervals, Table 1, by age, and considerations for special situations 2. Determine recommended interval for catch, notes, up vaccination, Table 2, catch up, 5. Review contraindications and precautions for vaccine types, Appendix, 3. Assess need for additional recommended vaccines by medical condition or other 6. Review new or updated ACIP guidance indication, Table 3, by medical indication, Addendum. Recommended by the Advisory Committee on Immunization Practices, ACIP, and approved by the Centers for Disease Control and Prevention, CDC, American Academy of Pediatrics, AAP4, American Academy of Family Physicians, AAFP7, American College of Obstetricians and Gynecologists, ACOG4, American College of Nurse Midwives, ACNM4, American Academy of Physician Associates, AAPA4, and National Association of Pediatric Nurse Practitioners, NAPNAP4. The comprehensive summary of the ACIP recommended changes made to the child and adolescent immunization schedule can be found in the January 11, 2024 MMWR report. Suspected cases of reportable vaccine-preventable diseases or outbreaks to your state or local health department sent clinically significant adverse events to the Vaccine Adverse Event Reporting System, VAERS, at www.vaers.hhs.gov or 800-822-7967. Questions or comments, contact www.cdc.gov/cdc-info or 800-CDC-INFO, 800-232-4636, in English or Spanish, 8 a.m. to 8 p.m. Eastern Time, Monday through Friday, excluding holidays. Helpful information. Sent Complete Advisory Committee on Immunization Practices, ACIP, Recommendations ACIP Shared Clinical Decision-Making Recommendations General Best Practice Guidelines for Immunization, including contraindications and precautions, Vaccine Information Statements Manual for the Surveillance of Vaccine-Preventable Diseases, including case identification and outbreak response. Top of page. Last reviewed, November 16, 2023. Copyright and 3 in, registered. Foot schedules home. For healthcare providers. For you and your family. Recommended no vaccination for adults. Vaccination for adults. Vaccination based on recommendation / not who meet age with an additional risk. Shared clinical applicable requirement, lack factor, or another decision-making documentation of indication. Vaccination, or lack evidence of immunity. Vaccine 19 to 26 years, 27 to 49 years, 50 to 64 years, 265 years. COVID-19 at 1 or more doses of updated, 2023 to 2024 formula, vaccine, see notes. Influenza inactivated, IIV4, or influenza recombinant, RIV4, at 1 dose annually. Influenza live copyright attenuated 1 dose annually, LAIV4, at respiratory SE. Seondalgian seasonal administration during Senves NN Okaramaya pregnancy. See notes, asterisk, RSV, at tetanus, 1 dose Tdap each pregnancy, 1 dose TD/Tdap for wound management. See diphtheria, notes pertussis, Tdap or TD, at 1 dose Tdap, then TD or Tdap booster every 10 years. Measles, for healthcare 1 or 2 doses depending on indication. Mumps, rubella personnel, if born in 1957 or later, MMR, at, see notes. Varicella 2 doses, VAR, at, if born in 1980 or 2 doses later. Zoster, _ Vecurabinant 2 doses for immunocompromising hoses 00 conditions, see notes, RZV, at. Human 2 or 3 doses Epilomavirus depending on IAE at Ps 27 tour GE 45 years vaccination or 1240-3415 U 3224 RFOMANAOE Bumaziopsiosis in NN papillomavirus depending on P27 through HPV at AE at IIA. In vaccination or condition. Pneumococcal C notes, PCV 15, PCV 20, PPSV 23, at C notes. Hepatitis A, HEPA, at. Hepatitis B A2, 3 or 4 doses depending on vaccine or, Hep B, at PET. Meningococcal A.CW_Y, Men ACWY, at. Meningococcal B, Men B, at. 19 through 23 years. Haemophilus influenza type B, HIB, at. Mpox at. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age 3. Review vaccine types, frequencies, intervals, Table 1, by age, and considerations for special situations 2. Assess need for additional recommended, notes, vaccinations by medical condition or other 4. Review contraindications and precautions for indication, Table 2, by medical condition, vaccine types, Appendix 5. Review new or updated ACIP guidance, Addendum. This schedule is recommended by the Advisory Committee on Immunization Practices, ACIP, and approved by the Centers for Disease Control and Prevention, CDC, American College of Physicians, ACP. 4. American Academy of Family Physicians, AAFP. 4. American College of Obstetricians and Gynecologists, ACOG. 4. American College of Nurse Midwives, ACNM. 4. American Academy of Physician Associates, AAPA. 4. American Pharmacists Association, APHA%, and Society for Healthcare Epidemiology of America, SHE. 4. The comprehensive summary of the ACIP recommended changes made to the adult immunization schedule can be found in the Anijern 024 Minlius/P. Children age 4 months through 6 years. The table below provides catch-up schedules and minimum intervals between doses for children whose vaccinations have been delayed. A vaccine series does not need to be restarted, regardless of the time that has elapsed between doses. Use the section appropriate for the child's age. Always use this table in conjunction with Table 1 and the notes that follow. Hepatitis B at birth 4 weeks, 8 weeks and at least 16 weeks after first dose. Minimum age for the final dose is 24 weeks. Rotavirus at 6 weeks, maximum 4 weeks. 4 weeks age for first dose is maximum age for 14 weeks, 6 days. Final dose is 8 months, 0 days. Diphtheria, 6 weeks, 4 weeks, 4 weeks, 6 months, 6 months. Tetanus, and a 5th dose is not acellular necessary if the pertussis at 4th dose was administered at age 4 years or older and at least 6 months after dose 3. Haemophilus influenza type B at 6 weeks. No further doses needed if first dose was administered at age 15 months or older. 4 weeks if first dose was administered before the 1-degree birthday. 8 weeks, as final dose, if first dose was administered at age 12 through 14 months. No further doses needed if previous dose was administered at age 15 months or older. 4 weeks if current age is younger than 12 months and first dose was administered at younger than age 7 months and at least one previous dose was PRPT, ACT HIV registered, Pentacel registered, Hybrix registered, Vaxillus registered, or unknown. 8 weeks and age 12 through 59 months, as final dose, if current age is younger than 12 months and first dose was administered at age 7 through 11 months. C. 8 weeks, as final dose, this dose only necessary for children aged 12 through 59 months who received 3 doses before the 1*T birthday. Or if current age is 12 through 59 months and first dose was administered before the 1-degree birthday, and second dose was administered at younger than 15 months, or if both doses were PEDVAX HIV registered and were administered before the 1* birthday. Pneumococcal 6 weeks. No further doses. 8 weeks, as final conjugate at needed dose, for healthy children. This dose is only if first dose was if previous dose was necessary for administered at age 24 months or older. 4 weeks if first dose administered at age 24 months or older. 4 weeks if current age is younger than 12. Children aged 12 through 59 months regardless of risk, or age 60 through 71 months with any. 4 weeks if first dose administered before the 1 birthday. 8 weeks, as final dose for healthy children, if first dose was administered at the 1T birthday or after. If current age is younger than 12 months and previous dose given at age 60 through 71 months with any risk, who received 3 doses before age 12 months. Inactivated poliovirus at 6 weeks. 4 weeks if current age is 6 months, minimum age 4 years for final dose. X26cdc.gov. P.S. Rubella at varicella at 12 months. 3 months hepatitis A at 12 months. 6 months meningococcal 2 months. 8 weeks. See notes ACWY at menacYCRM 2 years men ACWYTT. Top of page. Children and adolescents age 7 through 18 years. Meningococcal not applicable, N/A, 8 weeks ACWY at tetanus, 7 years 4 weeks 6 months diphtheria, if first dose of DTaP/DT if first dose of DTaP/DT tetanus, was administered before diphtheria, and the 1-degree birthday acellular 6 months, as final dose, pertussis at if first dose of DTaP/DT or Tdap/TD was administered at or after the 1-degree birthday. Human 9 years routine dosing intervals are recommended. Papillomavirus at hepatitis A at N/A 6 months. Hepatitis B at N/A 4 weeks 8 weeks and at least 16 weeks after first dose. Inactivated N/A 4 weeks 6 months. A fourth dose of IPV is poliovirus at a fourth dose is not indicated if all previous necessary if the third dose was administered at age 4 years or older and at least 6 months after the previous dose. Doses were administered at minimum interval between doses. Vaccine minimum age for dose 1 to dose 2 to dose 3 to dose 4. Measles, N/A 4 weeks. Mumps, rubella at varicella at N/A 3 months if younger than age 13 years. 4 weeks if age 13 years or older. Dengue at 9 years 6 months. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age, Table 1, by age, 4. Review vaccine types, frequencies, intervals, and considerations. 2. Determine recommended interval for catch-up vaccination for special situations, notes, Table 2, catch-up, 5. Review contraindications and precautions for vaccine types 3. Assess need for additional recommended vaccines by medical, appendix, condition or other indication, Table 3, by medical indication, 6. Review new or updated ACIP guidance, Addendum. Recommended by the Advisory Committee on Immunization Practices, ACIP, and approved by the Centers for Disease Control and Prevention, CDC, American Academy of Pediatrics, AAP4, American Academy of Family Physicians, AAFP4, American College of Obstetricians and Gynecologists, ACOG4, American College of Nurse Midwives, ACNM4, American Academy of Physician Associates, AAPA4, and National Association of Pediatric Nurse Practitioners, NAPNAP 4%. Recommended for all age-eligible children who lack documentation of a complete vaccination series. Not recommended for all precaution, all children, but is age-eligible children, and might be recommended for some additional doses may be indicated if children based on benefit of increased risk for or medical condition or protection. Severe outcomes from other indications. See disease notes. Adverse reaction. Outweighs risk of. Contraindicated or not recommended. No * vaccinate after pregnancy, if indicated. Guidance/not applicable. Always use this table in conjunction with Table 1 and the notes that follow. Medical conditions are often not mutually exclusive. If multiple conditions are present, refer to guidance in all relevant columns. See notes for medical conditions not listed. Vaccine and other immunizing agents. HIV infection CD4 percentage and count. Asplenia or CSF leak persistent immunocompromised or complement status, excluding HIV. RSV mAb at. Nirsevimab, 1 dose depending on maternal RSV vaccination status, see note second RSV season. Hepatitis B at. Heart disease or chronic lung disease. Second RSV season for alveolar lung disease, see notes. Kidney failure, end-stage renal disease, chronic or on liver dialysis disease, diabetes. 1 dose depending on maternal RSV vaccination status, see notes. Hepatitis B at. Rotavirus at. DTaP/Tdap at DTaP. See notes. See notes. See notes. Measles, mumps, rubella at. VAR at. Hepatitis A at. Human papillomavirus at. Meningococcal ACWY at. Meningococcal BO. RSV at seasonal, Abrysvo, administration, see notes. 3-dose series. See notes. Mpox at. For additional information regarding HIV laboratory parameters and use of live vaccines, see the General Best Practice Guidelines for Immunization, Altered Immunocompetence, and Table 4:1, footnote. B. Severe combined immunodeficiency CLAIV4 contraindicated for children 2 to 4 years of age with asthma or wheezing during the preceding 12 months. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age, Table 1, by age, 4. Review vaccine types, frequencies, intervals, and considerations 2. Determine recommended interval for catch-up vaccination for special situations, notes, Table 2, catch-up, 5. Review contraindications and precautions for vaccine types 3. Assess need for additional recommended vaccines by medical, appendix, condition or other indication, Table 3, by medical indication, 6. Review new or updated ACIP guidance, Addendum. Recommended by the Advisory Committee on Immunization Practices, ACIP, and approved by the Centers for Disease Control and Prevention, CDC, American Academy of Pediatrics, AAP4, American Academy of Family Physicians, AAFP4, American College of Obstetricians and Gynecologists, ACOG4, American College of Nurse Midwives, ACNM 4%, American Academy of Physician Associates, AAPA%, and National Association of Pediatric Nurse Practitioners, NAPNAP 4. The comprehensive summary of the ACIP recommended changes made to the child and adolescent immunization schedule can be found in the January 11, 2024 MMWR report. Recommended for all adults who lack documentation of vaccination, or lack evidence of immunity. Not recommended for all adults, but recommended for some adults based on either age or increased risk for or severe outcomes from disease. Recommended based on shared clinical decision-making. Recommended for all adults, and additional doses may be necessary based on medical condition or other indications. See notes. Precaution might be indicated if benefit of protection outweighs risk of adverse reaction. Contraindicated or not recommended. No * vaccinate after pregnancy, if indicated. Guidance/not applicable. Always use this table in conjunction with Table 1 and the notes that follow. Medical conditions or indications are often not mutually exclusive. If multiple medical conditions or indications are present, refer to guidance in all relevant columns. See notes for medical conditions or indications not listed. Kidney HIV infection CD4 percentage and count end-stage immunorenal chronic compromised men who asplenia, heart disease liver, excluding. COVID-19 at see notes. 144 at or RIV for 1 dose annually. 1 dose LAIV4 at annually if age 1 dose annually if age 19-49 years 19 to 49 years. Kidney HIV infection CD4 failure, percentage, and count end-stage immunorenal chronic compromised men who asplenia, heart disease liver, excluding. RSV at seasonal administration. See notes. Tdap or TD at Tdap. 1 dose each 1 dose Tdap, then TD or Tdap booster every 10 YRS pregnancy. MMR at 1 or 2 doses depending on indication. VAR at see notes. RAV at see notes. HPV at 3 dose series if indicated. Pneumococcal urotie. HEPA at. Hep B at age equals see notes. A precaution for LAIV4 does not apply to alcoholism. B. See notes for influenza, hepatitis B, measles, mumps, and rubella, and varicella vaccinations. See hematopoietic stem cell transplant. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age, Table 1, by age, 4. Review contraindications and precautions for vaccine types 2. Assess need for additional recommended vaccinations by medical, appendix, condition or other indication, Table 2, by medical condition, 5. Review new or updated ACIP guidance, Addendum. XX Sudden Infant Death Syndrome. Sudden Infant Death Syndrome, SIDS, is the abrupt and unexplained death of an infant less than 1 year old. Although the etiology of SIDS remains unclear, evidence suggests that it is caused by a combination of environmental triggers and cardiorespiratory impairment, which then leads to prolonged hypoxia. Most cases of SIDS occur in the first 6 months of life. Parents should receive information on how to prevent SIDS during prenatal care and in pediatric check UPS after birth. Recommendations include placing the infant on their back to sleep, ensuring a safe sleep environment, example appropriate sleeping surface and sleepwear, room sharing with a caretaker, avoiding accessories like pillows and toys, avoiding overheating, and avoiding second-hand smoke. SIDS is a diagnosis of exclusion, An autopsy is required to rule out other causes of death, example congenital cardiac anomalies or battered child syndrome. OS. CES. Definition. Sudden infant death syndrome, SIDS, is the abrupt and unexplained death of an infant. 1. O. OAO. Epidemiology. Cent peak incidence, 2 to 4 months. Sickle sex, 7-2. Epidemiological data refers to the U.S., unless otherwise specified. WA. OO ISIS. Etiology. The etiology of SIDS remains unclear. Evidence suggests that it is caused by a combination of both extrinsic and intrinsic factors, which ultimately lead to acute or chronic hypoxia. Over 90% of cases of SIDS occur during sleep. IL-4. Extrinsic factors /4LL5. Sleeping in the prone position, exposure to nicotine during pregnancy and after birth, including second-hand smoking, young maternal age, especially. Intrinsic factors 31. Male sex, premature descent, prenatal and /or postnatal exposure to smoking, alcohol, and /or drugs, polymorphisms in the serotoninergic pathway, brainstem abnormality that affects serotoninergic modulation of cardiorespiratory control and impairs protective responses to external stressors. WA. CE. Differential diagnoses. SIDS is a diagnosis of exclusion. As with any unexplained infant death, U.S. law requires an autopsy to rule out other causes of death. Congenital anomalies, example cardiac anomalies, fatal child abuse, copyright intentional suffocation, copyright battered child syndrome, copyright closed head injury, copyright poisoning, metabolic disease, example MCAD deficiency, infections, example pneumonia, meningitis, sepsis, aspiration, asphyxiation, anaphylaxis. Back collapse, fine text outline. Hyperthermia, epilepsy. The differential diagnoses listed here are not exhaustive. WA. CE. Brief resolved unexplained event, BRU, formerly apparent life-threatening event, ALTE, LELF 7. Definition, a sudden, brief. O. Physical examination and history. Copyright diagnosis of exclusion. If a cause for the event can be determined, then it is not BRU. Management, copyright patients with low-risk BRU, 6. Education for caregivers, recommend CPR training to caregivers, copyright patients with high-risk BRU, 7. Initial evaluation and management monitoring, continuous pulse oximetry for at least 4 hours, consultation, screen for child abuse, mental health factors, and feeding evaluation, diagnostic testing for potential underlying causes, concern for child maltreatment, consultation with child abuse expert, head imaging, skeletal survey, secondary evaluation and management, if no cause can be established after primary evaluation, hospital admission for continuous prolonged oximetry. Observation, swallow evaluation, and feeding consultation is indicated. Further interventions according to event characteristics. WI. OCES. Prevention. Prenatal and well child care visits should involve education on how to prevent SIDS. During pregnancy. No smoking, alcohol, or recreational drugs. 8. * prenatal care 1. Protective factors after birth. The infant should be placed to sleep in the supine position, safe sleep environment, firm mattress, no pillows, blankets, stuffed animals, or bumper pads in the crib. 9-10 in the first 6 months, co-sleeping in the same room without bed sharing. 11. Smoke-free environment. Avoid overheating, use of pacifier during sleep, especially between 1 and 6 months of age. 12 breastfeeding until at least the age of 4 months. 3 placing an infant in a prone position while awake and supervised, tummy time, helps strengthen neck and shoulder muscles. Copyright immunization in line with the official vaccination schedule to prevent infections associated with SIDS. Back collapse. Fine text outline. Avoid overheating. Smoke-free environment. 45. 45. F_Y F_ PKOH room sharing I_ without bed sharing. Pacifier use. J_ STWLREZ. Supine OESE. Position WPI flat, firm 7 sleeping surface equals L in // no soft objects _S_dot, /AIBEA, example pillows, or AE crib bumper pads i.e. LOSES and A_Y. Safe sleep practices to reduce the risk of sudden infant death syndrome. Copyright Boss. X tall stature and abnormally rapid growth. Tall stature is defined as a height of more than 2 standard deviations above the population mean or exceeding the G7th percentile for age and sex. In most cases, tall stature represents an acceptable normal variation in growth. However, tall stature can also be the result of an underlying disorder, i.e., endocrine or genetic abnormalities. Differentiating between normal or pathological growth variations involves a thorough medical history and clinical examination. Bone age tests, karyotyping, and endocrinological tests can confirm the diagnosis of a pathological cause. WA ISIS. Overview. Scent definition: a height of more than 2 standard deviations above the population mean or exceeding the G7th percentile on the normal growth curve for age and sex. Scent: most tall children do not have a pathological cause. Evaluation of growth. History 1. Assess milestones, exclude developmental delay, copyright determine midparental height. Scent physical examination accurate serial measurements of individual body areas equals proportional vs disproportional growth, example disproportionately long extremities usually indicate Marfan syndrome, equals length or height 1 equals growth velocity 7. Copyright exclude the following, equals secondary sexual characteristics equals neurological lesions equals dysmorphism. Scent further diagnostic measures, if a pathological cause is suspected, bone age 1 karyotyping endocrine laboratory tests, depends on which pathology is suspected example insulin-like growth factor for excess growth hormone or TSH and T, hormone for hyperthyroidism. Etiology of tall stature. Etiology of tall stature. Etiology characteristic features. Family history non-pathological familial/constitutional tall stature projected height within 5 cm of midparental height normal bone age. Other features of hyperthyroidism, i.e., tachycardia, diarrhea, goiter, hyperthyroidism plus abnormal TSH and T4 hormone. *7 BMI slightly advanced bone age obesity modest overgrowth early onset of puberty almost normal final height endocrine coarse facial features, frontal bossing, prognathism tumor mass symptoms, headaches, visual impairment T serum IGF-1 plus GH after oral glucose test. Pituitary gigantism, growth hormone excess. 2. Breast development before 8 years testicular enlargement before 9 years abnormal LH, FSH, estradiol, testosterone, 17-alpha-hydroxyprogesterone, BHCG levels precocious puberty. Macrosomia, omphaloceal, macroglossia hemihyperplasia insulin, glucose, abdominal ultrasound, i.e., to identify embryonal tumors, d equals a degree. Marfanoid habitus inferior displacement of lens abnormal homocysteine and methionine developmental delay homocystinuria. Delayed puberty, infertility, testicular hypoplasia, gynecomastia Klinefelter syndrome karyotyping, 47XXY. FBN1 gene mutation Marfanoid habitus Marfan syndrome superior subluxation of lens. Back collapse find text outline. FBN1 gene mutation Marfanoid habitus superior subluxation of lens kyphoscoliosis Marfan syndrome. Cardiac abnormalities. FMR1 gene mutation large ears, high arched palate, long face macroorchidism pes planus fragile X syndrome. Genetic macrocephaly, long face, prominent narrow jaw Sotos SY, feeding difficulties, hypotonia advanced bone age. Micronathia, broad forehead Weaver syndrome camptodactyly advanced bone age. 47XYY syndrome copyright tall stature copyright usually normal fertility and pubertal development copyright mild delays in motor and language development copyright acne 47XYY syndrome and 47XXX syndrome 47XXX syndrome copyright tall stature copyright delayed motor and language development copyright learning disabilities EO menstrual abnormalities, occasionally fertility problems. Café au lait spots or hyperpigmented macules neurofibromatosis type 1 axillary or inguinal freckles neurofibromas. References, ISI 4 IISI 6. WA. CE. Endocrine disorders. Gigantism. Scent definition, rare disorder characterized by abnormal linear growth during childhood due to growth hormone excess while the epiphyseal growth plates are still open. Scent pathophysiology. OE most common, T growth hormone, GH, secretion from the anterior pituitary, i.e., adenoma more details see the acromegaly article, O1 GHRH secretion from the hypothalamus, i.e., tumors. Copyright 7 production of IGF binding protein 7 half-life of IGF-1. Scent risk factors, associated with an T incidence of pituitary tumors. TF-IGF-1 synthesis 7 cell growth and proliferation, 4. O multiple endocrine neoplasia type 1, men 1. O McCune-Albright syndrome OE Carney complex copyright neurofibromatosis copyright tuberous sclerosis. Scent clinical features copyright tall stature copyright 1 growth of distal limbs, i.e., hands, feet, fingers, toes, O tumor mass symptoms, headaches, visual changes, features of hypopituitarism O progressive macroencephaly copyright coarse facial features, frontal bossing, prognathism 1 degree obesity. Scent diagnosis OTT serum IGF-1O. GH after oral glucose tolerance test confirms pituitary gigantism. O after a biochemical diagnosis is established equals MRI, pituitary mass equals CT if MRI is negative, exclude other GH secreting tumors, example pancreas, adrenal glands, ovarian, bronchial. Scent treatment copyright transsphenoidal surgery, pituitary adenoma excision O medical therapy. Equals somatostatin analogs, example octreotide. Equals GH receptor antagonists, example pegvisomant, scent complications. Back collapse find text outline. Scent complications O carpal tunnel syndrome O cardiovascular disease equals heart failure, the most common cause of death, equals hypertension copyright osteoarthritis copyright endocrine disorders, i.e., hypogonadism, diabetes, hyperprolactinemia, copyright benign tumors, i.e., uterine leiomyomas, prostatic hypertrophy, colonic polyps, other causes. Precocious puberty hyperthyroidism references. OO. CES. Genetic disorders. Beckwith-Wiedemann syndrome, IG. Scent definition, congenital disorder of growth with a predisposition to tumor development. Scent epidemiology E1/15,000 newborns in the U.S. Copyright increased risk of nephroblastoma, hepatoblastoma, neuroblastoma, adrenal tumors. Scent etiology, associated with WT2 gene mutation on chromosome 11, 80% of cases. Scent pathophysiology, defect in genetic imprinting, overexpression of genes. Scent clinical features, degree macrosomia, omphalocele, i.e., exumphallos, copyright macroglossia, organ enlargement, heart, liver, kidney, etc. O hemihypertrophy, hemihyperplasia, one side or a part of one side of the body is larger than the other. O features of neonatal hypoglycemia, 1 irritability, intellectual disability. O genitourinary abnormalities. O facies, midface hypoplasia, infraorbital and earlobe creases. Degree cleft palate, rare. Scent diagnosis, copyright J blood glucose, T serum insulin, IGF-2, hypoglycemia, copyright screening options for embryonal tumors, 91. Equals abdominal ultrasound every 3 months until 8 years of age. Alpha-fetoprotein levels every 3 months until 4 years of age. Scent treatment. O frequent feedings to maintain sufficient blood glucose levels. Copyright resection of embryonal tumors. At plus Soto syndrome, cerebral gigantism, 1 degree. Plus epidemiology, 1/10,000-14,000 newborns. Scent etiology, autosomal dominant mutation in the NSD1 gene on chromosome 5. 10** symptoms. Degree tall stature. EO macrocephalus. Equals high forehead. Equals elongated face. Equals hypertelorism. Equals pointed chin. Equals receding hairline. EO psychomotor retardation. O hypotonia. Copyright delays in achieving milestones, example walking, talking, clumsiness. Scent diagnosis. O usually clinical eDNA studies, 5q35 microdeletions and partial NSD1 deletions in 10 to 15% of cases. AV. Back collapse. A. Fine text. O. Outline. X tall stature and abnormally rapid growth. Scent epidemiology E1/15,000 newborns in the US. O increased risk of nephroblastoma, hepatoblastoma, neuroblastoma, adrenal tumors. Scent etiology, associated with WT2 gene mutation on chromosome 11, 80% of cases. Scent pathophysiology, defect in genetic imprinting, overexpression of genes. Scent clinical features, degree macrosomia, omphalocele, i.e., exumphallos, O macroglossia, organ enlargement, heart, liver, kidney, etc. O hemihypertrophy, hemihyperplasia, one side or a part of one side of the body is larger than the other. O features of neonatal hypoglycemia. 1, irritability, intellectual disability. J copyright genitourinary abnormalities. O facies, midface hypoplasia, infraorbital and earlobe creases. Copyright cleft palate, rare. Scent diagnosis. EJ blood glucose, T serum insulin, IGF-2, hypoglycemia. Copyright screening options for embryonal tumors. 9 equals abdominal ultrasound every 3 months until 8 years of age. Equals alpha-fetoprotein levels every 3 months until 4 years of age. Scent treatment. O frequent feedings to maintain sufficient blood glucose levels. O resection of embryonal tumors. E at plus Soto syndrome, cerebral gigantism, 1 degree. Plus epidemiology, 1/10,000-14,000 newborns, 1. Etiology, autosomal dominant mutation in the NSD1 gene on chromosome 5. No asterisk symptoms, 14. Copyright tall stature. EO macrocephalus. O facies. equals high forehead equals elongated face equals hypertelorism equals pointed chin equals receding hairline OE psychomotor retardation O hypotonia copyright delays in achieving milestones, example walking, talking, clumsiness, scent diagnosis OE usually clinical copyright DNA studies, 5q35 microdeletions and partial NSD1 deletions in 10 to 15% of cases, O prenatal diagnosis possible scent treatment. O only symptomatic treatment is possible. O multi-professional approach, 1. Scent course EO normal growth rate from 3 to 5 years of age, only moderately increased adult height, O permanent cognitive developmental impairments are common. Other causes. E. Marfan syndrome scent homocystinuria scent fragile X syndrome neurofibromatosis type 1 scent Klinefelter syndrome, 47XXY, scent Weaver syndrome. Back collapse fine text outline. Euro tall stature and abnormally rapid growth, 1/2. Beckwith-Wiedemann syndrome and neonatal hypoglycemia characteristic facies definition IEEE congenital disorder of growth with a, due to hyperinsulinism, predisposition to tumor development. Etiology, a WT2 gene mutation on chromosome 11-2 on defect in genetic imprinting Y2 et as. Diagnostics equals registered clinical diagnosis and/or genetic testing. Treatment copyright infraorbital creases E treatment of manifestations at midfacial hypoplasia, example omphalocele repair, Y. Macroglossia irregular screening for tumors and SY/Y earlobe crease urinary tract abnormalities, example abdominal organomegaly F, ultrasound, serum AFP levels, example hepatomegaly, OE, Connolist. NR macrosomia with equals hemihypertrophy. Nephroblastoma hepatoblastoma. Beckwith-Wiedemann syndrome fact sheet VV. Copyright Boss. Euro tall stature and abnormally rapid growth, 2/2. Soto syndrome VV. Characteristic features of the Soto syndrome such as a prominent forehead, macrocephaly, ocular hypertelorism, pointed chin and downslanting palpebral fissures can be seen. Source, Figure 4, in, steric clash in the set domain of histone methyltransferase NSD1 as a cause of Soto syndrome and its genetic heterogeneity in a Brazilian cohort by KHA, P. Anand, J. A. Lee et al., MDPI, Human Genomics and Genetic Diseases, licensed under CC by 4.0. X. Short stature. Short stature, dwarfism, in children is defined as a height that is at least 2 standard deviations, SDS, below the mean for children of the same age and sex. In adults, the condition is commonly defined as a height of 5 feet 1 in, 155 centimeters, or less in men and 4 feet 10 in, 147 centimeters, or less in women. Non-pathological variant short stature can be classified into 3 types: familial short stature, inherited short stature, constitutional delay of growth and puberty, an inherited pattern of short stature during childhood that is followed by a growth spurt during puberty, typically resulting in normal adult height, and idiopathic short stature in the absence of any metabolic, endocrine, or other diagnosis. These types of short stature are most often normal variants of growth and rarely affect a child's development beyond. Longitudinal growth. The pathological causes of short stature are diverse and include psychosocial circumstances as well as a variety of genetic, endocrine, and metabolic disorders, which may affect a child's development in other ways than longitudinal growth. Further diagnostic testing is indicated if a child's growth is less than what might be expected given the average height of the parents. An X-ray of the left hand and wrist are made to determine bone age, skeletal age, based on which the adult size of the child can be predicted. Laboratory testing can help rule out any underlying condition. Treatment is rarely indicated in non-pathological short stature, example if short stature does not represent a disability to the patient, while pathological short stature is treated according to the underlying condition and usually involves growth hormone supplementation. WA. GS. Definition. Cent short stature, dwarfism, copyright children, height of 2 SDS below the mean for children of the same age, sex, and similar genetic background. Copyright adults, height of cent disproportionate short stature or limbs disproportionately short compared to trunk Eocene, mostly in cases of skeletal dysplasia plus growth failure, growth rate below the rate considered appropriate for sex and age. Causes of short stature. Short stature can have a variety of genetic, systemic, and psychosocial causes. Cent genetic causes include copyright constitutional growth delay, O'Leary syndrome, copyright Turner syndrome, ESYIC causes IND. Copyright congenital hypothyroidism, copyright GH deficiencies, copyright glucocorticoid excess. Cent psychosocial causes include maternal substance use, example alcohol, copyright psychosocial short stature, copyright psychiatric conditions, example anorexia nervosa. And genetic causes of short stature. Genetic causes of short stature condition, underlying cause characteristics, non-pathological variant short stature 5 * hereditary short stature * normal development - familial short stature SE, i.e. EA5. Main. Back collapse, fine text outline. Genetic causes of short stature condition, underlying cause characteristics, non-pathological variant short stature. Normal development 1 skeletal age consistent with chronological age, hereditary short stature, most common cause of proportionate short stature, familial short stature. Temporary delay in growth and onset of puberty, X-ray shows a delayed bone age, less than the individual's plus inherited type of developmental delay, autosomal dominant, recessive, or chronological age, FA constitutional growth delay, X-linked trait, * delayed onset of puberty, but no treatment is needed, plus delay in pulsatile hypothalamic GnRH release. Copyright reassuring the child and parents is sufficient. Copyright catch-up growth eventually occurs. Copyright individual reaches a normal adult height. Height of S2 SDS below the mean for age that cannot be explained by inheritance or pathological processes. Idiopathic short stature, diagnosis of exclusion in the absence of an underlying condition. Pathological short stature. Microcephaly, prominent forehead * saddle nose, tissue insensitivity to growth hormone, GH, due to GH receptor mutation. Laron syndrome A, leads to linear growth, plus hypoglycemia, delayed puberty, small genitalia. Hormones, FTGH and IGF-1. Skeletal dysplasias, impaired osteogenesis. See the section on skeletal dysplasias below. Skeletal abnormalities, gonadal dysgenesis, congenital cardiovascular defects, Turner syndrome, loss of one Shoke's gene copy from the missing X chromosome. Craniofacial dysmorphia, skeletal abnormalities, Down syndrome, possibly due to selective IGF-1 deficiency, developmental delay. Obesity. Cognitive impairment, Williams syndrome, loss of several genes from chromosome 7, elfin-like facies, cardiovascular abnormalities. Malnutrition, defective chloride channel secretion of hyperviscous mucus, blockage of exocrine glands, chronic mucosal inflammation, cystic fibrosis, failure to thrive, chronic infections. Obesity, pseudo-hypoparathyroidism, Albright F+, round face, hereditary osteodystrophy, scent, impaired bone growth due to PTH resistance, E. Shornack. Brachydactyly. Polyostotic fibrous dysplasia, cafe au lait spots, precocious puberty, McCune-Albright syndrome, accelerated bone maturation associated with early onset of puberty. 0-haired N. Systemic causes of short stature. Systemic causes of short stature condition, underlying cause characteristics, endocrine disorders. Congenital iodine deficiency syndrome, cretinism, congenital hypothyroidism plus impaired skeletal development due to iodine deficiency. Copyright delayed skeletal age. Copyright intellectual disabilities. Growth delay. Low bone density. Muscle atrophy. GH deficiencies. Impaired bone and muscle development. Blood pressure disorders. Hypoglycemia. Adrenal crisis. Congenital adrenal hyperplasia. Rapid bone maturation due to increased androgen levels. Failure to thrive. Cushingoid features. Copyright central obesity. Copyright moon facies. Copyright skin modifications. Accelerated bone resorption. Glucocorticoid XSSI2 inhibited chondrogenesis. Degree hypertension. Back collapse. Fine text outline. Polyuria. Poor glycemic control and dysregulation of the hypothalamic pituitary. Somatotropic plus polydipsia. Axis polyphagia. Recurrent infections. Type 1 diabetes mellitus. Rheumatological diseases. Plus joint stiffening and deformation. Growth delay. Uveitis rash. Lymphadenopathy. Chronic inflammation of joints. Side effects of long-term high-dose glucocorticoid therapy. Juvenile idiopathic arthritis. Renal disorders. Renal osteodystrophy due to low conversion of vitamin D to calcitriol. Copyright secondary hyperparathyroidism. Copyright hypophosphatemia. Anemia of chronic kidney disease. Chronic kidney disease, CKD, rickets. Dysregulation of the GH/IGF-1 system. Polyuria with mineral loss. Rickets/osteomalacia. Polyuria growth retardation. Fanconi syndrome. Increased phosphaturia due to impaired tubular reabsorption of phosphate. Metabolic disorders. Bowing of long bones. Rachitic rosary. Craniotabes. Rickets. Defective growth plate and bone matrix mineralization due to vitamin D deficiency. Genivarum/valgus. Gastrointestinal disorders. Abdominal pain. Diarrhea. Celiac disease/inflammatory bowel disease. Malabsorption due to chronic intestinal inflammation and damage. Failure to thrive. Extraintestinal inflammatory symptoms, example arthritis, uveitis. Chronic oxygen deficiency. Failure to thrive. Signs of heart failure. Exercise intolerance. High energy requirements due to inappropriate gas exchange. Congenital heart defects. 9. Decreased nutritional intake. Cyanosis. Pallor. Exertional intolerance. Hepatosplenomegaly. Anemias. Tissue hypoxia and low metabolism rates. 1. Immunological diseases. Anorexia, cachexia. Malabsorption. Severe infections and organ failure, example HIV wasting syndrome, growth failure. Chronic immunodeficiency associated with copyright low dietary intake and altered metabolism. Copyright low IGF-1 levels and tissue insensitivity to IGF-1. Copyright increased susceptibility to diarrhea. HIV infection. Recurrent severe infections. Diarrhea. Thrush. Failure to thrive. Primary deficiency in B and T cells leading to severe combined immunodeficiency. Copyright recurrent diarrheal infections. Copyright cachexia. Other causes of short stature. GH deficiency due to 3079 * weight loss. Copyright mass effect of hypothalamic or pituitary tumors. ARAAE_fatigue neoplasms. Copyright hypothalamic or pituitary radiation. Anemia. Primary hypothyroidism due to radiation. Fever, nausea and vomiting as a result of radiotherapy and chemotherapy. ON5, shared note. And behavioral and psychosocial circumstances of short stature. Psychosocial causes of short stature. Condition. Underlying cause. Characteristics. Nicotine. Tissue hypoxia due to an increased carbon monoxide concentration and release of catecholamines. Maternal substance use plus alcohol. Underdevelopment of skeletal muscle cells and central nervous system. Fetal alcohol syndrome, cocaine. Fetal hypoxia due to placental vessels. Vasoconstriction. Intrauterine growth retardation. Low birth weight. Skeletal anomalies. Poor growth or weight gain, poor record of school attendance, and emotional deprivation or stress that typically involves neglect, abuse, or a poor relationship between the patient and psychosocial short caregiver and leads to stature, degree, malnutrition, copyright, low GH levels. Medical care signs of child maltreatment, clinical and radiographic signs of abuse. Back collapse, find text outline. XX short stature. Go. OO share. ES behavioral and psychosocial circumstances of short stature. Psychosocial causes of short stature condition, underlying cause nicotine, tissue hypoxia due to an increased carbon monoxide concentration and release of catecholamines, alcohol, underdevelopment of skeletal muscle cells and central nervous system, fetal alcohol syndrome, cocaine, fetal hypoxia due to placental vessels vasoconstriction, maternal substance use *. Emotional deprivation or stress that typically involves neglect, abuse, or a poor relationship between the patient and psychosocial short caregiver and leads to stature, copyright, malnutrition, copyright, low GH levels. Anorexia nervosa, malnutrition. Diagnostics. Patient history. Sent physical examination findings, sent growth rate, family history of short stature. Characteristics: intrauterine growth retardation, low birth weight, skeletal anomalies. Poor growth or weight gain, poor record of school attendance and medical care, signs of child maltreatment, clinical and radiographic signs of abuse. Low body weight, endocrine disorders, CNS and cardiovascular abnormalities, recurrent bone fractures, fragile skin appendages. Sent mid-parental height, estimated adult height of a child calculated on the basis of parental height, calculated via the following formula: $yen equals mother's height in cm plus father's height in cm, 13/20 of equals father's height in cm plus mother's height in cm plus 13/2. Laboratory tests. *CBC, differential blood count, ESR1, sent thyroid function tests, C hypothyroidism, sent renal function tests and urinalysis, in case of CKD and associated renal osteodystrophy, sent screening for GH deficiency, C hypopituitarism, sent hormone profile, LH, FSH, estrogen/testosterone, for puberty status assessment plus karyotyping. Imaging tests. Sent X-ray, used to determine an individual's bone age and height by comparing their X-ray images of the non-dominant hand and wrist to those displayed in the standard bone development atlas. Sent cranial MRI, in suspicion of hypothalamic or pituitary tumors. OI. CE. Treatment. Management depends on the underlying cause, reassurance that low height is a normal variant, example familial short stature, that does not require treatment. Sent discontinuation of growth-inhibiting medication, example glucocorticoids, sex hormone substitution in children with delayed puberty and growth. 1. Sent GH supplementation, example somatropin, in cases of GH deficiency, idiopathic short stature, and Turner syndrome. Sent in case of primary severe IGF-1 deficiency, mecasermin, recombinant. Insulin-like growth factor, sent treatment of underlying conditions, see causes of short stature above. Back collapse, find text. O. Outline. cm plus in 2007 May plus 78787 equals 476. E76 stature for age percentiles, ZM. Plus 74 95th 74, ID boys, 2 to 20 years equals pad 8 185 equals REI, 7 plus 72 ALT 72. ZA law 75th plus. QALMP ALI ACONFJ 175 4 plus 468 plus IMBY, 25th F equals ZIYT plus 66 equals /VAME 10th 66 for 165 FJ. Y645 he higher I'm third 64 160 plus ZJ yen 7 EEL plus 62 to 62 plus OS 60 equals IL, LALLLIC, 64 154 Zeology ZI. PS 58A. LLLA 58 4 RR Act Larva. Plus 56 equals L dollar ODVAVY, 56 a 140 equals 7 LGRGLA, RT 14 TLLA IA FA. 135 OL464 T4AA plus 524 OE 52 for 130 JMFAAZG equals 54, ZLVABR 54 125 44 OE AGUA 44 PA 1 plus 48 48 5 120, AIB underscore equals AAL asterisk a 46 4 EOIE FA, plus 44 a 4 to 44 for 110 7 YA4. 42 4 F 42 7 105 44 Ali Hal Beta 7 Yen 77 and WA 3 F 44. Plus 38. 38, GS equals A. 94 P 36 4. EO 24 F 32 4. Source, Figure 12, in 2000 CDC Growth Charts for the United States, Methods and Development, Cooks-Marsky R.J., Ogden C.L., Guo S.S., ETAL, Centers for Disease Control and Prevention licensed under public domain. Puberty. Puberty refers to the phase of development between childhood and adulthood in which complete functional maturation of the reproductive glands and external genitalia occurs. The other processes that characterize this transitional phase are the development of secondary sex characteristics, growth spurts, and psychosocial changes. The stages of development during puberty are classified according to the Tanner stages. Although there is considerable variation between individuals, puberty begins on average at the age of 11 in girls and 13 in boys. When puberty begins abnormally early, it is referred to as precocious puberty and is classified into two main types: peripheral precocious puberty, which is independent of gonadotropin-releasing hormone secretion, and central precocious puberty, which involves the hypothalamo-hypophyseal axis. At the other end of the disease spectrum, puberty may be delayed or absent. This delay can be constitutional, most common, secondary to underlying conditions, or due to hypogonadism. WA 5. Normal puberty. Definition: a phase of development between childhood and complete, functional maturation of the reproductive glands and external genitalia, adulthood, phases of pubertal changes. The age of pubertal onset may vary, but the order of changes that occur in each person is consistent. St. Adrian Archie, activation of adrenal androgen production, axillary and pubic hair, body odor and acne. St. Gonadarch, activation of reproductive glands by the pituitary hormones FSH and LH. St. Thel Archie, onset of breast development. St. Pubarch, onset of pubic hair growth. St. Menarche, onset of menstrual bleeding or anovulatory cycle. The menstrual cycle may be irregular in adolescence during the first few months/years after menarche. Immaturity of the hypothalamic pituitary gonadal axis, irregular secretion of gonadotropins, short luteal phase, and lack of progesterone. Endometrium remains in the proliferative phase. Irregular menses and heavy menstrual bleeding does not require treatment because menses become regular as hypothalamic pituitary gonadal axis matures. EC physical changes during puberty below. Physiology. St. Unknown initial trigger 7 activators and/or inhibitors of GnRH secretion. Pulsatile GnRH secretion TTFSH and 7LH secreted by the anterior pituitary gland. Stimulation of the Leydig cells and Sertoli cells in the testicles, and the theca and granulosa cells in the ovary. St. The hypothalamic pituitary gonadal axis is tightly regulated by a negative feedback mechanism. St. Testosterone inhibits further GnRH secretion from the hypothalamus. FSH-stimulated Sertoli cells also secrete inhibin, which further inhibits FSH secretion from the pituitary. Influential factors: plus general health, nutritional state, body weight. Scent genetics, scent social environment, example family stress, girls. Normal age of onset, 8 to 13 years, average 11 years, scent normal order of changes, Adrian Archie Gonadarchthel Archie, age of onset 8 to 11 years, growth spurt, age of onset 11.5 to 16.5 years, Pubarch, mean age of onset 12 years, Menarche, age of onset 10 to 16 years, mean age, 13 years, LJ2 boys. Normal age of onset, 9 to 14 years, average 13 years, asterisk normal order of changes, Adrian Archie Gonadarch, age of onset 9 to 14 years, Pubarch, mean age of onset 13.5 years, growth spurt, mean age of onset 13.5 years, androgenic hair growth. 6. The first visible sign of puberty in males is testicular enlargement, while in females it is breast development. OOIOS. Physical changes during puberty. Tanner stages. Asexual maturity rating, SMR, scale used to assess the development of secondary sexual characteristics, example breast, genital, pubic hair development, in both males and females. Tanner stages breast development, girls. Back collapse fine text outline. Physical changes during puberty. Tanner stages. Asexual maturity rating, SMR, scale used to assess the development of secondary sexual characteristics, example breast, genital, pubic hair development, in both males and females. Tanner stages breast development, girls. By prepubertal appearance and size asterisk occasional elevation of the nipple. Enlarged mammary glands form a breast bud scent slight increase in areolar diameter, nipple protrusion. Further enlargement of mammary glands breast bud extends beyond the areolar diameter. B4 nipple and areola form a secondary mound which projects above the breast tissue. He sent adult breast areola with projection of papilla only genital development, boys, G1 prepubertal appearance and size of the testes, scrotum, and penis. Scent testicular volume of 4 mlza scent larger scrotum scent penile growth has not begun scrotal skin darkens in color and texture. 3 continued enlargement of the testes and scrotum penile growth begins. Scent testicular volume of 12 mlga scrotum growth scent penile growth continues, longer and wider penis development of penis glands. G5 testes, scrotum, and penis attain adult appearance and proportions pubic hair development, boys and girls, pH1 usually no pubic hair, vellus hair possible. pH2 scent sparse, lightly pigmented hair, straight or curled, on the labia/base of the penis. pH3 scent dark, coarse, curly hair spreading over the pubic symphysis. pH4 adult pubic hair that does not extend to the inner thighs. pHS scent adult pubic hair that extends to the inner thighs with horizontal upper border. pH6 scent further growth of pubic hair along linea alba in the direction of the umbilicus. M+34. Other morphological changes during puberty IL4-LL5. Scent breast development, boys, copyright occurs approximately within 18 months of pubertal onset in males. Usually during Tanner stage 3 copyright lasts for 6 to 18 months. Copyright gynecomastia is diagnosed in a pubertal male when the palpable subareolar gland and ductal tissue is equals 2 cm, see pubertal gynecomastia. Scent growth spurt. Linear growth during adolescence is approximate 5 cm/year from 4 years of age to puberty. Varies between the sexes, generally occurs between ages 13 to 15 years, in girls, it can begin 2 years earlier. Copyright includes T growth in trunk and limbs assessed using growth velocity charts. Copyright it generally lasts 2 years, girls complete it at age 15 and boys at age 17. Bone growth accelerated during puberty determined by testosterone, estrogen, IGF-1, calcitriol, and GH. Copyright testosterone initiates and accelerates bone mineralization. Copyright order of growth, T length, T width, T mineral content, T density. Back collapse, fine text outline. Scent, body weight and composition during adolescence. Boys, initial body fat, early puberty, T lean body mass, late puberty. Copyright girls, gradual increase in body fat affected by nutritional status *, dermatological changes. 4. Copyright acne vulgaris, hyperhidrosis, and hair problems, example seborrheic dermatitis. Copyright activation of the adrenal cortex, pubertal hormonal fluctuation, T sebum secretion and excessive sweating, skin and hair changes. Myopia, due to axial growth of the eye. Scent, other physical changes associated with menarche, anemia. C3. AE. LS, psychosocial and cognitive changes during puberty. Adolescence is a time of not only pubertal physical change but also cognitive, psychological, and social development that may or may not be associated with reaching sexual maturity. Stage of adolescence: middle age, physical development, cognitive development, psychosocial development, sexuality and relationships. Preoccupation with self-esteem and increased interest in cognitive development, growing intellectual *, start of growth spurt and REAA. Body image, sexuality and sexual * 10 to 14 interests, concrete thinking, limited capacity. 2, equals early adolescence, appearance of secondary A * mood swings, orientation years. For abstract thinking, little interest in the F sexual characteristics, future * struggles with rules and desire for * growing peer identification, independence versus dependence and strong friendships. Scent, exploration of identity and lifestyles. Scent, growing interest in the future, example long term. 2 * strong orientation to peer experimentation with hobbies. 3 2 goals, F. Groups that can influence middle * 15 to 16 plus physical growth continues. 4 interests and risks, example cigarette, enhanced moral reasoning. Behavior and preferences, adolescence years boys but slows down for girls. 8 degrees, smoking, recreational drug use, sex. Scent, expanding capacity for abstract thinking and equals scent, self-exploration of sexual, increased drive to become. 7 problem-solving interests and relationships, independent, questioning of authority. * capacity for abstract and rational thought, late adolescence, degree 217 * physical maturity, end of Coutard-Vale. 2 sense, firmer sense of identity and * development of stable, early adulthood, years, physical puberty changes, independence, intimate relationships. Scent, long-term planning and goal setting. Anticipatory guidance should be offered to adolescents and their parents regarding the increased risk of morbidity and mortality due to an increase in risk-taking behavior. Sexually transmitted infections, unplanned pregnancy, eating disorders, depression, suicide, motor vehicle accidents, homicide. A healthy lifestyle and preventive measures, including the topics of balanced nutrition and physical exercise, traffic safety, example seat belt usage, bike helmet usage, safer sex practices, see counseling on safer sex practices, substance use, see primary prevention for more details. VA. OE. Precocious puberty. Definition, 9. The appearance of secondary sexual characteristics before the age of 8 years in girls and 9 years in boys. Epidemiology 110. Incidence, 1:5,000 to 1:10,000 children. Scent, 10 times more common in girls than boys. Classification. Central precocious puberty, gonadotropin-dependent precocious puberty, true precocious puberty, Sent peripheral precocious puberty, gonadotropin-independent precocious puberty, peripheral pseudo-puberty, peripheral precocity, sent isosexual precocious puberty, premature development of secondary sexual characteristics appropriate for gender, can be complete or incomplete, sent heterosexual precocious puberty, masculinization of girls or feminization of boys. Oh boys, see McCune-Albright syndrome. And Leydig cell tumors. Oh girls, see congenital adrenal hyperplasia. Sent benign pubertal variants. Back collapse fine text outline. Sent benign pubertal variants. O benign precocious Thel-Archie copyright idiopathic premature pubarch copyright idiopathic premature Adrian Archie. O benign precocious menarche sent obesity related precocious sexual development. Central precocious puberty /31L9L11. Definition. Precocious puberty with elevated GnRH levels. Etiology. Sent idiopathic, most common cause, sent CNS lesions copyright intracranial tumors, example hamartoma, glioma, craniopharyngioma, O trauma copyright infections, example encephalitis, meningitis, EO hydrocephalus sent obesity related precocious sexual development systemic conditions, tuberous sclerosis, neurofibromatosis sent radiation. Pathophysiology. Sent early activation of the hypothalamo-hypophyseal axis abnormally early initiation of pubertal changes early development of secondary sexual characteristics. Clinical features. Premature sexual development typically follows the normal pattern of puberty, except that it is early. Symmetric development of secondary sexual characteristics or, occasionally, as isolated premature Thel-Archie, Adrian Archie, or menarche. Increased growth velocity, children tend to be taller than their peers during adolescence, but are of shorter stature by the time they reach adulthood, due to early closure of the epiphyseal plate. Diagnosis. Sent laboratory tests. O serum LH and FSH, increased, O GnRH stimulation test, gold standard evaluates the reactivity of the hypothalamic pituitary axis to GnRH stimulation equals indications, suspicion of precocious puberty or delayed puberty equals method, base LH and FSH values administer GnRH blood is drawn after a certain time for re-evaluation of LH and FSH levels equals gonadotropin, LH and FSH, levels increase after intravenous administration of GnRH, O serum testosterone/estradiol. Increased sent imaging. O X-ray of the non-dominant hand and wrist, allows comparison between skeletal maturation and chronological age equals assess and confirm accelerated bone growth. Equals bone age is within 1 year of a child's age, puberty likely has not started. Equals bone age is 2 years of the child's age, puberty has been present for a year or longer. O MRI/CT of the brain with contrast, when TLH is confirmed. Equals perform in girls. Equals rule out intracranial causative pathology. Treatment. Sent GnRH agonist, example luprolide, buserelin, goserelin to prevent premature fusion of growth plates, copyright close monitoring of therapy. O follow-up is recommended every 4 to 6 months to assess progression. Manage underlying cause. Peripheral precocious puberty, 12I3-9111. Definition. Precocious puberty without elevated GnRH levels, due to 1 peripheral synthesis of or exogenous exposure to sex hormones. Back collapse fine text outline. Etiology. 7 Androgen production copyright congenital adrenal hyperplasia virilizing ovarian and adrenocortical tumors, example Sertoli-Leydig cell tumor, Leydig cell tumor, 7 Estrogen production EO McCune-Albright syndrome OHCG secreting germ cell tumors, example dysgerminomas, 7 Colonase BHCG production EC dysgerminoma OE malignant embryonal cell carcinoma copyright choriocarcinoma E primary hypothyroidism exogenous steroid use sent obesity related precocious sexual development. Clinical features may not follow the normal developmental pattern. Signs of estrogen or androgen excess may exhibit possible features of an underlying condition. Example: cafe au lait spots in McCune-Albright syndrome, testicular mass in Leydig cell tumor. Diagnosis: sent laboratory tests: O serum basal FSH and LH, decreased OGnRH. Stimulation test equals no increase in LH levels after GnRH administration. Equals precocious pseudopuberty is associated with low basal LH levels, prepubertal values. O serum testosterone/estradiol levels, increased, depending on the tumor. CA copyright TSH, T3 hormone, suspicion of hypothyroidism. O serum DHEAS and 17-hydroxyprogesterone, in cases of hyperandrogenism. Copyright corticotropin stimulation test, suspicion of congenital adrenal hyperplasia or an adrenal tumor. Sent imaging. O X-ray of the non-dominant hand and wrist, accelerated bone growth. Copyright ultrasound of the ovaries, testicles, and abdomen, cases of increased ovarian and/or uterine volume than expected. For age, diagnostic uncertainty. Treatment: precocious puberty caused by excessive hormonal production from a tumor in the body, surgical removal. Precocious puberty caused by CAH, cortisol replacement. See treatment in congenital adrenal hyperplasia, sent ovarian cysts. No intervention is necessary, spontaneous resolution is common. Copyright central precocious puberty has a central cause, example hypothalamic lesions and high GnRH levels, while peripheral precocious puberty has a peripheral cause, example germ cell tumors, without elevated GnRH levels. Benign pubertal variants, 11. Description: clinical features. Diagnosis: precocious pubarch, onset of pubic *, premature maturation of the adrenal zona reticularis, adren archi, and/or axillary hair growth. Plus premature onset of pubarch most likely due to increased sensitivity *, no plochemilial evidence of idiopathic premature of the pilosebaceous units to normal levels of androgen * isolated premature pubarch adren archi, LE, normal SCU pubarch androgen concentrations, copyright SO ES * normal bone age. Sent premature breast development, unilateral * clinical diagnosis: benign precocious * isolated breast development in girls. Uterine bleeding, can range from NW, to non-intense SRST to TTN Hananen Eurocon Danrimsnant NEESTEEA. Back collapse. Fine text outline. Trauma, infection, and sexual abuse. Uterine bleeding, can range from N7. Trauma, infection, and sexual abuse plus isolated uterine bleeding in the absence of secondary sexual isolated event to regular monthly bleeding, bona iri equals AY2 us AOE9, need to be excluded first. Menarche/vaginal bleeding characteristics * other secondary sexual characteristics are spent * normal bone age. Obesity-related precocious sexual development, 16 LL 171 I18. Sent definition: obesity is associated with early pubertal development, mainly due to obesity-related insulin resistance. This resistance leads to increased insulin and leptin levels. Sent pathophysiology. Copyright central mechanism: obesity causes increased secretion of leptin, which leads to increased GnRH pulsatility T production of gonadotropins and sex hormones. Early development of secondary sexual characteristics and early gonadarch. 1. Peripheral mechanism: obesity causes insulin resistance and compensatory hyperinsulinemia. Premature adren archi, thel archi, and pubarch. Adrenals and ovaries: T androgens equals liver, SHBG equals adipocytes, T aromatase TF bioavailability of sex steroids. WA, OE, and McCune-Albright syndrome. Definition 19. A genetic syndrome caused by a G protein activating mutation and subsequent continuous stimulation of endocrine functions. Epidemiology accounts for 5% of cases of precocious puberty, more common in females, 20 cent affects 1 in 100,000 to 1 in 1 million individuals in the general population. 20 peak incidence, early childhood etiology. Cent mosaic mutation in the GNAS1 gene on chromosome 20, autosomal recessive inheritance, copyright. Some cells have a normal version of the GNAS1 gene, while other cells have the mutated version. 10 embryos only survive if mosaicism occurs. Cent if the mutation occurs before fertilization, it affects all cells incompatible with life. Pathophysiology 21. Cent activating mutation in GNAS gene impaired G protein signaling constitutively activated adenylate cyclase excess production of CAMP. Clinical features, 19. Cent unilateral café au lait spots with unilateral, ragged edges, A** polyostotic fibrous dysplasia. Cent endocrinopathies. O peripheral precocious puberty, most common, copyright Cushing's syndrome. O acromegaly. O hyperthyroidism. Diagnostics 22-19. Cent clinical features, see above. Laboratory tests. O increased hormone levels, example estradiol, testosterone, cortisol, thyroid hormone, growth hormone, prolactin, somatomedin. C, copyright increased alkaline phosphatase. C diagnostics in fibrous dysplasia. O molecular testing, GNAS1 analysis. Cent imaging. Copyright X-rays of long bones, well-defined, lobulated lesions with a thin cortex and a radiolucent, ground glass appearance. Trademark OCT/MRI, identify fibrodysplastic lesions. O bone scan, determine the extent of bone disease. Back collapse. Fine text outline. Treatment. Cent symptomatic, treat underlying endocrinopathies. Cent estrogen synthesis inhibitors. Ketoconazole. Copyright testolectone, an aromatase inhibitor that prevents the conversion of androstenedione to estrone and testosterone to estrogen. Selective estrogen receptor modulators, example tamoxifen. Differential diagnosis. Cent neurofibromatosis type 1E fibrous dysplasia. Prognosis. Cent the condition is lethal when the mutation affects all cells, i.e., occurs before fertilization, but survivable in patients affected by mosaicism. And the 3 Ps of McCune-Albright syndrome are polyostotic fibrous dysplasia, pigmentation, café au lait spots, and precocious puberty. Oh yes. Delayed onset of puberty. Definition 231-1241. Cent absent or incomplete development of secondary sex characteristics by the age of 14 years in boys or 13 years in girls. Etiology 25. Cent physiological causes, constitutional growth delay. Pathologic causes. O hypergonadotrophic hypogonadism equals primary gonadal insufficiency, example clinical Tur syndrome, Turner syndrome, androgen insensitivity syndrome, equals secondary gonadal insufficiency, example chemotherapy, pelvic irradiation, infections, trauma/surgery, autoimmune disease. O hypogonadotrophic hypogonadism, example CNS lesions, Kallman syndrome, idiopathic hypogonadotrophic hypogonadism, Prader-Willi syndrome, Gaucher disease, copyright malnutrition, example anorexia nervosa, copyright. Chronic diseases, example inflammatory bowel disease, hypothyroidism, cystic fibrosis. Clinical features. Cent clinical features depend on the underlying condition. Cent physical examination. Copyright Tanner staging, testes. Diagnosis 25. Medical history, example positive family history of delayed onset of puberty, Tanner staging, BMI, Cent routine tests. O serum LH, FSH, and testosterone/estradiol low or normal with low testosterone/estradiol, constitutional growth delay, isolated GnRH deficiency, functional hypogonadotrophic hypogonadism, example medical illness, malnutrition, or hypothalamic pituitary disorders, example malformations, hemochromatosis, injury, tumors, -- equals elevated, primary hypogonadism. O X-ray of the Non-dominant hand and wrist equals first imaging study equals shows delayed bone age, less than the individual's chronological age, additional tests, based on suspected etiology. Degree serum prolactin level, elevated in prolactinoma, IGF-1 levels, exclude growth hormone deficiency, TSH and T, hormone, evaluate amenorrhea and hypothyroidism karyotype, Turner syndrome in girls, Klinefelter syndrome in boys, complete blood and biochemical tests, example CBC, ESR, LFT, BUN, creatinine suspected systemic disorder in children anti-endometrial antibody, screen for celiac disease in patients with signs of malabsorption abdominal ultrasound, streak ovaries in Turner syndrome, testicular mass, head MRI, suspected prolactinoma, example headaches, bitemporal hemianopia. Degree treatment 25. Scent constitutional growth delay, expectant management no treatment is needed as catch-up growth eventually occurs and the individual reaches a normal adult height. Copyright serial growth measurements at frequent intervals, every 6 months. Back collapse fine text outline. X puberty. WI. Yes. Delayed onset of puberty. Definition 231124. Scent absent or incomplete development of secondary sex characteristics by the age of 14 years in boys or 13 years in girls. Etiology 25. Plus physiological causes, constitutional growth delay scent pathologic causes OD hypergonadotropic hypogonadism equals primary gonadal insufficiency, example Klinefelter syndrome, Turner syndrome, androgen insensitivity syndrome, equals secondary gonadal insufficiency, example chemotherapy, pelvic irradiation, infections, trauma/surgery, autoimmune disease, O hypogonadotropic hypogonadism, example CNS lesions, Kallmann syndrome, idiopathic hypogonadotropic hypogonadism, Prader-Willi syndrome, Gaucher disease, copyright malnutrition, example anorexia nervosa, copyright chronic diseases, example inflammatory bowel disease, hypothyroidism, cystic fibrosis, clinical features. Scent clinical features, depend on the underlying condition physical examination copyright Tanner staging, testes. Diagnosis 25. Scent medical history, example positive family history of delayed onset of puberty, Tanner staging, BMI, scent routine tests O serum LH, FSH, and testosterone/estradiol equals low or normal with low testosterone/estradiol, constitutional growth delay, isolated GnRH deficiency, functional hypogonadotropic hypogonadism, example medical illness, malnutrition, or hypothalamic pituitary disorders, example malformations, hemochromatosis, injury, tumors, equals elevated, primary hypogonadism copyright X-ray of the non-dominant hand and wrist equals first imaging study equals shows delayed bone age, less than the individual's chronological age, sent additional tests, based on suspected etiology. Degree serum prolactin level, elevated in prolactinoma, IGF-1 levels, exclude growth hormone deficiency, TSH and T hormone, evaluate amenorrhea and hypothyroidism karyotype, Turner syndrome in girls, Klinefelter syndrome in boys, complete blood and biochemical tests, example CBC, ESR, LFT, BUN, creatinine suspected systemic disorder in children anti-endometrial antibody, screen for celiac disease in patients with signs of malabsorption abdominal ultrasound, streak ovaries in Turner syndrome, testicular mass, head MRI, suspected prolactinoma, example headaches, bitemporal hemianopia. Degree treatment, 25. Scent constitutional growth delay, expectant management no treatment is needed as catch-up growth eventually occurs and the individual reaches a normal adult height. Copyright serial growth measurements at frequent intervals, every 6 months, reassuring the child and parents is sufficient. Scent other pathologies. Treatment of the underlying disease. Hormonal therapy equals testosterone, used in boys to achieve secondary sex characteristics, example virilization, growth spurt, equals boys with constitutional growth delay usually respond well after 1 or 2 courses of testosterone therapy. If little or no response is seen, isolated GnRH deficiency should be suspected in boys over the age of 18 years. Equals estradiol, used in girls with primary gonadal insufficiency, example Turner syndrome, equals initially, low-dose estradiol that is gradually increased after 2 years, add cyclic progestin therapy to induce menstruation. Back collapse. Fine text outline. Europuberty, 1/1. Tanner stages VV. Copyright Boss. Europuberty, 1/1. Suspected precocious puberty at .g, resexual CH. Wrist and hand X-ray. Isolated AUF premature advanced bone age normal bone age LRG re-ease. 1 year difference between measure LH plus basal LHOLL LH. GnRH stimulation 7 LH secretion me/LH secretion. GnRH dependent GnRH independent, central, precocious, peripheral, puberty precocious puberty. Premature Adrian Archie, Evenelant Bell Archie, Pivart without VAS-gonadal maturity, Menard, EAS spermaceae, plus signs of NA hyperinsulinism. T+. Yes. Cranial MRI boys girls. Inconclusive conclusive. Cisexual isosexual heterosexual, secondary sexual polio secondary sexual, virilizing features such as eye characteristics appropriate yucca as bal bentia, characteristics appropriate hirsutism and/or VS no for gender, oi for gender, clitomegaly. V obesity HJ plus latex cell tumor, obesity FIA plus hypothalamic tumor yaig feminize autonomous functional J feminize and A toate, aerial SE other CNS tumors at UCG secreting a more omerantile more ovarian cyst plus congenital adrenal source F central, idiopathic, centra, e.g. hamartoma, adrenocortical tumors PE copyright Ovanan Weiner's hyperplasia Benpalal precocious puberty hydrocephalus congenital adrenal plus exogenous estrogen McCune Albright adrenocortical tumors precocious puberty hyperplasia indrain plus virilizing ovarian tumors puberty degree exogenous androgens plus exogenous androgens familial testotoxicosis. E-hormonal analysis, TEAS, testosterone, beta-HCG, 17O progesterone, progesterone, estradiol, E-abdominopelvic imaging. Imaging. Diagnosis of precocious puberty VB. Copyright Boss. Equals puberty, 1/3. Café au lait spot VB. There is a flat, hyperpigmented, irregularly shaped macule visible on the patient's forearm. These macules are also known as café au lait spots. Unilateral café au lait spots in patients with precocious onset of puberty suggest McCune-Albright syndrome. Source, Café au lait flag, Denise Nepronic, Wikimedia Commons licensed under public domain. Equals puberty, 2/3. McCune-Albright syndrome VB. Photograph of the torso of a 5-year-old girl. Multiple large, hyperpigmented lesions, café au lait spots, can be seen on the face, the left hemithorax, and the left arm. Left arm. The borders of the lesions are jagged, post of main appearance, and barely cross the midline. Café au lait spots are characteristic findings in McCune-Albright syndrome. Copyright Boss. This image was adapted from the image figure 1A, in McCune-Albright syndrome by Dumitrescu CE, Collins MT, Orphanet Journal of Rare Diseases, licensed under CC by 2.0. Overlay. Fibrous dysplasia in McCune-Albright syndrome (VB). X-ray calcaneus, lateral view, a mixed density lesion, green overlay, with ground glass and sclerotic components is present in the body of the calcaneus extending to the articular surface of the subtalar joint. The calcaneus is a rare location for fibrous dysplasia. The appearance suggests fibrous dysplasia in a patient with McCune-Albright syndrome. Source: Fibroes dysplasia calcaneus 21 Rose Seidlich, 001.jpg by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Overlay. Fibrous dysplasia in McCune-Albright syndrome (VB). X-ray calcaneus, lateral view, a mixed density lesion, green overlay, with ground glass and sclerotic components is present in the body of the calcaneus extending to the articular surface of the subtalar joint. The calcaneus is a rare location for fibrous dysplasia. The appearance suggests fibrous dysplasia in a patient with McCune-Albright syndrome. Source: Fibroes dysplasia calcaneus 21 Rose Seidlich, 001.jpg by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. X. Child maltreatment. Child maltreatment consists of any act or failure to act by a parent or caretaker resulting in any potential or overt physical or psychological harm, sexual abuse, or exploitation, or death of a child. Up to 25% of American children experience some form of child maltreatment. Major risk factors include the following: less than 4 years of age, caregiver, S, with substance use disorders, and intimate partner violence in the household. The most common form of child maltreatment is neglect, followed by physical abuse, sexual abuse, psychological maltreatment, and medical neglect. Common clinical presentations of child maltreatment include growth retardation and developmental delays secondary to neglect, trauma inconsistent with history or developmental stage secondary to physical abuse, STDs, pregnancy, and genitourinary complaints secondary to sexual abuse. When the differential diagnosis includes child maltreatment, the first diagnostic step is a thorough history and physical exam. Ophthalmologic exam and a skeletal survey should also be performed if appropriate. Management includes medical stabilization if necessary and immediately reporting any suspected child maltreatment to Child Protective Services, CPS. Laws vary by state but typically designate physicians as mandatory reporters. Because more than 1,600 children die each year from child maltreatment, it is essential to have a high index of suspicion and a low threshold for reporting. OO and Overview. Scent definition: any act or failure to act by a parent or other caregiver that results in harm, potential for harm, or threat of harm to a child. Scent epidemiology. Copyright incidence: 683,000 children/year, 2015. Copyright: up to 25% of American children experience some form of child maltreatment. Scent risk factors. Copyright perpetrator factors: alcoholism, drug abuse, and/or mental health issues, example depression, equals low education equals unemployment, financial hardship, personal history of abuse during childhood equals domestic violence. Copyright child factors equals age. Scent classification. Copyright child neglect. O physical abuse. O sexual abuse. Copyright psychological maltreatment. O medical neglect management. Copyright always notify Child Protective Services. Copyright interview child and parent/caregiver separately if possible. O keep verbatim record. Admit to hospital for medical stabilization if required. Document in detail the characteristics, location, size, shape, color, nature, of the lesion. S. Perform an ophthalmologic exam and skeletal survey if appropriate. Degree. Suspect child maltreatment if one or several of the following apply: the presence of risk factors, history does not fit clinical findings or pattern of behavior for child at age, the story continually changes, delay in seeking medical treatment, highly suspicious injuries. It is essential to have a high index of suspicion and a low threshold for reporting. References Lil 2 Isolalizitel. 7. CES. Child neglect. Scent definition: failure to meet a child's basic physical, emotional, medical, or educational needs. Etiology: failure to provide appropriate food, clothing, or shelter. Copyright: poor supervision and protection from potential harm. Copyright: denying emotional support and social interaction. Copyright: avoiding medical treatment when required. Example: physical injuries. Copyright: failure to enroll a child in school or homeschooling. Copyright: absent preventative care measures. Example: necessary vaccinations. Scent clinical features: neonates equals apnea, back collapse. Find text outline. Scent clinical features: neonates apnea equals irritability, feeding intolerance, failure to thrive equals seizures. Copyright: older children, abnormal language, social, and / or emotional development equals absence of fundamental trust towards others equals reactive attachment disorder, disinhibited social engagement disorder, social attachment to strangers without inhibition, due to emotional neglect during infancy equals poor overall appearance and clothing. Prognosis: long-term, 6 months. And / or severe neglect during infancy may result in irreversible personality changes and even death. Copyright: child neglect is the most common form of child maltreatment. References: /IL 4271 I8. FO. And. Physical abuse. Scent definition: non-accidental injury caused to a child. Scent epidemiology. Copyright: 40% of deaths occur in children. Etiology: burns. Example: scalds, sharply delineated patterns, multiple burns of different ages and localizations. Copyright: inflicted head trauma. Example: shaken baby syndrome. See below. Battered child syndrome. Injuries showing different states of healing in a child, resulting from long-term physical violence. X-rays may show different stages of bone healing. Equals ligature marks. Types of pediatric injuries: injuries suspicious, unsuspicious, contusions or other injuries involving the copyright upper head / forehead, cheeks, ears, eyes. Example: retinal hemorrhages. Copyright buttocks. Copyright posterior side of the extremities * stress fractures. Copyright back * contusions or other injuries involving upper arms and / or chest. Copyright lower head, nose localization plus metaphysiary and epiphysiary corner fractures. 1. Copyright front of the extremities. Scent femur fracture in non-ambulatory child. Copyright knees, elbows, hands * posterior rib fractures. Scent linear and solitary skull fractures, with a narrow fracture gap plus multiple or complicated skull fractures * long bone fractures that fit the incident. Copyright incomplete fractures, green stick or torus fractures. J. Copyright several skull bones affected. Copyright large fracture gap. Pat * evenealstabid. Unevenly distributed. Say scent multiple injuries of different ages and localizations. SF. Q at suspicious bruises, 10 for torso, ear, neck, any bruise in these locations in children. 07, 10, 11, 12 references. A 7. CE. Lee shaken baby syndrome. Back collapse. Find text outline. Lee shaken baby syndrome. Scent definition: head trauma through strong rotational and shearing force plus epidemiology, high mortality and a significant cause of death. 1. Scent etiology: violent shaking of a child plus pathophysiology. 75 pounds. Copyright rotational and shearing forces, shearing off of bridging veins, subdural hematoma. Copyright shaking of the child with a weak neck support, respiratory problems and apnea, hypoxia, brain edema and ischemia, diffuse axonal damage. Scent clinical findings: degree inconsistent or implausible history from caretakers. Injuries are hardly evident or entirely absent on physical exam. Retinal hemorrhages, irritability or lethargy, seizures, vomiting. Degree long-term, sight, hearing, and speech impairment, massive neurological deficits. Degree associated injuries. Equals rib fractures equals visceral injuries, example liver laceration, visceral hematoma, equals see also battered child syndrome. Scent diagnostics EO non-contrast CT equals subdural hematomas and / or subarachnoid hemorrhage of varying ages equals reversal sign, diffuse blurring of the gray-white matter interface equals diffuse punctate hemorrhages, variable localization, but most often interhemispheric degree skeletal survey OMRI, if CT findings are abnormal, or in asymptomatic children with non-cranial injuries. Approximate 25% of children who suffer abusive head trauma die. References, 14 IL 15 I 161 L 171. 44 No. F.O. Sharmana. Lee Scalds. Overview of Scalds characteristics abuse, immersion of the child. Accidental copyright. Asterisk clearly delineated from healthy skin asterisk no clear delineation 3 asterisk symmetrical lesions asymmetrical lesions. Injury depth equals _ similar injury depth in all areas sent differing injury depth. No marks from spills of water when immersing solitary body parts * third-degree burns on the back, buttocks, and thighs sparing of flexor surfaces suggestive patterns copyright zebra pattern scent splash marks scald marks equals stripes of spared skin surrounded by burn tissue scent typical marks left by spills of water in recesses, example arrow equals occurs in areas of flexion that are bent when the body gets in contact with the hot liquid like marks in the chest area, copyright donut pattern, when the child is immersed in a tub with hot water, the skin in direct contact with the tub is spared, with burn tissue surrounding it. Copyright stocking or glove pattern, symmetrical burns in extremities with a clear line of delimitation between burnt and normal tissue. Uneven scalding extremities * scalding by immersion, scalding, sock-like, of the entire foot / of the entire hand modeled scalding. Scalding does not characteristically affect the hair and eyelashes. Singed hair and eyelashes imply direct exposure to flames. Al. Collapse fine text outline. TS mimics of physical child abuse. Feature. Bruises. Scalding and burns. Fractures. Head trauma. WA. 00 Nota 2 shared N. Sexual abuse. Findings that may mimic physical child abuse presentation in child abuse. Reflect the shape of the instrument used for beating, example streaks the width of a belt, typically located on the back or torso. No splash marks burns, most commonly third degree, on the back, buttocks, and / or thighs flexor surfaces are usually spared. Socks and gloves pattern if extremities have been immersed in hot water punctate burns from cigarettes. Metaphyseal and epiphyseal corner fractures, bucket fractures, J-rib fractures, especially posterior, indicates squeezing, spiral fractures, common in femur and humerus, incomplete fractures. Multiple or complicated skull fractures involvement of several skull bones large fracture gap associated features copyright intracranial hemorrhages degree decreased consciousness copyright seizures degree retinal hemorrhages. PION in PIES and congenital dermal melanocytosis A copyright no characteristic changes in color over time copyright most commonly seen in African American, Hispanic, or Asian populations vasculitis, example Haynock-Sconline purpura palpable purpura M coagulopathies and vitamin K deficiency, history of bleeding from other sites, example from venipunctures, nasal bleeding, hemarthrosis. Alternative medicine, example cupping, coining, mustard plaster application burns resemble the shape of the heated object applied to the skin a staphylococcal scalded skin syndrome a degree follows a local infection copyright accompanied by fever severe contact dermatitis O follows exposure to allergens copyright accompanied by pruritus. Stress fractures typically occur in children and adolescents participating in competitive sports. Osteogenesis imperfecta. Copyright pathological fractures. Copyright bruising. Copyright excessive bleeding. Blue sclerae law. Copyright opalescent teeth. Copyright hearing loss. Accidental head trauma, linear and solitary skull fractures, with a narrow fracture gap. Intracranial hemorrhage. In the following conditions, copyright Menkes disease, abnormally wiry or brittle hair, hypopigmented skin and hair, decreased copper and ceruloplasmin levels. Copyright coagulopathies and vitamin K deficiency, history of bleeding from other sites, example from venipunctures, nasal bleeding, hemarthrosis. Copyright arteriovenous malformations. Scent definition, involvement of a child in sexual activity with an adult or an older child plus epidemiology. Peak incidence, 9 to 12 years of age. The perpetrator is usually male and known to the child. Copyright 8.5% of all victimized children. Etiology. Copyright sexual intercourse, oral, anal, or vaginal penetration, molestation, genital contact without penetration, exposure to a perpetrator's genitalia, forced sexual interaction with another child or object, exposure to explicit material. Scent clinical features. Copyright often no visible signs on physical examination, behavior or sexual insights which are inconsistent with age. Copyright injuries in the genital, anal, and oral areas, recurrent urinary tract infections. Signs and symptoms of sexually transmitted diseases. Pregnancies. Scent differential diagnosis, foreign objects in girls. Scent diagnostics. Suspicious STDs beyond the neonatal period. Gonorrhea equals chlamydia trachomatis infection, 1, equals herpes infection. Back collapse. Fine text. Outline. Etiology. Copyright sexual intercourse, oral, anal, or vaginal penetration, molestation, genital contact without penetration, exposure to a perpetrator's genitalia, forced sexual interaction with another child or object. Copyright exposure to explicit material. Scent clinical features. Copyright often no visible signs on physical examination. Copyright behavior or sexual insights which are inconsistent with age. Copyright injuries in the genital, anal, and oral areas. Copyright recurrent urinary tract infections. Copyright signs and symptoms of sexually transmitted diseases. Pregnancies. Scent differential diagnosis, foreign objects in girls. Scent diagnostics. Copyright suspicious STDs beyond the neonatal period equals gonorrhea equals chlamydia trachomatis infection, 1 equals herpes infection equals syphilis equals non-transfusion, perinatally acquired HIV. Copyright test for STDs ideally within 72 hours of the assault. Copyright even in the absence of physical signs. Sexual abuse should always be considered in young children presenting with behavioral changes or signs of sexually transmitted diseases. References, SIL 4LL 18L 190-1120. OC and psychological maltreatment. Scent definition, actions and behaviors from parents or caregivers that have a negative mental impact on the child. Scent epidemiology, approximate 80% of survivors fit the criteria for at least one psychiatric condition by the age of 21. Scent etiology. Name calling, insulting, intimidation, or threats of violence. Copyright allowing the child to see abuse being inflicted on another, example partner abusing the mother. Clinical features. Copyright children or babies seem to attach more to random adults rather than to their primary caregiver. Aggression towards other children or animals. Copyright overly distressed. Frequent tantrums, in older children. Copyright complaining about somatic symptoms with no identifiable medical cause. References. CES. Medical abuse. Scent definition, consists of providing non-required and potentially harmful medical care to a child, as a result of fabrication or exaggeration of symptoms by parents or caregivers. See Munchausen syndrome by proxy. Scent etiology. Administering inappropriate drug therapy or other agents to induce symptoms. Copyright simulating disease, example contaminating body urine specimens. References 21. Y. CES. Sources. Last updated June 14, 2023. Back collapse, fine text outline. Bruises fan. A. Suspect abuse MW, often accident. Bruise location suspicious for child abuse VV. The diagram, top left, shows common locations of bruising in children typical for abuse, blue, and often caused by accidents, green. The photographs show examples of bruises at locations suspicious for abuse, including the auricle, upper right, genital area, lower left, buttocks, lower middle, and back, lower right. Source, Figure 2, in Physical child abuse demands increased awareness during health and socio-economic crises like COVID-19, a review and education material by Martinkiewicz P., Larson LL, Grieshold-Knudsen T., ETAL, Acta Orthopedica, licensed under CC by 4.0. Further notes, image is part of the supplementary data of the paper. Hen. Retinal subdural intra/extracranial complex hemorrhage hematoma/hygroma lesions skull fracture. Skull fracture. Transverse classic femoral fracture lesio. 3-month-old infant eye bruises. At. Do not hesitate. Abdominal bruises plus elevated alt, report your -ABD. Plus pelvic CT suspicion to the local child protection pelvic fracture team. ML suspect abuse, it may save a life. BB often accident. Findings in physical child abuse. Source, Figure 3, in Locations of Bruises Suspicious of Physical Abuse in Children by Paulina Martinkiewicz, Lisa Lang-Eland Larson, Troels Grieshold-Knudsen, Gid Hesthaven, Michelle Bach-Helfritzsch, Karen Kastberg-Peterson, Bjarne Möller-Madsen and Jandwidel Rolfing, Acta Orthopedica, licensed under CC by 4.0. Mechanism of injury resulting injury. Shearing forces on vessels and axons, diffuse axonal damage, diffuse brain edema, jarring of the brain against the skull. Neck hyperflexion and hyperextension, retinal hemorrhage, rib compression, subdural hematoma. Rib fractures. Shaken baby syndrome BB. Copyright on Boss. Tub immersion of hands or feet, Weemy AIZY SIRS SA equals AM, I. Skin in direct contact with the tub is spared. Equals is. Areas of flexion NAR / are spared TJKJ. Slash. Immersion demarcation line, zebra pattern. Symmetrical donut pattern, lesion stocking or glove pattern. Child maltreatment, immersion scald injuries. Copyright on Boss. Child maltreatment, 2 halves. Second-degree scalding injury, 2B, deep partial thickness burn, after initial debridement BB. Photograph of the torso, left shoulder, and neck. There are extensive, irregular areas of burn injury with varying wound depth and poorly defined margins. The mottled red/white coloration indicates a deep partial thickness burn with damage extending down to the deeper layers of the dermis. The irregular pattern of the burn suggests accidental injury. Source, Figure 3, in Retrospective Evaluation of Progenitor Biological Bandage Use, a complementary and safe therapeutic management option for prevention of hypertrophic scarring in pediatric burn care by Aldurobi K., Laron A., Degaly L., ETAL, MDPI Pharmaceuticals, licensed under CC by 4.0. Modifications, image cropped, number removed. Child maltreatment, 1/7. Congenital dermal melanocytosis, Mongolian spot. A 5 cm, blue-gray macula with irregular borders is visible on the back. The macula has no evidence of hypertrichosis. Copyright on Boss. Child maltreatment, 2/7. Purpura in IgA vasculitis VV. Maculopapular, reddish, non-blenching, palpable skin lesions, purpura, are seen on both the distal right arm and leg. On the lower leg, the lesions are partially confluent and present with scaling and erosion. Source: Purpura 2, Okwikakim, Wikimedia Commons licensed under public domain. Cupping marks VV. Circular bruises caused by dry cupping. The shape of the lesions reflects the position and shape of cups applied to the skin. Such lesions should be differentiated from burns resulting from abuse, especially in children. Source: Cupping results.jpg by Bentaf, Wikimedia Commons, licensed under CC by SA 3.0. Staphylococcal scalded skin syndrome, SSSS, VV. There is diffuse erythema of all visible skin. Large ruptured blisters are visible on the left lower leg, and a large flaccid unruptured blister can be seen on the left buttock. Source: Figure 1, in Staphylococcal scalded skin syndrome in neonate by K. Kauka, M. E. Daingai, K. Cassie, case reports in Dermatological Medicine, licensed under CC by 3.0. Urushiol-induced contact dermatitis VV. An erythematous rash with numerous small vesicles in a linear pattern can be seen on the left forearm. This rash is typical of mild allergic contact dermatitis caused by urushiol-containing plants, example poison oak. In more severe cases, bullae and pronounced edema may be present. Source: 4484, CDC, Centers for Disease Control and Prevention, Atlanta, USA, licensed under public domain. Overlay. Olecranon stress fracture VV. X-ray right elbow, A, AP view, B, lateral view, and CT right elbow, C, frontal plane, D, sagittal plane, of a 16-year-old baseball pitcher with progressive posterior elbow pain. No fracture is visible on the AP radiograph, however, a subtle irregular line, green arrows, projecting over trabecular bone on the lateral view raises the possibility of a fracture. CT images reveal a non-displaced oblique fracture through the midthird of the olecranon, white arrows. Stress fractures may be very subtle or not visible at all on radiographs. Additional imaging is warranted when clinical findings suggest injury, but radiographs are equivocal or negative. CT, MRI, and bone scintigraphy have been used to further evaluate stress fractures. Source: Fig. 1, in Treatment of stress fracture of the olecranon in throwing athletes with internal fixation through a small incision by Fujioka H., Tsunemi K., Takagi Y., Tanaka J., BMC Sports Science, Medicine, and Rehabilitation, licensed under CC by 2.0. Modifications: letter markers removed. Scleral manifestations of osteogenesis imperfecta VV. The sclerae show a distinct blue-gray tint. Source: Picture 2 in, These three teenaged girls had the same disease by Herbert L. Fred MD and Hendrik A. van Dijk, OpenStax, licensed under CC by SA 3.0. X. Child development and milestones. Early childhood, which typically spans from birth to 8 years of age, is characterized by rapid growth and development. Close monitoring during this period ensures children are meeting age-specific milestones and that deviations from expected developmental trajectories are quickly identified. Developmental delays affect 15% of children and can impact more than one domain, i.e., physical, language, cognitive, and social and emotional development. Early identification and treatment can improve outcomes. Developmental milestones are an important component used to track a child's progress over time and provide a framework by establishing a set of skills or behaviors that most children are expected to achieve by a certain age. A child's development should be assessed at every well-child visit and whenever there is a concern for abnormal development. For children who are not meeting their milestones, An evaluation of abnormal pediatric development and relevant referrals are indicated. See well child visits for more information on routine health assessments. For information on growth below the expected parameters for age, see growth faltering. V7 RO IEEE Overview of normal development. Normal development in childhood involves the evolution and resolution of primitive reflexes, and the sequential development of motor, language, cognitive and social skills, tracked using developmental milestones. Throughout childhood, various behaviors, example stranger anxiety, magical thinking, imaginary companions, may also be temporarily observed and are part of normal development. Caregivers should be reassured that these behaviors will resolve as children age. VA and one's primitive reflexes. General principles. 1. Plus primitive reflexes are transient reflexes that manifest during infancy and disappear when subcortical motor inhibitory pathways develop, usually within the 1 T year of life. A scent evaluation of primitive reflexes is an essential part of the newborn examination. Abnormal primitive reflexes are those that are absent, asymmetric, and/or persist past the expected age range. O bilateral absence or prolonged reflexes, most commonly CNS dysfunction. 1. Copyright unilaterally absent or asymmetric reflexes are usually caused by one of the following. 2. Peripheral nerve dysfunction, example brachial plexus injuries, equals musculoskeletal involvement, example neonatal clavicle fracture, equals unilateral CNS injury, example perinatal brain injury. At multiple primitive reflexes in adults, i.e., frontal release signs, indicate frontal lobe dysfunction. 3I4 Overview of primitive reflexes. Overview of primitive reflexes. SLL6 reflex description. Typical age range 5. Clinical significance. Glabellar tap sign 41 plus. Tapping the glabella elicits blinking. Asterisk birth 6 months. Asterisk clinical significance unknown. Snout reflex 4. Applying light pressure to closed lips causes the lips to pucker. Copyright birth 4 months. 7. Stroking the cheek causes the mouth to open and the head to turn. 24 weeks gestation 4 towards the stimulus. Month C251 rooting reflex required for newborn feeding. 81 touching the lips and/or oral palate elicits sucking of the early in utero. -3 months. 1 sucking reflexes. Stimulus 5. When the infant is lying supine, turning the head to one side elicits asymmetrical tonic. ERAIA extension of the ipsilateral extremities and flexion of the neck reflex. ATNR, POM contralateral extremities, fencing posture. Equals birth 7 months. Phylel affects rolling. Protective reflex to grasp mother when falling. 0, when the infant experiences a loud noise or sudden movement. Moro reflex, startle they abduct and extend their arms and fingers before bringing. 2 weeks gestation 6 plus may be unilaterally reduced or absent in infants with reflex. IRSMTGERSTHIAM a months. 5 ipsilateral brachial plexus injuries or neonatal clavicle M back to midline. Fracture. No clinical significance, evolutionary remnant 7 and 0, may be unilaterally reduced or absent in infants with pressing or placing something into the infant's palm causes the 32 weeks gestation. 4 palmar grasp reflex of fingers to flex towards the palm. Months 51 5 ipsilateral brachial plexus injuries. Phi. Pressing the infant's sole beneath the toes causes their toes to 32 weeks gestation. 12 plantar grasp reflex F. No clinical significance, evolutionary remnant, 10 S's SH flex towards the sole. Months 1. Back collapse. Fine text outline. Birth 12 months, may be a normal finding up to 24, 51 11 12, stroking the sole of the foot upwards elicits dorsiflexion of the big extensor plantar reflex, Babinski reflex, toe and fanning of the other toes. 2 months. When the infant is held prone in the air, the head raises, the back arches, and the legs extend. When the head is flexed downwards, the legs will also flex downwards. Landor reflex 3 to 24 months 51. When the infant is held prone in the air, lowering the infant towards a flat surface causes the arms and the hands to reach towards the surface. Parachute reflex 7 months throughout life 5. When the infant is held prone in the air, stroking the paravertebral region causes the lower back and hip to curve inwards on the same side. Law. Truncal incurvation reflex, Gallant reflex, 14 birth 4 months a 14-15. Holding the infant upright in a standing position elicits a walking motion, with alternating flexion and extension of the legs. Stepping reflex 16 birth 3 months 16. And S. GK developmental milestones. General principles, 71. Developmental milestones are the expected abilities that most children can do by a defined age and are, copyright divided into physical, cognitive, social, and emotional domains continuously progressing as the child ages adjusted to compensate for prematurity in infants. Clinical significance unknown. A positive Babinski sign at 24 months of age is a sign of an upper motor lesion. 3. Aids in core strength and is required to roll from supine to prone. 13 Infants with hypotonia will have a weak Landor reflex, example hang in an inverted U shape, while those with hypertonia will remain stiff and resist head flexion. 11. Asterisk protective reflex when falling. 6. Absence may suggest neuromotor deficit. 6. Clinical significance unknown. Abnormal development occurs when children fail to attain developmental milestone, S, by the expected age and/or in the expected order. Copyright 15% of children have developmental delay. 18 Copyright common etiologies include neurodevelopmental disorders. 19 Neurologic injury equals parental neglect. 1. Developmental domains. 5. Scent motor development. Gross motor development, the development of movements, example sitting up, walking, that require the use of large muscle groups. Fine motor development, the development of precise movements using hands and smaller muscles, example picking up a small object. Language development, the development of communication through either spoken or signed language. Receptive language, the ability to understand and process language. Expressive language, the ability to formulate language. Cognitive development, the development of reasoning and problem-solving skills. And social and emotional development, the development of self-regulation and attachment and interaction with others. Age-specific developmental milestones. Asterisk in 2022, the CDC recommended using the 75th percentile rather than the 50th percentile for developmental surveillance. The following tables reflect this change. 20, 21. If ACLD is not meeting milestones, conduct an immediate evaluation of abnormal pediatric development. 2022. Add, a wait-and-see approach is no longer recommended for potential developmental delay. 2° L22. Developmental milestones in infants. 2° LL21. Overview of developmental milestones in infants, 2021. Motor development. Speech development. Asterisk gross motor. When prone, raises head up. Moves all extremities equally in addition to crying, makes other sounds. 2 months. 4. Asterisk reacts to startling noises. Cognitive and social development. Asterisk social smile. 4. Asterisk calms down when held or spoken to plus focuses on a face or toy. Asterisk Rico ana is Skaria Ivers, Q. Find text. Al. Outline. Nadadgavayopment and moose tones. Developmental milestones in infants, 2° LL21. Overview of developmental milestones in infants, 20F21. Motor development. Speech development. Cognitive and social development. Social smile. I calms down when held or spoken to. Asterisk gross motor. When prone, raises head up in addition to crying, makes other sounds 2 months. Copyright moves all extremities equally. * reacts to startling noises. Rocuses onitus ortoi. * recognizes caregivers, _ fine motor, hands are not always fisted, 1 cent eyes track caregiver, without crossing midline. * gross motor. Copyright good head contro. May still bob. Attempts to gain the attention of others. Aec * coos, i.e., makes vowel sounds, scent chuckles when prone, uses forearms to prop self up, 4 months. Scent vocalizes when being spoken to. Interested in hands. Copyright brings hands to midline. Fa. Oe * orients to sound 1 cent when breast or bottle is visible, opens mouth to express degree. Swats at toys. Hunger scent fine motor, holds a toy when placed in the palm. Scent laughs * gross motor * recognizes familiar individuals. Copyright rolls from front to back -151 I20, Warnani ie * enjoys looking in the mirror 6 months. FL * squeals. Copyright when prone, uses hands to prop self up with straight arms. Reaches for desired objects. Blows raspberries. Copyright sits in tripod position 229, shows disinterest in food if not hungry. Explores objects with mouth. B. Stranger anxiety orients to name. Gross motor, independently gets into a steady seated position. Fine motor has a range of facial expressions. Repetitive babbling, repeats consonant 9 months. Copyright transfers objects from one hand to the other, voluntary sounds. 1 palmar grasp, raises arms. Express desire to be picked up. Enjoys playing peekaboo. 1 develops object permanence, e.g., copyright looks for an object out of view. Degree raking. Grasp ig grasp / copyright separation anxiety. Bangs to 2 objects together. Gross motor. Copyright pulls self to a stand. Copyright cruises. Copyright drinks from an open cup with assistance. Waves goodbye. Pauses or stops when told no. Engages in interactive games. 1 places an object in a container. Looks for objects after they are hidden. 12 months specifies mama / Scent fine motor, pincer grasp. 20. Children, including twin siblings, develop at different speeds and one child's milestones should not be used to evaluate another child's development. LE27. Developmental milestones in childhood 2 degree LL21. 2021 Overview of PPI in Child 1 to 5 years age. Motor development, speech development, cognate and social. Shares interests with others. Protooperative pointing, imitates actions. Swerhes * gross motor, takes a few independent steps. * says one specific word in addition to mama / _ attempts to use objects correctly. Fine motor, brings food to mouth with fingers / hands. _ follows one-step verbal commands with prompting. _ claps to express excitement. * glances at a familiar object when mentioned. * demonstrates affection. 1 * stack 2 objects. * gross motor IEJ, walks unassisted. SAS * proto-declarative pointing, indicates joint attention. Copyright glimpse on furniture. Independent. * tentatively moves away from caregiver. Fa 48 Fe * fine motor. * 3 specific words in addition to mama / dada. * assists with self-care routines. * my copyright scribbles. * follows one-step verbal commands without prompting. * looks at a book for short periods of time. Copyright drinks from an open cup independently. * imitates household chores. C degree. Independently feeds self with fingers / hands. No * plays correctly with simple toys. C2 utensils, copyright attempts feeding with spoon. * gross motor plus pomstonomy donjex ci. Shares in the emotions of others. A degree runs equals plus in new situations, looks at the caregiver's face to scent. Combines 2 words together. 377 Copyright independently goes up the stairs with both feet. 23 Guide reactions. 2 years scent. Half of speech, 50%, is understood by strangers. 23 On each step. Copyright kicks ball independently, uses both hands to manipulate an object. In addition to waving and pointing, uses gestures to attempts to use complex toys. OA, fine motor, feeds self with spoon. Communicate. One plays with more than one toy at a time. Back collapse. Find text outline. 2.5 years, 30 months. 3 years. 4 years. 5 years. 410. Gross motor, jumps with 2 feet off the ground. Fine motor. OE removes some clothing. Copyright twists wrist to open things. Copyright turns single pages of a book. Gross motor, can independently put on some clothes. Fine motor. Copyright can string large items. 1 degree. Uses a fork. Gross motor, catches a big ball. Fine motor. E can undo buttons. Copyright tripod pencil grasp. Asterisk. Gross motor, hops on a single foot. Asterisk. Fine motor, fastens buttons. Common developmental behaviors. Says 50 words. Makes a 2-word sentence, noun plus verb, names objects when pointed to. Uses personal pronouns a, 20. When asked, can say their first name. Uses question words. See correctly. Names actions in a picture, converses back and forth at least 2 times. Most of speech, 75%, is understood by strangers. 23. Makes 4-word sentences. Describes at least one event from the day. Can repeat some words from a story or rhyme correctly. States the purpose of objects. Tells stories. Answers simple questions about a short story. Converses back and forth at least 3 times. Rhymes simple words. All of speech, 100%, is understood by strangers. 23. Parallel play. Picks up toys after playing. Requests a caregiver watch them do something. Follows simple routines. Early pretend play with objects. Problem solves to obtain desired objects. 1 follows 2-step commands, points to 1 color correctly. Resolving separation anxiety. Engages in cooperative play with other children. Copies a circle when demonstrated. Avoids dangers when warned. 4. Asks to play with children even if not present. Likes being assigned a role or task. 1 appropriately comforts others. Moderates behavior in different settings. Avoids dangers without a warning. Imaginative pretend play, example dress up. 5 names a few colors. Repeats parts of a well-known story. Draws a person with 3 body parts. Understands rules and taking turns. Performs for caregivers. Can perform simple chores. Can count to 10. Names some letters and numbers, example 1 to 5. Writes some letters from their name. Developing a concept of time. Attention span of 5 to 10 minutes, excluding screen time. Certain temporary pediatric behaviors are considered normal parts of cognitive, imaginative, and creative development, e.g. sense stranger anxiety, when an infant is fearful of unknown individuals. Copyright expected ages, 6 months 3 years 24. Copyright clinical features, crying and / or clinging to a known caregiver when around strangers. Sense separation anxiety, when an infant or young child is afraid of being separated from their caregiver. Expected ages, peaks between 9 and 18 months and resolves by 3 years of age. 25 Copyright clinical features. Equals crying and / or clinging to a caregiver if the caregiver tries to leave. Equals continued crying after a caregiver has left. Scent pretend play, when a young child imitates adult activities and / or interactions. 26. Expected ages, starts around 15 to 18 months. Examples. Equals the use of real or toy items to imitate activities. Equals symbolic play, the use of an item to represent other things. Copyright benefits, enhances creativity and provides practice for social skills, emotional regulation, and language development. 5. Scent magical thinking, when thoughts are believed to affect change and non-related events are causally linked. Tells. Expected ages, 4-5 years. Equals decreases with age. Some persistence into adulthood may occur, 5 to 71. 5. Examples. Equals assuming their actions cause unrelated events. Equals attributing emotions to an inanimate object. 1 equals believing that wishing for something causes it to come true. Scent imaginary companion, when a fictitious human, animal, or object is treated as if it were alive. Copyright expected ages. Preschool and young school-aged children copyright benefits are similar to those of pretend play. 28. 7. Oh. Back. 28. 28. Collapse fine text. AO. Outline. Common reactions to specific life events. Arrival of a sibling 291-1301. Sent. The arrival of a sibling can pose significant stress to a child, who may react with negative emotions, example jealousy, anxiety, resentment, anger, and changes in behavior. Further typical reactions include, regression, psychiatry, equals bedwetting in a toilet, trained child equals finger or thumb sucking equals demanding help with eating, wanting to drink from baby's bottle and / or wanting to breastfeed equals speaking like a baby, changes in sleeping pattern, copyright violent behavior towards the sibling and / or caregivers, example hitting, biting. Sent. Counsel caregivers about the older child's possible reactions and advise them to, copyright avoid other major changes at the same time as the anticipated arrival, example moving houses, starting new kindergarten. Copyright organize caregiving support from other family and friends. Spend alone time with the older child after the baby's arrival. Encourage the older child to take part in the caretaking of their sibling and praise them for doing so. Acknowledge the older child's negative emotions and reinforce their importance and sense of security. Understanding of death 31. Sent. Child's understanding of death depends strongly on their developmental age, personal experiences, and parental communication about death, including parents' spiritual and religious beliefs. An adult understanding of death involves the comprehension of the following concepts: copyright irreversibility, death is permanent. Copyright universality, all living things will die eventually, including oneself. Non-functionality, upon death, all bodily processes end. Degree causation, death is caused by a breakdown of bodily functions. Concepts of death at different ages. Sent. Infants and toddlers, 0 to 2 years no understanding of death. Preschoolers, 3 to 5 years copyright typically perceive death as something temporary and reversible. May believe that they can influence death, magical thinking. School-age children, 6 to 12 years copyright typically know that death is irreversible and universal, may understand the concept of non-functionality. Often personify death, example as a ghost. Have a strong interest in death, and may feel anxious and fearful about their own death or the death of caregivers. Adolescents, 13 to 18 years typically have an adult understanding of death. VA. OCES. Overview of abnormal development. General principles. Early identification and treatment of developmental delay improve outcomes in children. Sent. Developmental screening uses validated tools and should be used at set child visits, or if there are concerns. 30 to 18 types of abnormal development, 61 331 17. Sent. Developmental delay, milestones occur in the expected order but not by the expected ages. Copyright 1 domain affected, isolated developmental delay. Copyright 22 domains affected, global developmental delay. 6 Sent. Developmental dissociation. Copyright significant developmental delay in one domain when compared to the other domains. Copyright can occur in children with isolated developmental delay and in those with a global developmental delay. Sent. Developmental deviation, developmental milestones within a given domain are not achieved in the expected order. Developmental regression, the loss of previously acquired skills. Back collapse fine text outline. Concepts of death at different ages. Sent. Infants and toddlers, 0 to 2 years no understanding of death. Sent. Preschoolers, 3 to 5 years copyright typically perceive death as something temporary and reversible. May believe that they can influence death, magical thinking. School-age children, 6 to 12 years copyright typically know that death is irreversible and universal, may understand the concept of non-functionality. Copyright often personify death, example as a ghost, have a strong interest in death, and may feel anxious and fearful about their own death or the death of caregivers. Adolescents, 13 to 18 years, typically have an adult understanding of death. VA. IEEE. Overview of abnormal development. General principles. SENT early identification and treatment of developmental delay improve outcomes. Asterisk in children. SENT developmental delay, milestones occur in the expected order but not by the expected ages. 1 Copyright 1 domain affected, isolated developmental delay. Copyright 22 domains affected, global developmental delay, SENT developmental dissociation. Copyright significant developmental delay in one domain when compared to the other domains. Copyright can occur in children with isolated developmental delay and in those with a global developmental delay. SENT developmental deviation, developmental milestones within a given domain are not achieved in the expected order. SENT developmental regression, the loss of previously acquired skills. Evaluation of abnormal pediatric development. 18.6. SENT confirmed developmental abnormalities are present using validated developmental screening, if not already performed. SENT obtain a full medical history, example in utero, birth, past medical history, and family history. Plus evaluate for abnormal physical findings. 5841 SENT perform a detailed neurological examination. Plus rule out hearing loss and vision loss. Screen and test for common underlying etiologies. / SENT for children with suspected global developmental delay, see also diagnostics of global developmental delay. Management of abnormal pediatric development. 18. Identify and treat underlying medical comorbidities, example hearing loss. SENT involve relevant therapy services, as needed. Behavioral issues, behavioral therapy. Copyright emotional and / or cognitive issues, psychology. Copyright gross motor delay, physical therapy. Fine motor delay, occupational therapy. Copyright speech delay, speech therapy. Ensure regular follow-up. SENT see also neurodevelopmental disorders. WA. OSO. Tips and links. Sources. Last updated October 26, 2023. Back collapse. Fine text. Outline. Asymmetrical tonic neck reflex, ATNR, VV. With the infant in the supine position, turning the head to one side elicits extension of the ipsilateral extremities and flexion of the contralateral extremities. This reflex is often referred to as the fencing or bow and arrow posture. Source: Asymmetrical tonic neck reflex, ATNR, in a 2-week-old female by Samuel Finlayson, Wikimedia Commons, licensed under CC by SA 4.0. Modifications, anonymized. 4 months OOASSEE 4. 1 raises head 1. Holds head 1. Rolls over 2. Recognizes familiar voices 2. Holds toy 2. Laughs 3. Social smile 3. Coos, vowel sounds, 3. Reaches for toys. Gaga ga. 1 sits unassisted 1 cruises 2. Babbles, monosyllables, EE3 2. Pincer grasp 3. Transfers objects between hands pie piece 3. Says mama or dada 4. Separation anxiety / stranger anxiety. Child development milestones. Copyright Boss. X neurodevelopmental disorders. Neurodevelopmental disorders are a class of psychiatric disorders characterized by childhood onset, potentially lifelong deficits resulting in the impairment of personal, social, academic, and occupational function. The specific causes of neurodevelopmental disorders are unknown but assumed to be multifactorial, with certain associations having been established, example Fragile X syndrome, tuberous sclerosis, Rett syndrome, epilepsy, low birth weight. Intellectual disability is characterized by impaired mental abilities, example abstract thinking, academic learning, problem solving, that cause impairments in adaptive functioning, example communication, independent living. Global developmental delay is defined as a significant delay in equals two of the major developmental domains, gross motor, fine motor, language, cognition, and social milestones, in children. Specific function, i.e., reading, written expression, or maths. The disorder typically manifests in the first few years of schooling and results in poor academic performance. In the corresponding discipline, language disorders and speech sound disorders are characterized by deficits in the acquisition and/or comprehension of language, speech, and communication. Childhood onset fluency disorder, stuttering, is characterized by disturbances in the normal fluency of speech that manifests with sound and syllable repetition, sound prolongation, and broken words. Other neurodevelopmental disorders, including autism spectrum disorder and attention deficit hyperactivity disorder, are discussed in separate articles. For information regarding neurodevelopmental motor disorders, including stereotypical movement disorder, and tic disorders, Tourette syndrome, persistent motor tic disorders, persistent vocal tic disorder, and sporadic transient tic disorder, see Tourette syndrome. 7 ES. Intellectual disability. Definition, a neurodevelopmental disorder that manifests during the developmental period, and affects an individual's intellectual abilities, example abstractive thinking, language, memory, and adaptive functioning, example communication, independent living. Prevalence, 1% in the general population. U1E etiology copyright congenital. Genetic conditions, example Fragile X syndrome, trisomy 21, Klinefelter syndrome, exposure to teratogens in utero, example fetal alcohol syndrome, congenital hypothyroidism, congenital infections, example toxoplasmosis, rubella, perinatal hypoxia, perinatal trauma. Copyright acquired CNS infections, example viral encephalitis, meningitis, CNS malignancies, example neuroblastoma, traumatic brain injury, intoxications, example lead, mercury, lutein deficiency, malnutrition. Clinical features. Copyright. The following features should be present, deficits in cognitive functioning such as learning, problem solving, reasoning, abstract thinking, judgment, and planning. Impaired adaptive functioning, example inability to maintain personal independence and social responsibility, leading to educational, occupational, communication, and social problems. Onset during the developmental period, during childhood or adolescence. Other features include, features of accompanying mental conditions, example apathy and depressed mood in depression, poor attention in ADHD, features of the causative conditions, example characteristic appearance in trisomy 21, behavioral problems in Lesch-Nyhan syndrome, scent diagnostics. Copyright intelligence quotient, IQ, testing. Copyright workup for identification of underlying disease, example genetic testing, neuroimaging, e-management. Non-pharmacological psychotherapy, example cognitive behavioral therapy, family-oriented therapy. Occupational therapy. Special education programs. Speech language therapy. Pharmacological, used to control psychiatric symptoms of accompanying conditions. Atypical antipsychotics, example risperidone, aripiprazole, olanzapine. 2 antidepressants, example SSRIs, references, SIL 4LL1. Back collapse. Find text outline. SESSSSAA underscore 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 EC underscore Q, global developmental delay. Definition, significant delay in two of the major developmental domains, gross motor, fine motor, language, cognition, and social milestones, in children. Degree. Scent clinical features. Copyright. Mild forms may not be detected until preschool age 1. Severe delay in meeting milestones. See developmental milestones for details. In equals 2 of the major developmental domains: gross motor, fine motor, language, cognition, and social milestones. Serum and urine analysis and enzyme studies, in infants suspected of having a metabolic disorder. Management. Treatment of the underlying cause, if reversible. Copyright. Early intervention to minimize the severity of disability. Multidisciplinary team, neurologists, orthopedics, physical therapists, speech therapists, nutrition. Copyright. Special schooling and occupational therapy. References, 5 IL 6. WA 005. Specific learning disorder. Scent definition. Co-neurodevelopmental disorder that occurs due to a combination of genetic, epigenetic, and environmental factors and results in difficulties learning and applying specific academic skills. Features should be present for more than 6 months despite academic interventions to address these problems. Scent prevalence, 5 to 15% in the school-age population. 3 Scent clinical features. Copyright. Inability to acquire age-appropriate academic skills, such as reading, most common, spelling, writing, operations with numbers or mathematical reasoning. Dyslexia, a specific learning disability characterized by difficulties with word recognition and decoding, as well as spelling, which often results in below-average reading comprehension, limited vocabulary, and delayed language development that cannot be attributed to intellectual disability, IQ. Academic support, example individualized learning programs. Irregular school psychology consultations. Copyright. Individual or family psychotherapy. Extracurricular activities to improve academic and social inclusion. References, 3. WA and childhood onset fluency disorder, stuttering. Scent definition, a condition characterized by disturbances in the normal fluency of speech with onset in the early developmental period. Back collapse. Fine text outline. Childhood onset fluency disorder, stuttering. Scent definition, a condition characterized by disturbances in the normal fluency of speech with onset in the early developmental period. Scent prevalence, 5 to 10% of preschool children. 7 Scent clinical features. Onset of symptoms typically between age 2 to 7 years. E-sound and syllable repetition. E-sound prolongation of letters. Copyright. Repetition of monosyllabic words. Broken words and speech blocking. Substitution of words to avoid problematic words. Copyright. Secondary maladaptive behavior, example word avoidance, mannerisms, avoidance of speaking, may develop in some patients. Scent diagnostic criteria, DSM-5, copyright. Persistent disturbances in the normal fluency of speech. Copyright. Stuttering results in anxiety related to speaking, impaired social participation, and/or poor academic performance in childhood. Copyright. Not attributable to sensory impairment or speech motor deficit, or other medical condition, example stroke, CNS trauma, * management. 7. Spontaneous resolution in 65 to 85% of preschool children with dysfluency by the age of 7 years. Speech therapy for severe or persistent cases. Develop compensatory techniques to improve fluency. Treat maladaptive behavior. OE language disorder. Scent definition, a communication disorder characterized by a delayed and/or impaired ability to comprehend and/or produce language. Scent classification. Expressive language delay = characterized by an inability to formulate language, example spoken, written, signed language, manifestations include word finding difficulty, omission of words within sentences, and use of incorrect tenses. Receptive language delay = characterized by an inability to understand and process language, example spoken, written, signed language, equals manifestations include impaired ability to understand and follow directions, misunderstanding the words and meanings of stories or information. Scent diagnostic criteria, according to DSM-V, copyright persistently reduced ability to learn, understand, and use language, written, spoken, and/or signed, characterized by limited vocabulary for age, incorrect understanding of word meanings, difficulty with sentence structure, and/or incorrect grammar use. Copyright a significant deviation of language abilities below those expected for age, resulting in impaired communication, social participation, and/or poor academic performance. 1. Copyright the language difficulties begin to manifest during the early developmental period. The symptoms are not due to another condition, example hearing impairment, intellectual disability, cerebral palsy. Differential diagnosis. Normal variations in language acquisition, especially in children. Oi. Og. Speech sound disorder. Definition: a communication disorder characterized by persistent difficulties in phonology and/or articulation. Scent diagnostic criteria, according to DSM-V, copyright impaired verbal communication and speech intelligibility due to persistent difficulty in speech sound production. Copyright the communication difficulties cause impaired social participation and/or poor academic performance in childhood. Copyright the speech difficulties begin during the early developmental period. Copyright the symptoms are not due to an underlying condition, example hearing impairment, cleft palate, cerebral palsy. Plus differential diagnosis degree. Normal variations in speech, example speech delay in children learning 2 languages. Expressive language disorder, often occurs with speech sound disorder. Hearing impairment. Copyright selective mutism. Back collapse. Fine text outline. X neurodevelopmental disorders. Sound prolongation of letters. Repetition of monosyllabic words. Broken words and speech blocking. Copyright substitution of words to avoid problematic words. Copyright secondary maladaptive behavior, example word avoidance, mannerisms, avoidance of speaking, may develop in some patients. Scent diagnostic criteria, DSM-5, copyright persistent disturbances in the normal fluency of speech. Copyright stuttering results in anxiety related to speaking, impaired social participation, and/or poor academic performance in childhood. Not attributable to sensory impairment or speech motor deficit, or other medical condition, example stroke, CNS trauma, management. 71. Spontaneous resolution in 65 to 85% of preschool children with dysfluency by the age of 7 years. Speech therapy for severe or persistent cases equals develop compensatory techniques to improve fluency equals treat maladaptive behavior. WAY. CE. Language disorder. Scent definition: a communication disorder characterized by a delayed and/or impaired ability to comprehend and/or produce language. Scent classification: expressive language delay equals characterized by an inability to formulate language, example spoken, written, signed language, equals manifestations include word finding difficulty, omission of words within sentences, and use of incorrect tenses. Receptive language delay equals characterized by an inability to understand and process language, example spoken, written, signed language, equals manifestations include impaired ability to understand and follow directions, misunderstanding the words and meanings of stories or information. Scent diagnostic criteria, according to DSM-V, copyright persistently reduced ability to learn, understand, and use language, written, spoken, and/or signed, characterized by limited vocabulary for age, incorrect understanding of word meanings, difficulty with sentence structure, and/or incorrect grammar use. Copyright a significant deviation of language abilities below those expected for age, resulting in impaired communication, social participation, and/or poor academic Performance 1 Copyright The language difficulties begin to manifest during the early developmental period. Copyright The symptoms are not due to another condition, example hearing impairment, intellectual disability, cerebral palsy. Asterisk differential diagnosis normal variations in language acquisition, especially in children. CES. Speech sound disorder. Definition: a communication disorder characterized by persistent difficulties in phonology and/or articulation. Scent diagnostic criteria, according to DSM-V, 3 copyright impaired verbal communication and speech intelligibility due to persistent difficulty in speech sound production. Copyright the communication difficulties cause impaired social participation and/or poor academic performance in childhood. Copyright the speech difficulties begin during the early developmental period. Copyright the symptoms are not due to an underlying condition, example hearing impairment, cleft palate, cerebral palsy. Plus differential diagnosis normal variations in speech, example speech delay in children learning 2 languages, expressive language disorder, often occurs with speech sound disorder, hearing impairment. Copyright selective mutism motor/neurological disorders, example apraxia, dysarthria due to cerebral palsy. Copyright structural abnormalities, example cleft palate. Management, speech therapy for articulation and/or phonological techniques. Back collapse. Find text outline. X. Growth faltering. Growth faltering is defined as a pattern of slow growth in children when compared to the predicted values for their age and sex. It is seen in up to 10% of children in the United States and often occurs secondary to malnutrition, which can be due to a complex interplay between biological and psychosocial factors. The primary mechanisms that contribute to growth faltering and malnutrition are inadequate nutritional intake, inadequate absorption, and increased metabolic requirements. Clinical features may include signs of malnutrition such as muscle mass wasting, minimal adiposity, hair loss, developmental delay, and recurrent infections. Growth faltering is confirmed using standardized growth charts, example weight for age. Risk factors and the underlying etiology. Diagnostic testing is reserved for children with no response to initial management or severe clinical features and can include urinalysis, stool tests, or specific tests depending on the suspected etiology, example HIV test. Management consists of treatment of the underlying cause and nutritional modifications. Most patients can be successfully managed as outpatients. Close follow-up is indicated to prevent relapses or excessive weight gain. OBETS. Definition: scent growth faltering. Copyright a pattern of slow growth in children compared to the predicted values for their age and sex. Copyright commonly used criteria include IL-3 weight for age, length for age, BMI for age, or weight for length. VA. CE. Epidemiology. Scent seen in up to 10% of children in the United States. 2. Most commonly occurs in children aged 6 to 18 months of age. 4. Epidemiological data refers to the U.S., unless otherwise specified. CE. Etiology. Growth faltering occurs secondary to malnutrition, often due to a complex interplay between biological and psychosocial factors. L2 its risk factors 223. Biological 3, prematurity and low birth weight. Copyright intrauterine growth restriction 2. Copyright congenital anomalies. Developmental delay. Autism spectrum disorder 2. Copyright gastroesophageal reflux. Copyright dental caries. Psychosocial, see also social determinants of health, SI. 3. Copyright low socioeconomic status. 4. 2. Copyright in the caregiver, stress, social isolation, inexperience, or untreated mental illness. SI2 I3. Back collapse. Find text outline. Restrictive diets, 1-4. At, growth faltering is more common in children with multiple risk factors. 3. Mechanisms. Overview of mechanisms of growth faltering. 2 3. Mechanism common causes breastfeeding difficulties, example inadequate supply, ineffective latching, incorrect preparation of formula feeds, poor feeding practices * mechanical difficulties, example cleft palate and/or lip, poor oral neuromotor coordination, poor oral intake, most common. 3. Child abuse and neglect, psychiatric disorders, avoidant restrictive food intake disorder, anorexia nervosa, insufficient calorie consumption conditions affecting appetite, example pain from GERD, anorexia secondary to lead poisoning. Inflammatory bowel disease, asthma, malignancy, congenital heart defects, chronic lung disease of prematurity, renal impairment, chronic and/or recurrent infections, example HIV, tuberculosis. Increased requirements ALS. Gastrointestinal disease, example celiac diet, bowel infections, example Giardia lamblia, food intolerance, example milk protein allergy, cystic fibrosis 117, inadequate absorption 21.3, hypertrophic pyloric stenosis 1, iron deficiency, anemia, exocrine, pancreatic insufficiency, cholestasis including biliary atresia. Inborn errors of metabolism, example glycogen storage disease, trisomy 21, trisomy 18, defective energy utilization 21. Clinical features. Growth faltering is a manifestation of malnutrition and may be accompanied by features of other underlying conditions. Its features of malnutrition 21. Scent failure to gain weight. Scent clinical features of protein energy malnutrition, example wasted muscle mass, minimal adiposity, copyright growth stunting, copyright dermatologic signs equals thin, weak hair equals pale, dry skin. Features of micronutrient deficiencies, such as, is copyright acral dermatitis or change to hair color / texture, in zinc deficiency, copyright pallor, in iron deficiency, anemia, developmental delay. Scent recurrent infections. Persistent severe malnutrition affects growth parameters sequentially. The first affected is weight, then length, and finally head circumference. 3. Features of underlying conditions. 1. Features depend on the cause, examples include scent suspicious contusions or fractures, abnormal language, social, or psychological development in children who experience abuse, scent recurrent vomiting and diarrhea in gastrointestinal diseases, atopic dermatitis in food allergies, heart murmur in congenital cardiac disease, scent dysmorphic features in genetic abnormalities, edema in renal or liver failure. Back collapse, fine text outline. Diagnostics. Clinical assessment 223. Comprehensive pediatric history and physical examination including family history and prenatal/birth history, feeding and nutrition history, number and frequency of feeds, copyright food refusal, copyright observation of a feed 1, 9. Social history, identify risk factors such as food insecurity, lower socioeconomic status, identify features suggestive of an underlying etiology, see clinical features of growth faltering. Copyright. Because growth faltering is commonly multifactorial, a thorough clinical assessment is necessary to address the interplay of contributing biological and psychosocial factors. 10. Diagnostic studies. Common studies /223. There is no standard set of blood tests to order. Common studies include 23. Scent CBC with differential for anemia, immunodeficiency, or malignancy, all CMP for electrolyte disturbances and renal tubular acidosis, ALTS, thyroid function tests, hypothyroidism can cause short stature. 2 ILS3 urinalysis for glycosuria, infection, or renal pathology. 2 stool microscopy and culture for infection or malabsorption. 2 diagnostic studies for celiac disease. 2 lead and iron levels. Further studies. 2 Consider additional studies guided by clinical suspicion, for example, 2. Scent cholestatic jaundice, example biliary atresia, liver chemistries and imaging. Scent immunodeficiency, immunoglobulin levels for congenital immunodeficiency disorders, HIV screening. Aspiration, modified barium swallow, gastrointestinal conditions, co-esophagogastroduodenoscopy with biopsies O upper gastrointestinal series with small bowel follow-through O fecal calprotectin. Food allergies, IgE skin prick test, congenital heart disease, echocardiogram, cystic fibrosis, sweat test, CFTR, genetic testing, infections, tuberculosis screening. 7. OE. Management. Scent determine malnutrition severity and whether inpatient management is required. Copyright severe malnutrition or other admission criteria for growth faltering, inpatient management. Copyright mild or moderate malnutrition, trial outpatient management. Calculate additional calories required for catch-up growth and start nutritional modifications for growth faltering. Replete micronutrient deficiencies, if present. Treat any underlying etiology and address modifiable risk factors. Arrange regular follow UPS to ensure adequate growth. L2I L3. Appetite stimulants are not routinely recommended but may be considered in select cases, example children undergoing cancer treatment. 3. WA. OOHO. Complications 2. Increased susceptibility to infections, developmental delay, persistent short stature, increased risk of cardiovascular disease and metabolic syndrome in adulthood. Back. VN collapse. A. Find text. Al. Outline. Growth faltering, 1/8. Birth to 24 months, girl's name, length for age and weight for age, percentiles record hashtag. Birth 3/6/9/12/6/18/21 in cmm in 39 to 1100 age, months. 100,434. Minus 384 387 times 10 to the power of negative 374th degree EET. Beta. Equals 95 to 901 degree T. Mesa ET 335 ABSE equals AE, L. 30 to 75 League SAAT equals 174 degrees 29 to 5 ZS at SL 28 Lea EGIE on at N 2774 LZFAA OMG 26 So 15 to 4. H 98 24 to 414 plus dash 23 EAS dash 30 W plus dash 22 CER 2013 A. WORAE AELEELG plus dash 20 IA is 12 HPs plus 267 SECs equals 1413855 11. ATL equals 11 plus 24 Wales ALEAEED 1H plus 16 dash plus 40 PAT equals YZ equals SZ equals AE equals SE, AAA a PEAE BO 0 gear AAA CES RATA SSES. Equals YZ POT ISZSEMG 18 to 4 dash 16 slash, AAAE equals plus 16 plus IILYEGE, het equals. YL via age, months, kg. IB. EH12VY backslash 91215182124 1 EO. 4 VA mother's stature gestational G10-4 ye father's stature age, weeks comment H equals Y date age weight length head CIRC Y keg Y birth. A. Smiley face. May I be kg birth 36. Length and weight for age percentiles for age, girls O 24 months, V. This image is an adaptation. Source of original image, Centers for Disease Control and Prevention. Original title, birth to 24 months, girls length for age and weight for age percentiles. Created by, Centers for Disease Control and Prevention. Licensed under public domain. Modifications to original image, CDC logo removed by request. See growth faltering, 2/8. Birth to 24 months, boys name length for age and weight for age percentiles record hashtag. Birth 3 6 9 12 15 18 21 24 41 CIN POL in. Plus 100 age, months, 100 equals E395, ZA 38-1 387 E PAVE 9537 to 4N. P38-90 Z36-5. E355 78 90% 3574 HL 345 a 34 to 4 E equals 2533 equals 10 3280 AEETGT 407 31 AA equals 75 as 12L. A PROE 367 E equals plus dash 70 up equals a 16. And PE2AYA4GF265 Z15 Watt equals B-4FF98 equals 25 AD pre-R32 to 4H 5454 Lala 95 I equals 607 VAT equals 1-147 plus 2357 9304 W. 22 to 74 A equals E equals PSFTS 5GF 20560 YYE equals 4 equals A equals 1845 underscore TAB 25 TT 24 Nick LZ underscore 40 ACUM equals set 10 F 22 153 NELVE equals ATI equals VAR 76 MA AESAGF 20 plus FLA law RAA 7 IAAAA equals underscore so 14 HOF IFAEOS equals 4 F4 FSKGIBW plus 6 AEH months E12 Lawton 9 215 248 21 AA I5 TFF Phi mother's stature gestational GP10 AAS father's stature age weeks comment H equals date age weight length head circ T any fo UI birth OE3 LAL B6 AE IB-KGIAIIIRTI birth 36 Stature and weight for age percentiles, male individuals 0 to 24 month, 2 ND 98 asterisk percentiles, VV. This image is an adaptation. Source of original image, CDC. Original title, birth to 24 months, boys length for age and weight for age. Percentiles. Created by, Centers for Disease Control and Prevention, National Center for Health Statistics. Licensed under public domain. Modifications to original image, CDC logo removed. Growth faltering, 3/8. Birth to 24 months, girl's head circumference for age and name weight for length percentiles record hashtag. Birth 3 6 9 12 15 18 21 24 underscore in underscore CMI dash M underscore in underscore 4 age, months, E52 525. Plus dash 20 dash 4 plus 24 plus 50 EE51. H plus 19 to 48 IA equals Y 757 plus 48 dash 194 cent. D49 to 146 NHS 23's SSSSA 746 plus 49J, AES equals plus 10 EC equals a PNSS2S 22 equals 3 slash equals 77 EE. I plus 17 TAC high 74 N, 42 OISSES equals C, ZZ seal fat euro. M ha OE plus 231.04 FMLA Liz OE 44 to 29 dash plus 4 GJ. E, 15 to 38 4 Y, AASAE equals 21 ARYZ XAOEEO. 9571 20 F44 4 E slash EAL 19 to 42, equals ESO LKS. Plus 13 LAL LE 47 to 1385, E32 SOA 4 A low 46 dash dot degree 1 P equals OL, L9 GBCD. TNHOL. 4A ISRA MSAI. Plus 20,419 LIL 920 plus. pi. Lila G18 WTEVG La YAE 7 equals 95 ET 41 cent mil 6144 142 jug 124. SIO degree HES 2 length KGG 1B. 1 I 64 66 68 70 72 74 76 7880 82 84 86 88 90 92 94 96 98 100 102 104 106 108 110 centimeters 6 equals 2 26 27 28 29 30 31 32 33 34 35 36 37 38 39 40 41 42 43 and equals E, date age weight length head CIRC, comment equals 2 IBKG. CMM / 46 4850 52 54 56 58 60 62 UL in 18 19 20 21 22 23 24. Head circumference for age and weight for length percentiles, girls 0 to 24 months, v. This image is an adaptation. Source of original image, Centers for Disease Control and Prevention. Original title, Birth to 24 months, girls' head circumference for age and weight for length percentiles. Created by, Centers for Disease Control and Prevention. Licensed under public domain. Modifications to original image, CDC logo removed by request. Growth faltering, 4/8. Birth to 24 months, boys' head circumference for age and name weight for length percentiles record hashtag. Birth 3 6 9 12 15 18 21 24 __ in _cm cm lin _h months, fe. Equals 252 AD 2098 F204 50 E, 5054. H19 _48 padcom 48 plus 19 4. D plus 18 minus 46 A equals SSSS equals 7 equals weird 18 yen. Las SESOSSE plus 174 N OLID equals SSS equals CWTIAE, FUTME de ARSE equals ES. F mil / YWSAE 22 plus 48 E is my EEAR 38 WWW, equals A7 plus 21 4 to 465. ELE 98 sevenths 20 plus ELLWZ equals A ta phi 44. Plus 14 equals 94 plus 194 to 42. CCRACL 492 1 to 407 E equals VPA 1843 8 LP 4738 plus CAG plus 32. LLL loose 1G 987 L142 AZLA LMGA 15 plus, R30 volley A equals 26 to 412 Ella Z 12 to 1264-24 plus 11 Len Og Eaton 99 to 410 age 10 to 224 T plus 20 4 plus 9 LOLLE 9 plus 20, 18 to 49 Vala Figs. W, E equals 7 VP is 7 a 165 E, 1445 log E 41 7 equals dash 19, a 5 equals. H equals R length kg IBT2 SS 64 66 6870 72 74 76 7880 82 84 86 88 90 92 94 96 98 100 102 104 106 108 110 centimeters R 64 26 27 28 29 30 31 32 33 34 35 36 37 38 39 40 41 42 43/in equals date age weight length head circ comment plus 2 plus IBKCM 46 4850 52 54 56 58 60 62 in 18 19 20 21 22 23 24. Head circumference for age and weight for length percentiles, boys 0 to 24 months, v. This image is an adaptation. Source of original image, Centers for Disease Control and Prevention. Original title, birth to 24 months, boy's head circumference for age and weight for length percentiles. Created by, Centers for Disease Control and Prevention. Licensed under public domain. Modifications to original image, CDC logo removed by request. C. Growth faltering, 5/8. 2 to 20 years, girl's name stature for age and weight for age percentiles record hashtag. 12, 13, 14, 15, 16, 17, 18, 19, 20 mother's stature underscore 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 father's stature TTTT Tom in date age weight stature BMI asterisk age, years, equals 76 190 plus 74. 185 plus 724 180 T plus 704 A seat 175 T. Asterisk to calculate BMI, weight, kg, plus stature, cm, plus stature, cm, x 10,000 equals ed 170 f or weight, ib, plus stature, in, plus stature, in, x 703 t equals ss, 3 plus 66 r in Tom plus 3 4 5 6 7 8 plus 9 10,411 equals s equals h equals s equals 5, e. Plus 160 plus pound plus 160 plus 625 TAC equals dash 62 number 155 SSI plus 101,553 minus 62 SS5 equals plus dash 60 dash 4 plus 150 OAZ 1,505 58 plus equals SA 145 OS7F minus 56 ZRA 3 plus 140 equals VAX 105, 423054 tier ATT. SS plus 135 equals reign of 100 hashtag 220 plus. A equals 2 Rs A plus HM 5 plus 130 I equals 295 number 2104 QEE 2225 SU. RN 483120, LAF SE is state 1. E plus 0 a 95 for 465,115 equals, EOF. G3% F1 70 447,410 Tiditai 1 to $754-$42 7 plus, $604 $105 AR70 F50-40 plus SEWW plus 1004 equals ADZZAE 6544 401 E plus 38Q equals 38 to 954 Ray Z equals 604 1304 G. 3690 TES equals I 554,120 H 34 plus FA equals underscore 2 low T $853 equals Z dash equals IE equals 50 hashtag 110 plus 3250 Z equals P 45 3100. 30x 4483 equals 35 a 35 cents degree. W703 equals 30 degrees. E60 equals SAS plus $6125 equals 25 plus. NE20 plus OIDA $40. Plus dash 30451 SE 394 equals 1010 plus WKGOE, years, EKG TDB. 23 45 6 7 8 9 10 11 12 13 14 15 16 17 18 19 20. Stature and weight for age percentiles, female individuals 2 to 20 years, 5th to 95th percentiles, VV. This image is an adaptation. Source of original image, CDC. Original title, 2 to 20 years, girl's stature for age and weight for age percentiles. Created by, Centers for Disease Control and Prevention, National Center for Health Statistics. Licensed under public domain. Modifications to original image, CDC logo removed by request. C. Growth faltering, 6/8. 2 to 20 years, boys name stature for age and weight for age percentiles record hashtag 1273 14 16 16 17 18 19 22's ES mother's stature _. SE father's stature CRF in date age weight stature BMI asterisk age, years 76 to 14 1903, TSAT 74 S equals Z equals PH 185 plus 5. 75 725 X plus 1804 T5 plus 704A. And FT 175 plus T asterisk to calculate BMI, weight, kg, plus stature, cm, plus stature, cm, x 10,000 fa SSOO, equals n solu or weight, IB, plus stature, in, x 703 SAS 10 equals re in toms 3 equals 4 to 65 6 7 equals 8 to 9 10,411, a 2 as ES 5 1655 E. Plus 160 PUA 160 plus 625 AZ equals 62 F 155 AFF 1555 SS minus 605 equals 7 TSRs 4T plus 150 LA ISOBs 1503. A minus 58 $145 is equals V4 equals YY 56, smiley face, equals a 7 equals FY Xian as A105, 4230. AE 54 plus 435 5L equals I as 100,220. 225,130 Ferris ESA 95 $210. Het 27 AL equals 904,200. 485,120 Pa ASP 9 equals Shay 7 F 180 plus 467, 5115 SSSE 2 AOD. EK 7 equals F 170 plus 4110 BPP 75. I 42 7X plus 160 BRE plus 105 Java RA2. A 705, F7 equals 507 W40 plus 100,444 raw form Z7 TN33 STEYS5 SS equals 4 A 7 equals ST604 4304 G38 equals 907 AZ equals EEFAS equals 55 $120, 1. P3465 Ali EE 50,110. Plus 3,280 ZT PO EG 454,100. 30 Summi 40 cents 9. Plus 83 equals 35 as a WA 35 cents 0 WP 70 equals 30 at S equals S5 equals 30 plus 704 E-60 equals plus 604 plus 25 plus G50 equals 450 plus H equals 2020 plus TF 403 E 407. Lap 153 LESA 10,344 10 plus Phi F equals CZ Cisracitello. CZECA. 2 cent $.848 copyright F and 1 to 17 T233, 14 degree 1816 if 618. Stature and weight for age percentiles, male individuals 2 to 20 years, 5 T8-95 TH percentiles, VV. This image is an adaptation. Source of original image, CDC. Original title, 2 to 20 years, boys, stature for age and weight for age percentiles. Created by, Centers for Disease Control and Prevention, National Center for Health Statistics. Licensed under public domain. Modifications to original image, CDC logo removed by request. C. Growth faltering, 7/8. 2 to 20 years, girls name body mass index for age percentiles record hashtag Date, age, weight, stature, BMI asterisk comments BMI-35 to 4 344 33 to 4 324 at 31 304 asterisk to calculate BMI, weight, kg, plus stature, cm, plus stature, cm, x 10,000 or weight, IB, plus stature, in, plus stature, in, x 703.29 BMI underscore equals 28, 27 27, 2685, 26. R24 equals WA 75 24, 23 SA equals 234 20 equals 22 to 4 AA equals 504 L24 equals 214. L 2020 to 4 VIT L 194 equals 19 G3 MNND 10 underscore LN 717 T16 equals 16X 14 to 2 equals 14 13 12 124 kg/m age years kg/m seat FF 8 at WIBRBU 2 OE Body mass index for age percentiles, female individuals 2 to 20 years, 5 TT 95 TH percentiles, VV. This image is an adaptation. Source of original image, CDC. Original title, 2 to 20 years, girls, body mass index for age percentiles. Created by, Centers for Disease Control and Prevention, National Center for Health Statistics. Licensed under public domain. Modifications to original image, CDC logo removed by request. Euro growth faltering, 8/8. 2 to 20 years, boys name body mass index for age percentiles record hashtag. Date, age, weight, stature BMI asterisk comments BMI dash. 35 34. 33. 32. 31. Z30 asterisk to calculate BMI, weight, kg, plus stature, cm, plus stature, cm, x 10,099. Or weight, IB, plus stature, in, plus stature, in, x 703.29 to 4. BMI ZTOG. 27 underscore 27. 26 equals 26. L25 RO 2575 plus 24 7 equals 24. A equals X50, 22 A 7 22 L24 equals 21 to 4 ZZ 25-20 equals Z equals ohm equals 27 on 10 as 19 equals E equals AEOM equals PET 19 18 TT equals 18 plus 17 equals 1 T-4x equals R16 to 4 T equals 16, 15 equals 154 equals 44 14 4 13 13 12 12 kg/m age years kg/m 2 3 4 6 7 8 registered 170 11 TF 2 14 16 3 160 168 2 Body mass index for age percentiles, male individuals 2 to 20 years, 5 T8-95 TH percentiles, V. This image is an adaptation. Source of original image, CDC. Original title, 2 to 20 years, boys, body mass index for age percentiles. Created by, Centers for Disease Control and Prevention, National Center for Health Statistics. Licensed under public domain. Modifications to original image, CDC logo removed by request. XX skeletal dysplasias. Skeletal dysplasias are a group of genetic disorders that affect the development of bone and cartilage. The disorders may be inherited in an autosomal dominant, autosomal recessive, or X-linked manner. Some skeletal dysplasias can be detected as early as the prenatal period, while others manifest later in life, typically during childhood or adolescence. Achondroplasia, characterized by disproportionate short stature and craniofacial abnormalities, is the most common type of skeletal dysplasia. Osteogenesis imperfecta is a bone disease characterized by impaired osteogenesis that results in brittle bones that fracture easily, while osteopetrosis is a high-density bone disease that results in increased sclerotic thickening of the skeleton on radiological examination. Campomelic syndrome is a life-threatening disorder characterized by skeletal dysplasia, abnormal sex development, and other congenital defects due to SOX9 gene mutations. 2. OES. Achondroplasia. Scent definition: a genetic disorder characterized by impaired longitudinal bone growth that results in disproportionate short stature. Scent epidemiology: O most common type of skeletal dysplasia. O most common cause of disproportionate short stature. Copyright 1:15,000-40,000 children affected in the U.S. Etiology: copyright gain of function mutation in fibroblast growth factor receptor 3 gene, FGFR3, on chromosome 4 new, sporadic, mutations in 80% of cases. 2. Copyright: the probability of new mutations increases with the father's age at the time of conception. Autosomal dominant inheritance in 20% of cases. Homozygosity is lethal perinatally. Pathophysiology: copyright defective FGFR3 continuous receptor stimulation by FGF inhibited chondrocyte proliferation. Endochondral ossification: impaired longitudinal bone growth. Normal intramembranous ossification of the craniofacial bones. Disproportionately large head in relation to the limbs. Clinical features: copyright stature 1 equals disproportionate short stature equals normal size torso equals short, plump extremities. Copyright craniofacial abnormalities equals macrocephaly equals prominent brows equals mid-face retrusion equals flattening of the nose equals middle ear deformation, recurrent otitis media. O other skeletal abnormalities equals small foramen magnum, compression of the cervical medulla lumbar lordosis and kyphoscoliosis equals spinal canal stenosis, lower back and leg pain, paresthesias, dysesthesia, incontinence. J small. Chest wall 1 equals trident hand, a deformity of the hand that is characterized by short stubby fingers of equal size and increased separation between the middle finger and ring finger, which gives the hand the three-pronged appearance of a trident. Copyright normal intellectual development. Scent diagnostics. Copyright physical examination degree. X-ray findings equals lateral skull, frontal prominence, mid-face hypoplasia equals spine, spinal canal stenosis, scoliosis equals extremities, short, thick bones. OCT/MRI head, indicated in patients with signs of cervicomedullary compression. 1 equals assessment of brain stem compression equals measurement of the size of the foramen magnum plus therapy. Copyright daily SC vosoritide injections. C-type natriuretic peptide analog increases linear growth in children 5 years of age and older with open epiphyses, growth plates. 1 Copyright surgical correction of spinal stenosis, secondary scoliosis, geniverum, brain stem compression. Back collapse. Fine text outline. Osteogenesis imperfecta, brittle bone disease. Definition: a genetic disorder characterized by impaired osteogenesis that results in skeletal deformities and brittle bones that fracture easily. Epidemiology: 1 in 15,000 to 20,000 births. 41. Etiology: various genetic defects, most commonly autosomal dominant mutations in COL1A1 or COL1A2 genes plus 115. Pathophysiology: formation of hydrogen and disulfide bonds between type pre-procollagen molecules. J triple helix formation. Synthesis of normal type collagen. Impaired bone matrix formation, osteogenesis. Clinical features: 67. Osteogenesis imperfecta type, the mildest and most common form. Growth delay equals skeletal deformities, brittle bones. Bowing of bones and saber shins. Fractures during childbirth and recurrently from minimal trauma thereafter equals blue sclerae, choroidal veins show through the thin, translucent sclera, progressive hearing loss due to deformation, fracture, and/or atrophy of the ossicles brittle, opalescent teeth, dentinogenesis imperfecta, due to a lack of dentin, equals ligamentous laxity and joint hypermobility. Copyright osteogenesis imperfecta type 2 equals most severe form, usually fatal within the first year of life. Equals multiple intrauterine and/or perinatal fractures. Equals MICR amelia, hypoplastic thorax. Equals underdeveloped lungs leading to respiratory problems. Equals other findings, micronathia, large fontanelle, hypotonia. Scent diagnostics. DNA test. Copyright ultrasound before birth and radiographic skeletal survey afterward, to visualize fractures, calluses, deformities. Bone or skin biopsy to examine collagen. Scent therapy. No definitive treatment available. Supportive measures, walking aids, wheelchairs. Devices to improve patients' mobility and function. Bisphosphonates, increase cortical thickness and decrease the risk of fractures. Surgery, to improve mobility and correct the associated skeletal defects. And individuals with osteogenesis imperfecta can't bite, bones, recurrent fractures, eye equals blue sclerae, teeth, dental abnormalities, ears, hearing loss. Copyright bone fractures from osteogenesis imperfecta are easily mistaken for signs of child maltreatment. WA. CE. Osteopetrosis, marble bone disease. Scent definition, an inherited, diffuse bone disease that results in sclerotic thickening of the skeleton on radiological examination. Scent epidemiology. Copyright type osteopetrosis, 2 to 5 per 1 million live births. Copyright type IL osteopetrosis, 2 to 10 per 1 million live births. Etiology. Copyright type osteopetrosis, malignant osteopetrosis. Autosomal recessive disease. Equals age of onset, infancy. Equals clinical course, severe. Copyright type IL osteopetrosis, benign osteopetrosis, Albers-Schunberg disease. Autosomal dominant disease. Equals age of onset, early adulthood. Equals clinical course, mild or rare cause, carbonic anhydrase 2 deficiency. Equals autosomal recessive condition associated with inability of osteoclasts to generate an acidic environment for bone resorption. Equals leads to renal tubular acidosis, osteopetrosis of intermediate severity, and cerebral calcification resulting in intellectual disability. Pathophysiology, gene mutations. Inability of osteoclasts to generate acidic environment in the bone matrix. Bone resorption with preserved osteoblastic function. Overgrowth of bone with pathological bone composition. Scent clinical features. Copyright recurring pathological fractures, osteopetrotic bone tissue is very dense but brittle. Copyright cranial nerve disorders, example palsies, due to hyperostosis and stenosis of the cranial nerve. Foramina. Pancytopenia due to reduced marrow space. Back collapse. Fine text outline. Clinical features. Recurring pathological fractures, osteopetrotic bone tissue is very dense but brittle. Cranial nerve disorders, example palsies, due to hyperostosis and stenosis of the cranial nerve. Foramina. Pancytopenia due to reduced marrow space. Hepatosplenomegaly due to extramedullary hematopoiesis. Scent diagnostics. X-ray, symmetrical, homogeneous, sclerotic thickening of both cortical and trabecular bone, stone bone. Laboratory findings, see laboratory evaluation of bone disease. Equals calcium levels may be normal or low, especially in severe form, example type osteopetrosis. Equals 1 CKBB1 tartrate resistant acid phosphatase, TRAP, scent therapy. Bone marrow transplant, potentially curative treatment. Functional osteoclasts may develop from unimpaired monocytes deriving from transplanted stem cells. Copyright surgical decompression is required in the case of optic and/or auditory nerve compression. References. WA. CE. Campomelic dysplasia. Scent definition, a potentially lethal disorder characterized by skeletal dysplasia, abnormal sex development, and other congenital defects due to SOX9 gene mutations. 9-10 cent etiology OE SOX9 gene mutations on chromosome 17 EO autosomal dominant inheritance O results from missense mutations, frameshift mutations, or chromosomal rearrangements. Cent clinical features copyright skeletal abnormalities bowing of long bones, particularly the legs, short legs dislocated hips club feet. Underdeveloped shoulder blades short stature characteristic facial features, example small chin, prominent eyes, flat face, large head, Pierre-Robin sequence, cleft palate, glossoptosis, micrognathia, O abnormalities of the reproductive system equals in most affected individuals with 46XY karyotype, the external genitalia will either be ambiguous or female. Equals internal reproductive organs may not correspond with the external genitalia and individuals can have testes, ovaries, or both. O other defects. Equals life-threatening laryngotracheomalacia equals respiratory distress syndrome equals hearing loss. Cent diagnosis copyright clinical and radiographic findings copyright genetic testing. Cent treatment O airway protection copyright surgical repair of congenital anomalies. Back collapse fine text outline. Uroskeletal dysplasias, 3/3. Epidemiology most common skeletal dysplasia incidence, 1:15,000, 40,000 children affected in the U.S. Etiology defective endochondral ossification and growth disorders of the long bones due to mutation of the fibroblast growth factor receptor 3 gene, FGFR3, autosomal dominant inheritance, approximate 80% spontaneous mutations. Complications increased risk of cardiovascular disease obesity is common. Life expectancy normal. Achondroplasia fact sheet. Copyright Boss. Wheeze. Prominent brow. Midfacial hypoplasia. Flattened nasal bridge. Long, narrow trunk. Short extremities _rhizomelia. Achondroplasia AE equals macrocephaly with _G increased occurrence for of otitis media equals WA. 70, narrow foramen magnum at with compression of yen spinal cord. /psi ____ increased risk of D/cardiovascular disease. _ plus _scoliosis, spinal stenosis. Trident hands. Overlay. Achondroplasia VV. X-ray thoracic and lumbar spine, lateral view, there is accentuation of thoracic kyphosis and lumbar lordosis, green line. Vertebral body heights are reduced, examples indicated by red outlines, and intervertebral disc spaces are widened, examples indicated by arrows. Several vertebrae show anterior wedging, example indicated by black arrowhead, and posterior scalloping, example indicated by white arrowhead. Source, copyright IMPP. Skeletal dysplasias, 2/3. Copyright overlay. Achondroplasia VV X-ray thoracic and lumbar spine, lateral view, there is accentuation of thoracic kyphosis and lumbar lordosis, green line. Vertebral body heights are reduced, examples indicated by red outlines, and intervertebral disc spaces are widened, examples indicated by arrows. Several vertebrae show anterior wedging, example indicated by black arrowhead, and posterior scalloping, example indicated by white arrowhead. Source, copyright IMPP. Achondroplasia. Short stature and prominent lumbar lordosis can be seen in this 11-year-old patient. This is the characteristic appearance of achondroplasia. Source, copyright IMPP. Uroskeletal dysplasias, 3/3. Osteogenesis imperfecta short stature. Triangular facial appearance epidemiology prevalent CE, approximate 1/10,000-20,000 deafness E /. Classification 11 types with highly variable genotypes and phenotypes. Etiology disorder of collagen type synthesis, inheritance can be scoliosis, autosomal dominant, most common, equals dentinogenesis but also autosomal recessive, rare, equals, imperfecta. Life expectancy SY mild forms, typically normal very severe form, type 2 typically lethal within the first year of life. Frequent fractures, bone deformations. As tendon instability. Osteogenesis imperfecta, brittle bone disease, fact sheet VV. Copyright Boss. Scleral manifestations of osteogenesis imperfecta VV. The sclerae show a distinct blue-gray tint. Source, picture 2 in, these three teenaged girls had the same disease by Herbert Alfred MD and Hendrik A. van Dijk, OpenStax, licensed. Under CC by SA 3.0. Overlay. Skeletal deformities in osteogenesis imperfecta VV. Left, X-ray whole body, AP view, right, X-ray right arm, AP view, of a 3-year-old boy. Osteoporosis is accompanied by severe deformities of the appendicular, examples indicated by green overlay, and axial skeleton, examples indicated by red overlay on left image. Multiple old fractures, red arrows, are associated with callus formation and sclerosis. There is severe limb bowing and foreshortening. The findings are consistent with osteogenesis imperfecta. H. Humerus, R. Radius, U. Ulna source, figure 2, A, and B, in, hereditary connective tissue diseases in young adult stroke, a comprehensive synthesis by Olivier M. Vanacker, Dimitri Hemelsowit, and APP, Stroke Research and Treatment, licensed under CC by SA 3.0. Modifications, blue tint removed. Copyright. Overlay. Skeletal deformities in osteogenesis imperfecta VV. Left, X-ray whole body, AP view, right, X-ray right arm, AP view, of a 3-year-old boy. Osteoporosis is accompanied by severe deformities of the appendicular, examples indicated by green overlay, and axial skeleton, examples indicated by red overlay on left image. Multiple old fractures, red arrows, are associated with callus formation and sclerosis. There is severe limb bowing and foreshortening. The findings are consistent with osteogenesis imperfecta. H. Humerus, R. Radius, U. Ulna source, figure 2, A, and B, in, hereditary connective tissue diseases in young adult stroke, a comprehensive synthesis by Olivier M. Vanacker, Dimitri Hemelsowit, and APP, Stroke Research and Treatment, licensed under CC by SA 3.0. Modifications, blue tint removed. Osteopetrosis. Anteroposterior X-ray of the hand of an 8-year-old girl, pronounced metaphyseal densities in line with increased sclerotization of the bones of the fingers. Source, copyright IMPP. Overlay. Osteopetrosis VV. X-ray of the thoracic and lumbar spine, AP and lateral view, broad, linear sclerotic lesions of the inferior and superior end plates, box 1, highlighted with green overlay in box 3. Normal findings are shown in boxes 2 and 4. This finding is sometimes referred to as sandwich vertebral body. Diagnosis, autosomal dominant osteopetrosis. Source, copyright IMPP. Overlay. Osteopetrosis VV. X-ray of the thoracic and lumbar spine, AP and lateral view, broad, linear sclerotic lesions of the inferior and superior end plates, box 1, highlighted with green overlay in box 3. Normal findings are shown in boxes 2 and 4. This finding is sometimes referred to as sandwich vertebral body. Diagnosis, autosomal dominant osteopetrosis. Source, copyright IMPP. Osteopetrosis VV. X-ray pelvis, AP view, marked sclerosis involves the pelvic bones and visible portions of the lumbar spine and proximal femurs. A bone-within-bone appearance is produced, best appreciated in the iliac wings. Source, figure 9 in, clinical and radiological findings of autosomal dominant osteopetrosis type 2, A case report by Priyanka Kant, Neelkamal Sharda, Rahul Arbhawit, Case Reports in Dentistry Journal, licensed under CC by 3.0. Overlay. Campomelic dysplasia VV. X-ray fetus, AP view, multiple skeletal abnormalities are consistent with a diagnosis campomelic dysplasia. Distinguishing characteristics include absence of ossification of thoracic pedicles 11 rib pairs, hypoplastic scapulae, white arrows, and fibulae, red overlay, narrow iliac wings, green overlay, dislocated elbows, and normal bone density. Characteristic long bone angulation at the junction of the proximal third and distal 2/3 of the femur, green arrowheads, and at the proximal 2/3 and distal third of the tibia, red arrowheads, helps distinguish campomelic dysplasia from hypophosphatasia. Source: Fig 17a, in Differential Diagnosis of Perinatal Hypophosphatasia, Radiologic Perspectives by Offia A.C., Fakali J., Mun C.F., Muratsuki J., Springer Link, licensed under CC by 4.0. Modifications: image cropped and removal of the letter A in the upper left corner. Copyright. Overlay. Campomelic dysplasia VV. X-ray fetus, AP view, multiple skeletal abnormalities are consistent with a diagnosis campomelic dysplasia. Distinguishing characteristics include absence of ossification of thoracic pedicles 11 rib pairs, hypoplastic scapulae, white arrows, and fibulae, red overlay, narrow iliac wings, green overlay, dislocated elbows, and normal bone density. Characteristic long bone angulation at the junction of the proximal third and distal 2/3 of the femur, green arrowheads, and at the proximal 2/3 and distal third of the tibia, red arrowheads, helps distinguish campomelic dysplasia from hypophosphatasia. Source: Fig 7.